Are we ready to go? Good morning, everyone. I'm so pleased to have everyone here, and I wanted to be able to introduce our weekend seminar from the National Medical Association. I'm Marie Borum. I am the chair of the Internal Medicine Section for the National Medical Association. And on behalf of the Internal Medicine Section and the NMA, I'm pleased to welcome you to a weekend seminar offering updates on COVID and the impact in the Black community. This special seminar will feature experts in a variety of specialties discussing COVID in their field and providing information about COVID-19 vaccine. During the panel discussions following specialty presentations, please feel free to share your experiences and ask questions of the experts. Today, we will have presentations in gastroenterology, podiatry, obstetrics and gynecology, community medicine, HIV, and cardiology. Tomorrow, on Sunday, we will have expert presentations in pulmonology, rheumatology, oncology, allergy and immunology, and infectious diseases. I'm so appreciative of those in our virtual audience and speakers who have chosen to spend their Saturday and Sunday with us to talk so we can all learn about COVID updates and how to continue to care for ourselves, our patients, and our communities. Please feel free to put questions in our chat because each subspecialty will address those during their panel discussions and in our live Q&A. We'll start today by talking about gastroenterology. So I'd like to put up our agenda here. We'll talk about the impact upon COVID in African-American and vulnerable communities and strategies for improving outcomes. This will feature Dr. Jihan El-Bayoumi. We'll talk about COVID and the gastrointestinal tract. I'll do some speaking about some of the issues related to the GI tract during the pandemic. We'll also happen to talk about COVID and the inflammatory bowel disease by Dr. Bhattacharya, because this is among our most vulnerable of patients in the GI cohort. And then we're looking forward to having a panel discussion with questions and answers. And we would love for you to be able to ask questions so we can talk about our experience and you can talk about yours. So I'd like to begin by introducing our speakers. Dr. El-Bayoumi, who I'm so pleased to have here this morning, is a nationally known physician who's based in Washington, D.C., who has been involved in efforts to address COVID, vaccine hesitancy, and improving outcomes in the Black community since the very beginning of the pandemic. She's an adjunct professor at Georgetown University. She's the founding director of the Rodham Institute, which is focused on increasing underrepresented minorities in healthcare professions. And the Institute partners with community-based organizations to improve healthcare outcomes of the underserved. She's a consultant and frequent speaker for BlackDoctors.org. And if that's not enough, she is a co-founder and board member of the Black Coalition Against COVID. This morning, she will offer important information and perspectives about the impact of COVID in the Black community and what efforts have been made and those which continue to need to be made to improve healthcare outcomes. She will address her experience in patient care, improving clinical outcomes in the community, addressing vaccine hesitancy, and the successes that have occurred in Washington, D.C. and in different communities nationally. After Dr. El-Bayoumi, I hope to be able to talk and I will share some information about gastrointestinal diseases and during the COVID pandemic. I'm the director of gastroenterology and liver diseases at George Washington University. I went to Princeton, I went to Rutgers Medical School, and for the purposes of, and what's so important about some of my community work, I have a master's in public health and a doctorate in education. I've been involved with community outreach programs, sharing many of those efforts with Dr. El-Bayoumi, multiple research projects, and have developed a number of educational programs, which have been focused in Washington and nationally. I've been able to share some of this work and my research in books and in abstracts and in book chapters. And I'm hoping to have a robust discussion about COVID with Dr. El-Bayoumi and Dr. Bhattacharya, who I would like to introduce now. Dr. Bhattacharya is an assistant professor of medicine in the Division of Gastroenterology and Liver Diseases at George Washington. She graduated from Cornell University, then went to Thomas Jefferson University Medical College. She completed her internal medicine residency at Rutgers and her gastroenterology fellowship at University of Maryland and NIH. She also did her inflammatory bowel disease specialty training at NYU. She has multiple publications and presentations, and based upon her expertise, she was a high priority faculty recruit at GW and is establishing our inflammatory bowel disease program at the university. She will review important information about COVID and inflammatory bowel disease because individuals with inflammatory bowel disease are among our most vulnerable patient populations in gastroenterology because of their intrinsic immune dysregulation and often because of their medication regimens. So without ado, I'd like to start our presentations with Dr. El-Bayoumi. Thank you so much for being here.
Good morning, everybody, and thank you, Dr. Borum, for that over-the-top introduction. I'm like, did my parents pay you for that? I'm not sure. It seems strange to me to not include in my title that I'm a professor at George Washington University School of Medicine and Health Sciences, which I just left after several decades, and actually will be joining the Georgetown faculty, that other George across town. Well, I didn't have any slides prepared today because I think that it's important to have a discussion about, health outcomes in the COVID, relating to the COVID pandemic in the African American community. But there's no new news here. I say everything old is new again. The same reasons that contribute to poorer outcomes during, non-COVID times for a variety of health conditions were simply amplified and made public. And it was for some, especially sort of in mainstream medicine, mainstream media, it was a shock and surprise. For others, it was not. So, what is it that has happened, or what are some of the statistics? So being based in Washington, D.C., I want to share just some numbers to give you an idea of why I decided to start the Rodham Institute, because they are shocking. So our history is that Washington, D.C. was Chocolate City. When I first came to Washington, D.C., after graduating from medical school in Ann Arbor to do my residency. And at that time, the population was about 86% African American. That number has dwindled down to 46%. Washington, D.C. has a total of 8 wards, and the span of the city is 10 miles. So in the richest ward, the life expectancy is 94 years. That's average. In the poorest ward, it's 66.5 years. Now, the average in terms of urban areas, in terms of that gap, is between, let's say, it's about 15 years. For the capital of arguably the most powerful country in the world to have a 26.5 year gap in life expectancy is shameful. And this is just a stone's throw away from Congress to see some of these outcomes. And remember, averages don't tell the whole story. In our poorest ward, the rate of HIV is the same as Namibia. The rates of infant mortality are the same as Cambodia and El Salvador. So it is no wonder that Washington, D.C. is #1 per capita in cancer mortality, in HIV and end-stage kidney disease in the United States of America. Now, that's a whole other conversation about sort of why that is, and sort of the history of Chocolate City. And I would really recommend for people who are interested to read the book Chocolate City, because it really outlines how DC was established, why we are considered a territory. So we only got 2/3 of the COVID stimulus package under the previous administration, but fortunately the Biden-Harris administration released the rest of the funding when they took over. And our budget is overseen by Congress. So that's sort of just as a background. So I'd like to start off with the questions, and forgive me for not having the questions on the screen. The first question: what were some of the strategies used to educate and engage African-American communities in COVID testing and vaccination? You have several options: implement national programs, increase funding to such initiatives, engage community leaders, organizations, engage community-based organizations, use social media to reach communities, or A, all of the above. The second question is, what are the major factors that contributed to poorer health outcomes in African Americans during the COVID pandemic? 3 options: access to healthcare, quality of healthcare, education, and food. So we know that some of the major contributors to poor outcomes have to do with the social determinants of health. Only 20% of health outcomes and life expectancy are related to access to healthcare. One of the most important social determinants of health is education. And just to give you some sense, in DC, again, the poorest ward, Ward 8, only has a 42% high school graduation rate. If all we did was got these young people to graduate from high school, we would add 10 years to their life expectancy. Why is food so important? Well, it turns out that food is the #1 social determinant of mental health. And of course, we know that mental health has really impacted everybody, but particularly communities, underserved communities, but what I also call the minorities within the minorities. We know that trans kids of color have their suicide rates have just gone through the roof. We know that youth, African-American youth, are seeing rates very high increase compared to their white counterparts in self-harm and in suicide. And of course, there are the elderly and the disabled. When we first started COVID, RODM, we actually did an environmental scan to see what the health priorities were for wards 7 and 8. Those are the high need wards. And mental health, this was 10 years ago, was #1. And I think it's important to recognize that, because I think sometimes not this illustrious audience, but sometimes there is an overemphasis on physical health, and that's certainly important. But the entryway to mental health, to physical health, is really mental health. One of the things that I think really kind of popped in terms of COVID, and I just want to give some credit to Dr. Anthony Fauci, because Dr. Fauci has been talking about disparities for a long time. This was not anything new. And just want to give him a shout out. He has a history of working with community-based organizations that dates back to the AIDS epidemic. So for all the criticism that he's received, I think that he really deserves our respect and thanks. So what are sort of some of those issues that were really sort of amplified? Well, the workforce. We know who runs this society, what keeps America going. And it was those people on the front lines, which, yes, included medical personnel, of course. But we forgot about the bus drivers. We forgot about the people who are cashiers, the people serving food, all of these essential services that make our country and our hospitals and healthcare systems run. People were forced to take public transportation, which of course then resulted in higher exposures. And sadly and shamefully, many people who fell in those categories did not have PPE. They were not offered it. They were not seen as a priority. And of course, for economic reasons, really, especially at the beginning of the pandemic and the shortages for PPE in general, they did not have access. This actually is illustrated in that 1 in 3 of the direct service health workforce, meaning the home health aides, the certified nursing assistants, the medical assistants, et cetera, dropped out of the workforce. The other aspect that really, I think, again, amplified is this notion of competing priorities. Do you know that there is no direct bus service from Ward 8 to Northwest, where all of the hospitals are concentrated in Washington, D.C.? Do you know that it takes 3 bus rides and 45 minutes, depending on if there is a breakdown in the bus or not? Many people cannot afford living in Washington, D.C. So we see people that live in the outlying areas. And with gentrification, people are really being pushed out into Maryland in particular. So some of the people that we work alongside with are coming and commuting an hour and a half in each direction. And just to show you what institutionalized racism looks like, when we have people of color, and in Washington and at my former institution, African-American women, it was really the white counterparts that were allowed to telecommute. There was one egregious situation where one of the medical assistants was made to work in the COVID testing tent, who had asthma and lived in a multi-generational household. Her parents, her mother and her grandmother, 95 and 75, were living with her. So it was not just her and her health, but also her family's health. And she was not given the option, although we rectified that, to work in a highly intense COVID exposure tent. So when we look at these factors, competing priorities, right? And all of a sudden, all of the education shifted to online. So given the digital divide, the lack of adequate computers in households, you had families, and by the way, 1/3 of people in Washington, D.C. are functionally illiterate. So you're asking people to teach their kids, and they may have 4 kids in a household, and if they have 1 computer, the kids have to share it. So what did kids do during COVID? They actually went to the hotspots outside of their schools. Now, that's not awful during warmer weather, but imagine these children going outside in freezing cold weather just to complete their assignments. So talk about exposure and vulnerability. The other aspect is that food programs, which are essential to feed kids through public schools, that all disappeared. So for some children in Title I schools in particular, they were getting breakfast and lunch. All of that disappeared. So nutrition, education, certainly crowded households. And then, of course, we know that there was an epidemic among everybody of mental health issues, as well as substance use, domestic violence, as well as elder abuse. And this is, of course, goes across all socioeconomic groups. It's just different that richer communities have access to mental health services. And just to give you an idea, I don't know what it's like in other communities, but there were no mental health services available. I had, even my rich patients who would pay cash, had 2 to 3 month wait. So if access to healthcare was the reason for poorer outcomes or good outcomes, said differently, Washington, D.C. would be second only to Massachusetts, because we have the second highest rate of insurance coverage. I think it's 97% as opposed to Massachusetts, which is 98%. Certainly, quality of care is very important. So one of the factors that contributes to poor outcomes in cancer mortality is that for our Medicaid population, there are 150 oncologists that are listed as taking Medicaid, but when you go to make appointments, only 3 in the entire city oncologists for every cancer are available. So is it no wonder? Certainly, access to vaccines was a huge issue. We had, probably like many other cities, you had to log on to the computers and sign on to the database, which kept crashing. Again, I told you about the digital divide and, all of that. I'd like to move then into solutions. And these solutions are certainly not unique to our experience, and they're not necessarily new. I think for those of us that already had established relationships with the community, and Rodham, we have 160 community partners, it was just easier to kind of implement these solutions as opposed to other people that were kind of going into that space. So Dr. Reed Tuckson, a former president of Charles Drew University, the former health commissioner during the AIDS epidemic here in Washington, D.C., a member of the Academy of Medicine, I could go on about his qualifications, really had the brainchild, the Black Coalition Against COVID, which, by the way, we're changing our name to the Black Coalition for Health. He was the one that said, look, we've got to do something. And a core group of us became the co-founders. I really would invite you to go to blackcoalitionagainstcovid.org, because it is a national organization bringing together all of the historically African-American medical schools, bringing various industries, including education, labor, the arts communities, not to mention all healthcare leadership communities, whether it's nursing or pharmacy or physicians, and also representatives from the returning citizens community. So what did we do? Well, the first thing when you're doing any community work is to recognize that it is the community that leads. As you know, there is a long history and ongoing abuses by the academic medical communities of African Americans specifically, but underserved communities in general. It's just that African Americans, only second to indigenous peoples, have sort of one of the longest histories, but certainly brutal. And it is the community that leads, because guess what? If we had all the answers, these issues would be non-issues. And so we keep doing worse and worse. So the community knows who they are, who are the shut-ins, who people that can read, who's got mental health challenges. So one of the first things that we had to do was to begin to educate people. As we know that there were a lot of myths that were circulating. And that is understandable given the historic abuses, as I mentioned. Many people were quoting the Tuskegee experiment. And of course, we partnered with the descendants of the Tuskegee experiment, who were huge advocates for vaccinations. And we used this opportunity to tell people that no, people were not injected with syphilis. They were prevented from having treatment, and the history which led to the history of IRBs and protections. We highlighted the fact that many African-American leaders and scientists were leads in terms of the development of the vaccines and the research. That was successful to a point. We started to see that certainly older people, seniors, were becoming educated, and the uptake of vaccines was actually pretty high and comparable to their white counterparts. But as time went on, it was really the young people that were quite reluctant. So the strategies of education, which were town halls and the Black Coalition Against COVID, I think we reached, I don't know, maybe 40 or 50 million different people across the country. I forgot to mention the faith-based community, because they are just, are an integral part of the African-American community. So we had to shift and really begin to prioritize those highest risk groups. So we engaged, first of all, we said, well, what would work? And they said social media. And by the way, for anybody, Facebook is no longer it. There's Snapchat and Instagram and TikTok and other ones that will be, these will be outdated, in who knows, you got to keep the trends. And it was the young people that were really sort of guiding us to say that these are effective, the artistic community and so forth. So on the website for the Black Coalition Against COVID.org, you will see that we brought all the examples and the exemplars from all over the country of effective strategies for education as well as vaccination in that. And I would really recommend that you look at that, because there was a lot of outstanding work. People really, really stepped up. And of course, the NMA was an integral part of that. And we were lucky that we had an African-American leader at the AMA who amplified these issues. But I'd like to talk to you about our work at the Rodham Institute and what we did. Cora Berry, the former, Cora Masters Berry, the former First Lady of Washington, D.C., who's a friend and a patient, called me up and she said, Gigi, I'd like to have a one-day mass vaccination event in Ward 8. And I said, yes, ma'am. And she said, I'd like it to be with the Johnson & Johnson vaccine. I said, but Ms. Berry, it's not officially been approved. It's going to be approved, or, we can use it in 4 weeks. She goes, well, that will give you enough time to organize it. I said, okay. So she, by the way, as an aside, if you want to learn about her, she's just an incredible leader. She established the Southeast Tennyson Learning Center, which I will encourage you to learn more about that. So the first thing that we did is in Washington, D.C., there are family success centers. And one of the biggest leaders and who has been around for quite a while is and I always get their name mixed up, is the Greater Far Southeast Family Collaborative. So we went with them and we said, okay, let's start off by doing town halls to the people that work there. We did 9 90-minute town halls. And what was important is that the people that work in that center, some of them were vaccine hesitant themselves. And it was very important to start off with them, because guess what? They were the ones that were then signing people up to get vaccinated, but also answering their questions. That was really, really key. They know their community best. They have relationships with the community. So even though, we, Rodham Institute, have been working in the community, they are trusted agents. And that's the key. Our intentions are good, but we have to have trusted agents. And if we're going to do good work, really the relationships should be developing prior to a crisis, because we are always in crisis, sadly. So what was important in the event was to bring all of the institutions together. Children's Hospital had already had a number of mass vaccination events. So we reached out to them and asked them, please share lessons that you've learned with us and help us. You have experience. We brought Howard University, Georgetown University, as well as GW. And what was so cool about this event, everybody had a leadership position. It was the Howard University pharmacy department that actually would mix the vaccine and prepare it. We had dental students, we had nursing students, we had PA students, and of course, medical students. But initially, and additionally, it was important that we realized with a mass vaccination event that this was an opportunity for other types of education, and mental health was very important. So we had our mental health colleagues also there to share resources, especially, you have to sit there for 15 minutes after you get vaccinated. So we were showing videos as well. Food was essential. We partnered with the Capital Area Food Bank, and there were actually food boxes that were available, but also we arranged for there to be once a week drop-offs in areas that were of high need. So it wasn't just a one and done. We were really about establishing relationships. Believe it or not, something that was a big draw, which really surprised me, was free blood pressure cuffs. People who would come to the event would call other people to say, oh, they're free blood pressure cuffs. We had condoms available. There was really a lot, and health literacy tutorials. But I think the most important thing that was really key was that Ms. Berry hired a go-go DJ. And for those of you that don't know about go-go music, that is the official music in Washington, D.C. We had free childcare. We also had free Uber rides for people. And because we used the model of the community-based organization as the leader, they basically would say, let's meet to get vaccinated. I'll get vaccinated with you. On that one day, we vaccinated 900 people from Ward 8. But then if you recall, Johnson & Johnson, there was an issue. It's like, oh no. So we called our partner and we said, do we need to have a town hall? And they said, no, we're good. We're good, because the people that got vaccinated knew that we were there with them, and they just would call and ask us questions. And we were the ones that were reassuring. So, I know that probably I'm done with my time, Dr. Borum. We're very close to it.
Oh, no, you're fine, because
Okay.
I really wanted you to be able to, I want you to be able to share
Sure.
the strategies and the multi-pronged approach
Sure.
to making sure we can improve healthcare
Sure.
outcomes
Sure.
and
Will do.
address vaccine hesitancy.
Of course. So that is sort of our experience. And what was important is that, we were lucky at the Rodham Institute in that there was a businessman. This was right before Delta, right before it. And he had all of this excess inventory. So a colleague, he had reached out to a colleague and said, look, I've got all this excess inventory. I want to be able to sell it. And the colleague said, don't sell it. I know exactly who you can contribute it to. So we had 560,000 masks and hand sanitizers that we used. We basically took it to 10 of our core larger community partners, and then people could come from various groups. That was huge. I mean, I think, the importance of community engagement is that you're there through thick and thin. You're there, the one and done, as we know, is just, it's not going to work. And so people would call us and say, this is what we need. And because, sort of us, meaning those of us that do community work, may have access to different resources. What we can bring is we can leverage resources and connections. We don't tell people what the priorities are, but we are at their service.
Has this model been able to be used as a foundation and other areas that the Black Coalition has worked in across the nation for COVID specifically? And I imagine this model can then be used in other health issues. But I'm curious about your personal experience with managing people clinically, and also how you're able to extrapolate that experience to make successes in the community.
Yeah, thank you, Dr. Borum. So first of all, as I sort of mentioned, there are lots of models out there, and the whole idea of having the exemplars and that publication that's available for free at the Black Coalition Against COVID.org is to share experiences so that people can choose the model that really is tailored for them. An idea of one size fits all, and you just sort of take things off the shelf and say implement, that's not going to work, as we well know. I mean, you know, when we are sitting with a patient one-on-one in the exam room, and we are talking about the importance of adopting a strategy, we're not going to use the same language even. We may know that there are many more barriers, and so the kind of discussions really have to be focused on the needs. You know, the late Dr. Paul Farmer, the MD, PhD, talked about, and he had a PhD in medical anthropology, talked about the importance of taking a mini ethnography on the patient that you see. And one of the barriers for us as clinicians, we think that this is going to take a lot of time. It doesn't. Actually, it is time saving, because it's when we are being judged as physicians on quality of care, outcomes, and so forth, to have that conversation with somebody, to ask them, what do you do for a living? Who do you live with? You know, sort of, are there any barriers to your care? How's your job going? You know, employment, all of that. And really that comes from trust. And we know that outcomes improve when African-American physicians, that's why our focus at the Rodham Institute, one of our priority areas is workforce. And that's why it was important in the Black Coalition Against COVID. I mean, it was, I don't want to say exclusively African-American, but the experts were African-American. And I think that really, really made a difference. We also were able to engage people like Dr. Fauci, people from the White House, so that it wasn't a second kind of stepchild type of phenomenon. No, people had access to the very best of information. We use this opportunity to actually educate people about science. People say, well, one second you say this and another second that you say that. You keep changing your mind. So the analogy that certainly I use, which I think is so important, well, when there is a hurricane that might hit, or a tornado, we don't expect the weather person to say, well, it's going to hit this neighborhood. No, we say it's a forecast. Stay tuned for updates, as this is a developing story. And I think that having those kinds of analogies and being able to communicate in ways that everybody and anybody can understand helps to really reduce that mistrust. And to say, I don't know, when we don't know. I think one very powerful thing was that in, I want to say, Thanksgiving of 2020, the Black Coalition Against COVID sent a love letter to the African-American community, and it was a videotape as well as a written one. I would urge you to look at that, because I think it's very powerful. Different people, different backgrounds, health professionals, all really spoke about why they got vaccinated and why or I think the vaccine may not have been available yet. I lose track, COVID time. But why their children are getting vaccinated, why the elderly are getting vaccinated. So I think it was very important and crucial to also share those personal experiences, And one of the things that I would always discuss when I was on any kind of public panel is, look, I never advise people to do things that I wouldn't do myself or I wouldn't have my family. And that kind of discussion, if you want to say rapport building, you want to say credibility, I think is very important. Well, would you take it, doctor? I said, I already did. That's how much I believe in it. So just having those real conversations, which again, don't take a lot of time, but do require interest and understanding. One of the myths, as I mentioned, was I'm going to be a guinea pig. And so we would use other analogies. So I said, you eat and drink food and you don't do research on the food that you're drinking. There are lots of chemicals and carcinogens in the food. So if we're going to talk about issues and problems, then let's talk about that. But you're using such a different standard for the vaccine, which I understand. I mean, I'm not minimizing that. And I think that's another thing, is to address people's concerns, directly, and not say, well, just take my word for it, just get it done, right? And using that authoritarian voice, but rather that this is a conversation and a discussion. Being a general internist, I know that it may take a while for people to come to a decision. And so my particular expectations are such where I will, say, well, I want you to think about it. And I want you to consider getting, the vaccine. And I have to tell you, not everybody, but a certain percentage do change their minds. I thought about it and you're right. And then, of course, I use guilt. Who's in your household? Who do you love? Your grandparent, your children, a significant other. And that certainly works for smoking cessation. So to your point, Dr. Borum, this is the specific disease and crisis that we were addressing was the COVID pandemic. But in reality, you use this strategy for colon cancer screening, right? And education. We use this for hypertension, diabetes, all of these things. I think the difference in terms of the COVID pandemic was how we were all able to come together. One of the most powerful events that we had was at Temple Praise Baptist Church. This is a church that has 10,000 congregants. And Bishop Staples oversees a fellowship of churches with 60,000 congregants. There, the pastors were there. We brought together a group of African-American physicians and nurses to have a town hall, and people were vaccinated at the pulpit. And let me tell you, that was extremely powerful. People basically said, well, our spiritual father is doing this, or our spiritual mother is doing this, then we should do it too. So again, it is about knowing, Bishop Staples has a lot more weight than I do, right? As a physician. He's an advantage really, because it's the spiritual. And of course, another really important group that I want to make sure that I give a shout out to is Choose Healthy Life. This was started by the Reverend Al Sharpton and Ms. Deborah Fraser House from New York. And it's a 6-city initiative, which the church is really it's a faith-based group. And this faith-based group, and I'll stop because I know that you have a question or a comment, this faith-based group was really key in increasing the trust and dispelling myths.
Yeah, I think that the partnership is so important with the communities. And I think we'd like to again circle back to that when we get to our panel discussion. One of the challenges that we have had is recognizing that there are multiple ways that people can present with COVID and multiple disease entities that can be affected. And so as an internist, having to face all of those potential presentations is a challenge to you, to us, to the community to understand exactly what COVID did and does. And so one of the things that I wanted to move on to just now is to talk about gastrointestinal issues.
Can I just make one comment, Dr. Borum? Because I did not talk about, and I just want to briefly touch upon this. Institutional racism was blatant and rampant during this time. There were many patients, people that I hadn't even met, that we had to transfer from other hospitals who were basically told, you know, you're going to die. Because there isn't that, let's just say, I don't mean to be global, in those particular cases, there was not that care. As an internist, I will tell you, what happened is that anchoring bias of everything is COVID. Everything is COVID. And so PEs, especially pulmonary embolisms, were overlooked. Other diseases were overlooked. And the challenge as an internist is that, of course, COVID, you know, in the immediate was important to focus on, but you and I both know that things like colon cancer screening, mammography, and so forth were delayed, which is really what we're dealing with now. Thanks.
Yeah, so I want you to stay on for the panel and for questions. And I'd like to begin to talk about the gastrointestinal manifestations, which were one of the manifestations or the type of manifestations that often got overlooked. So I'd like to be able to transition to that discussion. So let's talk about gastrointestinal diseases and issues related to COVID. I just have to disclose that I am a consultant with Takeda, although it is not pertinent to our present talk. When we talk about the early pandemic and we talk about what happened with the COVID, it was a circumstance in which we didn't know much. And what we did know is that we needed to know more. And so in the end of 2019, the global coronavirus spread throughout the world and became this global pandemic that many of us were not prepared for. And it was, as we all know, designated as a severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. And the spectrum of disease from the respiratory standpoint ranged from asymptomatic infection to mild respiratory diseases to severe respiratory distress. But our understanding of the spectrum of disease, as well as optimal management strategies, was not known. And what happened is that as we met these people with severe illnesses, we also met people who had things that we didn't know was related to the pandemic. So as gastroenterologists were introduced to the early pandemic, we were introduced a little bit differently. We, of course, were on the front lines to take care of acutely ill people coming into our offices and hospitals, but we didn't know the spectrum of disease in GI. And so I just wanted to share some of that this morning. And let me talk about how some of us were introduced to the early pandemic. And this happened in the Washington, D.C. area, and I want to talk about this case. And there was a 45-year-old man who came to his gastroenterologist's office with nausea and diarrhea. He had no associated symptoms. He had no fever. He had no chills. He had no dyspnea. He had no chest pain. He was examined. His labs were performed. Stool studies were obtained. And he was advised, like so many people with these particular symptoms, that he likely had viral gastroenteritis. 4 days later, the receptionist, the nurse, and the gastroenterologist were diagnosed with COVID, and the gastroenterologist was hospitalized in the ICU. Contact tracing found that the patient with diarrhea who came in that day was likely the source of infection. So indeed, he had a viral gastroenteritis, but it was actually COVID. And COVID resulted in the gastroenterologist being intubated in the ICU. The receptionist, the nurse, and the gastroenterologist all survived. They all are doing well. But in fact, their introduction to the early pandemic and gastrointestinal disease was something we did not know about. And so in fact, as we talk about GI diseases, the importance is that we recognize that there are GI manifestations that may come with or without other issues. There's both acute COVID manifestations, and it turns out there are long-haul GI manifestations. And in particular, as gastroenterologists, we want to be aware of those people who may be most at risk. So why do we know about GI or about GI issues in COVID? What is the importance of GI issues in COVID? Why does the GI tract get involved? And we believe it's because of the intestinal angiotensin converting enzyme 2, or the ACE2 receptors that are abundant in the GI tract. And ACE2 receptors are a receptor for SARS-CoV-2. So it turns out the GI tract can be involved and involved significantly. It's just that it's not as dramatic and it's not as life-threatening. And when you can't breathe, you're not worried about your diarrhea. But in the early pandemic, specimens were taken from patients who had GI symptoms and were documented to have COVID. And what they found that it was that these specimens showed the virus in different parts of the GI tract, including most often the stomach, the intestine, and in the rectum, very little in the esophagus. And so this patient was a 78-year-old man who was in the ICU after presenting with cough and fever. He was intubated, he was extremely ill, but while he was in the ICU, he had GI bleeding. He had an upper GI tract bleed. And of course, many of the issues were thought just to be related to the severity of his illness and being in the ICU, and that's why he's bleeding. But in fact, the evaluation showed not only did he have irritation in the lining of his stomach, erosions and ulcers, there was an abundance of virus in different aspects of his gastrointestinal symptoms. So while the ICU illness and the severity of his illness and his intubation contributed to his GI symptoms, like they do for so many people with non-COVID cases in the ICU, COVID also contributed to the bleeding that he had. So the symptoms in the GI tract are quite varied. They range from nausea and vomiting to abdominal pain to burping and bloating, and also diarrhea. Why this is important is because one can transmit the virus through oral fecal transmission, and we may not be aware of that. So in one of the largest studies, one of the largest early studies, they found that about 16% of people who presented had GI symptoms, mostly diarrhea, nausea, and vomiting, in the absence of respiratory complaints, So we want to make sure that as we continue to move through the COVID pandemic, as we continue to take care of our COVID patients, that we understand that there are GI manifestations that need to be looked at, need to be addressed, and need to be understood. So the most common symptoms are diarrhea, nausea, and anorexia. We also have other GI symptoms that I showed in the previous slide, but understand that that very often can present on its own or in the background of respiratory and cardiovascular complaints. Diarrhea for us is the most common digestive symptom. It can be mild or it could be severe. The prevalence has been difficult to determine, but as we have gotten to or later in the pandemic, we understand that COVID patients, up to 50% may actually have GI symptoms. The initial early study talked about 16% of people having GI symptoms without respiratory symptoms. But if you look at the whole cohort of patients who have COVID, up to 50% may have GI symptoms. The diarrhea typically lasts up 1 to 14 days, usually about 4 to 5 days, and the vast majority of patients have self-limited diarrhea. But COVID patients with diarrhea with only diarrhea, tend to present later because it's not likely to be recognized as a non-respiratory COVID complaint. There was a study that looked at 204 patients showing 51% had at least one GI symptom. There was another study of hospitalized COVID patients where up to 60% had at least one GI symptom. And we believe they occur because of direct cytopathic effects of the SARS virus, like we saw in that gentleman in the ICU where biopsies of his tissues showed the presence of the virus. And the virus, the direct cytopathic effects can be inflammatory, and they can also increase pro-inflammatory pathways. And we also understand there may be gut microbiome alterations. There are so many potential areas that the GI system can be affected to produce so many different symptoms. But there are also, importantly, some critical issues that can occur from GI manifestations. Critically ill patients can have significant GI complications, including bowel ischemia, including elevated liver transaminases that cause significant hepatic disorders, including rates of ileus, which complicate management of other concerns. So studies have attempted to determine if GI symptoms are associated with disease severity or whether they are not. And as you can imagine, there are disparate results. There was one meta-analysis of 35 studies that suggested people with GI disorders or GI symptoms can have more severe disease. There were other studies that showed there was no association with disease severity if you had GI disease. And there are limited studies that suggest that GI manifestations from COVID may actually result in a more favorable prognosis. So what we know is that we don't know. We don't know as much as we want to know. We don't know as much as we'd like to know. So we have so much more from the GI tract that we have to find out about when it comes to COVID. But again, when people are critically ill with respiratory symptoms, with cardiovascular symptoms, with PEs, diarrhea doesn't rise to the area of biggest concern, but diarrhea can in fact impact so much more and GI manifestations so much more in someone's outcome and well-being. We at GW looked at patients who are hospitalized. And one of the reasons we wanted to do a study from GW is that most of our hospitalized patients were African-American or Latinx. 87% of the hospitalized GW patients with COVID were from Black and Brown communities. And 59% of those hospitalized patients actually had at least one GI symptom. Sometimes they presented with it, sometimes they developed it when they were hospitalized, but it was an issue we had to deal with during their hospitalization. Patients had abdominal pain, nausea, vomiting, and diarrhea, and significantly, and also had significant symptoms in relation to, tendency toward mortality. There was a tendency for lower ICU care. There's a tendency for requiring hemodialysis. There's a tendency for mechanical ventilation. What we knew was that our patients had GI symptoms and it was related to their other manifestations. So acute COVID infections can occur with GI manifestations. COVID virus is detected in the stool and GI samples. The prevalence earlier can be up to a third, and approximately 60% of critically ill people have gastrointestinal complications. And the pathophysiology is multifactorial. But what have we learned as COVID has gone on? What we have learned is that there are also long-haul symptoms. The prevalence of long-haul COVID is unknown, but we know that 6.2% of individuals who had symptomatic infection have at least one long-haul COVID symptom. And they range from both physical and psychological issues. The most common physical symptoms are fatigue, dyspnea, cough, chest pain, but in fact, you also have GI issues. So in the mid-pandemic, we had a long-haul clinic. And in the long-haul clinic, this was one woman who came in who was illustrated what could happen and what was being seen in some of our long-haul patients. She came to us because she had nausea, decreased appetite, altered bowel movements, and weight loss. And while she was dealing with all of her other respiratory concerns, her non-productive cough, her decreased exercise tolerance, her dyspnea, her fatigue, her lightheadedness, and headaches, she was continuing to lose weight because of her GI symptoms. So while we know what happens acutely in our long-haul patients, we have to be aware that their GI manifestations can impact how they're doing. Persistent GI symptoms can occur in up to 7%. You can imagine what they are because they are just like the ones that occur in acute infections. And functional bowel disorders, people who've had that as baseline can get worse, and people can develop functional bowel disorders after they have had a COVID infection. So diarrhea initially can result in long-haul symptoms. It's related to the mucosal integrity and epithelial injury. But what the things that we want to know about is that these symptoms can be manifest and go on for months. They can go on for 6, 8 months. People I continue to see who have long-haul, mild GI symptoms, but may very often have been related to their COVID. So we have functional bowel disorders in general. We have functional bowel disorders occurring because of COVID. Maybe it's because of fecal microbiome. Maybe it's the intestinal dysbiosis that occurs from intestinal inflammatory permeability. Maybe it's any and all of that. But one of the things that gastroenterologists very often have to understand is that it occurs. We can have issues that stay long-term, but we really want to take care of and understand what happens to our most vulnerable patients. And those are people who may have inflammatory bowel disease. So as we all in this audience are taking care of our taking care of our patients in general with COVID, we understand that GI symptoms can occur. We really want to recognize what happens in our IBD population, because for us, this is most vulnerable. And Dr. Bhattacharya, I'm hoping that you could give us some insight about what happens to our most vulnerable population.
Thank you so much, Dr. Borum, and thank you so much to everybody for being here today and for inviting me to speak. As Dr. Borum said, I am a member of the faculty at George Washington University School of Medicine, and I'll be talking about COVID-19 and inflammatory bowel disease. As Dr. Borum said, this is a very particular area of interest for gastroenterologists and everybody caring for patients with Crohn's disease and ulcerative colitis, as these patients, even at baseline, may have an increased susceptibility to infections. Furthermore, to treat inflammatory bowel disease, we give our patients immunosuppressant medications. So when the pandemic started, when it first hit in 2020, we all were extremely worried about our patients. Are they at increased risk for this infection? Are they increased risk for poor outcomes from this infection? Are our medications going to put them at increased risk? And thankfully, there's been a lot of amazing research that has come out in the last few years to answer some of these questions and concerns. So these are the topics that I'll be discussing today. I'll start first with risk factors for hospitalization. This was a study that came out early on in the pandemic out of New York City, and it was looking at risk factors for hospitalization in patients with immune-mediated inflammatory diseases, so not just inflammatory bowel disease, but also psoriasis, psoriatic arthritis, and rheumatoid arthritis. In this group, 16% of patients did require hospitalization. Those hospitalized tended to be older. They tended to have rheumatoid arthritis versus those other diseases I mentioned. And they tended to have these comorbidities such as hypertension, COPD, diabetes. The medications of those patients hospitalized tended to be oral glucocorticoids, hydroxychloroquine, or methotrexate. And something that was reassuring from this early study was that those not hospitalized tended to be on JAK inhibitors or biologic medications. So the biologic medications, for example, infliximab, adalimumab, and JAK inhibitors include, at the time of the publication of this study, tofacitinib. Those are medications that we do use in inflammatory bowel disease. So this was a little reassuring to us. Subsequently, many larger studies came out examining COVID-19 outcomes in our patients with Crohn's and colitis. The Secure IBD registry was a registry that anybody across the country or worldwide could submit cases of their patients who had developed COVID-19 and outcomes. So one of these early studies included at that point over 500 patients, 7% of patients at the time had developed severe COVID, which is defined as ICU admission, ventilator use, and or death. 31% in general were hospitalized, and 16 patients from this cohort did pass away from COVID-19. This study found that risk factors for severe COVID included systemic corticosteroids with an adjusted odds ratio of 6.9. And again, it did not show that our anti-tumor necrosis factor antagonists were a risk factor for severe COVID. So the anti-tumor necrosis factor antagonists are our medications like infliximab, adalimumab, golimumab, and certolizumab. So this was reassuring as well. And then they had, again, an even larger study, at this point, almost 1,500 patients from 47 countries around the world, looking again at risk factors for severe COVID. And they demonstrated again in this even larger study that the anti-tumor necrosis factor antagonists patients were not at increased risk of severe COVID. However, they did find in the study that there was a higher rate of severe COVID with patients on thiopurines, namely 6-mercaptopurine and azathioprine, as well as patients on combination therapy, meaning anti-TNF antagonists plus thiopurines. And that is demonstrated here. And you can see how much higher the risk of severe COVID was in this cohort on patients on thiopurine monotherapy as well as combination therapy, and much lower on the anti-TNF antagonist monotherapy. And the authors postulated that the increased risk on combination therapy is really driven by the thiopurines and not driven by the anti-TNF antagonists. Looking at other risk factors, Secure IBD demonstrated as well in another study that risk of hospitalization and severe outcomes, again, ICU admission, ventilator use, death, increased as disease severity of Crohn's or colitis increased, and that's demonstrated here. So this was yet another reason that we want our patients to be in good control of their disease. And they also demonstrated that as the decade increase of the patient, meaning older patients had a higher risk of hospitalization, as well as ICU admission, ventilator use, and death. So all of these findings together so far are not dissimilar from the general population. So we were getting reassured that there were no particular risk factors that our IBD patients had that would lead them to have poor outcomes from COVID-19. Looking at COVID-19 outcomes in IBD patients who are racial or ethnic minorities, this study looked at the racial and ethnic background of patients and outcomes. At this point in time, the registry had 11% non-Hispanic Black patients, 8% Hispanic patients, 74% non-Hispanic white patients, and 7% unknown or other patients. They found in this study that non-white groups had a higher rate of uncontrolled inflammatory bowel disease, as well as obesity and other cardiopulmonary conditions. And here shown, they demonstrated that Hispanic patients had a higher risk of ICU admission, ventilator use, or death compared to non-Hispanic white population. And then non-Hispanic Black population also had a higher risk of these outcomes compared to the non-Hispanic white populations. So potentially suggesting their vulnerability to COVID-19, potentially related to underlying other disease and comorbidities. So just talking briefly about our evolving physician practices, again, like I said, in the beginning of the pandemic, we didn't know how our medications would be affecting our patients and their outcomes with COVID-19. And many of us did hold or change their therapies. Of course, this, I'm sure, varied in different parts of the country and world, depending on the patient population and community practice type. One study showed that earlier on in the pandemic, a significant minority of patients, around 35% of patients, did have their therapy held. They did find that for the 5-aminosalicylate therapies, that's the mesalamine therapies, they did have lower rates of discontinuation, and rates were also lower for patients with ulcerative colitis, but it was higher for the anti-TNF antagonist group and higher for immunomodulator therapy. This is showing differing rates stratified by medication type, and again, showing that the highest rate of discontinuation was in the anti-TNFs and immunomodulator therapy group. So moving on to vaccinations, the other concern we had for our IBD patients was, will they have an appropriate response to the COVID-19 vaccination when that came out later? Again, patients with inflammatory bowel disease may have attenuated response to vaccinations. Additionally, if they're on immunosuppressant medications, we have the concern that they may not respond appropriately to vaccinations. So this study was a Clarity study. It compared antibody response and seroconversion in patients treated with infliximab compared to those treated with vedolizumab. So infliximab is thought to be a slightly stronger immunosuppressant medication compared to vedolizumab. And they did find that mean antibody levels were lower in the patients on infliximab versus vedolizumab for both of the vaccines that they studied, which were the Pfizer and Moderna vaccines. So shown on the right, the infliximab group is shown in the green and the vedolizumab group is shown in the orange. So for both vaccines, the antibody rates were higher in the vedolizumab groups than in the infliximab groups. They did find that lower antibody rates tended to be seen in those patients on immunomodulator therapy, again, thiopurines, as well as patients who were smokers or over 60 years old. They did see that there was higher antibody rates in those who were non-white in ethnicity. And shown on the right is, again, comparing both vaccines. The highest antibody rates are shown in the dark orange. That's the vedolizumab without immunomodulator group. Slightly lower is seen in the dark orange. That's the vedolizumab with immunomodulator group. And then in green, the bright green is infliximab without immunomodulator group, or without immunomodulator. And then the dark green is infliximab with immunomodulators. So as those differences have been shown between two groups. They also followed these patients over time, and they did demonstrate that, not unlike in the general population, antibody rates did decrease over time in both groups, shown on the right. This was a little bit of a concerning study to all of us caring for our patients with Crohn's and colitis when it first came out, but there were several limitations that are important to note. So one is that the study used an enzyme immunoassay versus a neutralizing assay when they were studying the antibody responses. And Neutralizing assays are thought to be a little bit more biologically relevant when investigating vaccine response. Furthermore, the study only was able to quantify a humoral response, whereas T-cell response is also clinically significant in terms of vaccine response and was not able to be measured in the study. So this was something that everybody took really a significant note of. And this was a meta-analysis of 25 studies published in Gastro in 2022, looking again at seroconversion as a response to the COVID-19 vaccination. And this was in several disease states, not just inflammatory bowel disease, but also psoriasis and rheumatoid arthritis. They did see that there was, very high seroconversion rates after 1 or 2 doses of the vaccine, of course, higher after 2 doses than 1 dose. But despite this, the authors concluded, and many of us conclude, that of course, we still need to recommend vaccination for our patients. Looking at some of the numbers from the study, 8 studies looked at the response after 1 dose and 18 studies looked at the response after 2 doses. Both arms of the study did find that there was lower serologic response for those patients on anti-tumor necrosis antagonist agents, again, adalimumab or infliximab. However, it was not statistically significant in the studies examining response rate after 2 doses. They did find that there were lower response rates after 2 doses in patients who were older or on anti-CD20 therapy. And currently, we do not give anti-CD20 therapy for inflammatory bowel disease. Again, looking at current vaccination recommendations, I follow the CDC guidelines, and I know sometimes it can be difficult or sometimes even confusing again with the change in recommendations over time. So I frequently refer to the current CDC website where they have the recommendations listed out very clearly. So currently, for those who are immunocompromised, for Pfizer and Moderna, they recommend 3 regular doses plus the bivalent booster. They do recommend sticking with Pfizer or Moderna for the primary series, so the first 3 doses. One question that came up a lot from my patients was, is this a live vaccine and is this safe? Thankfully, the COVID-19 vaccines are not live vaccines and they are safe. I think we did a great job of educating our patients to avoid live vaccines, and this is a question I still get occasionally. And I do feel that it's safe to administer this vaccine at the same time as other vaccines. For example, I frequently give it at the same time as the influenza or flu vaccine. I probably wouldn't give it at the same time as certain vaccines, for example, the shingles vaccine, because that itself can cause patients to have fevers, muscle aches, etc. So I don't want them to feel, too ill in terms of the side effects afterwards. And there's no evidence that I'm aware of that states that vaccinations need to be given at any particular time of the biologic cycle, meaning for patients on infliximab every 8 weeks, there's some thought that maybe around week 6 or 7, or in the few days leading up to their next dose, that their drug level may be at the lowest, and then therefore they may have the highest rate of response to the vaccination. I'm not aware of any particular studies demonstrating that antibody conversion rates are higher if you give them at the lowest rate of their cycle. So I tend to just tell patients to get it whenever they can, to try to maximize how many patients do get vaccinated. This is an immunization schedule from the CDC. I won't go through it, but it is helpful, especially when you're thinking about the timing between vaccinations, because it is different for the different vaccines and it can be difficult for me to remember. So sometimes I'll just pull this up, go through it with the patient in terms of their previous vaccinations, and then try to figure out when their next one is due. Then we were worried about, adverse events after the vaccination. Does the vaccination cause flares of inflammatory bowel disease in our patients? So thankfully, we have some good data looking at that. The CORAL IBD was a national prospective registry looking at patients who had received either the Pfizer or Moderna vaccinations. They found that overall adverse event rates were similar to the general population. They had 39% of patients develop adverse events after the first dose and 62% after the second dose. These types of reactions included injection site reactions, fatigue, malaise, headache, dizziness, fever, and chills, again, not unlike the general population. GI symptoms were reported in 6% of patients after the first dose In 12% of patients after the second dose, there were 5 total patients hospitalized after vaccination, some with GI symptoms and some without GI symptoms. They found that rates of adverse events after vaccination was significantly higher in younger patients, as well as those who had previously had COVID-19 infection and those with ulcerative colitis. They did find that adverse events rates were significantly lower in those on immunosuppressive therapy. And of note, they did not find any differences in adverse events between those who had reported a history of infusion or injection reactions and those who had not. And that is a question that I still get time to time, because patients who develop infusion reactions, they get so ill, so severely symptomatic for some, that it's something that they have, they do not easily forget, and they're very wary of anything that could set off a similar reaction. But thankfully, the study did not demonstrate any such association. Now, another thing that we were worried about was, as I previously mentioned, will vaccination cause any type of inflammatory bowel disease flares for whatever reason? And there was an early study, or this is really just a case series of 10 patients from New York who developed flares after their vaccination. And this was some concern to us. All of these patients were in clinical remission for over 6 months prior to the vaccination, which is interesting to note. And most of them, resolved within a few days, but they did develop, significant GI symptoms that could meet criteria for a flare. However, a much larger study, the Prevent IBD study, looked at over 3,000 patients to see if any flares were seen after the vaccination. The majority of these patients were on biologic or small molecule therapy, and there was a wide variation in baseline disease activity, ranging from patients who had active symptoms, were uncontrolled, to those who were in clinical remission. GI symptoms reported included abdominal pain and increased bowel frequency. Only 2% of patients met criteria for an IBD flare after vaccination. Again, this is a very large study. So this study, I think, demonstrated that there was no significant IBD flares that will develop after vaccination. And this is something that I also discuss with my patients when I'm discussing, pros and cons of vaccination. Looking at the same question from a different way, this study of over 5,500 patients did not find any increased steroid prescriptions in patients who received the vaccination versus those who were not, with the basis that patients did flare after the vaccination, they would receive a prescription for maybe prednisone, for example. And then I'll briefly end on long-term IBD outcomes after the infection. So this is a study I was a part of in New York. It was a multi-center study matching cases of COVID-19 with controls in patients with inflammatory bowel disease to determine whether there were any differences in IBD outcomes after developing this infection. Again, baseline characteristics were not dissimilar between the two groups, except for sex, which was intentionally matched. Again, disease type was intentionally matched between the two groups, and otherwise there were no significant differences between the groups, with the exception of prior IBD hospitalization was significantly higher in the cases for whatever reason. Medication history was also not significantly different between the group, with the exception of any biologic use was a little bit higher in the case population. Baseline comorbidities were not different between the two groups. And then in terms of outcomes, we followed patients for a median follow-up of 394 days. A significant minority of patients did receive a COVID-19 related therapy, of course, higher in patients who developed severe COVID-19. And then in terms of IBD related hospitalization, IBD related surgery, there were no significant differences between the controls and cases, with the exception of actually higher rates of IBD related surgery in the control group or the non-COVID-19 group compared to the case group or the patients who developed COVID-19. There were no significant differences in these other outcomes that we looked at, meaning changes in medication use, disease progression, or even non-IBD complications that included immune-mediated diseases and psychiatric illness. I'll skip this for the sake of time. So in summary, I'll say that we do not feel, based on these studies, that IBD patients have a higher risk of COVID-19. We feel that their risk factors mirror those of the general population. We feel that the risk factors based on these studies for severe COVID-19 outcomes are similar, again, to those of the general population. We have not found that our biologic or small molecule therapies are associated with complications in COVID-19. There's many studies from the Secure IBD Registry looking at specific medications that each one does not increase risk of severe COVID-19 outcomes. We did find, however, that systemic glucocorticoids, meaning probably prednisone, and then our immunomodulator therapies, our thiopurines, 6-mercaptopurine, azathioprine, are associated with worsened outcomes due to COVID-19. So another reason to try to minimize our chronic steroid use and to consider, whether or not immunomodulators are the best choice of therapy for our patients. We did find that worsened IBD disease activity is associated with poor outcomes, especially in our young patients. We did find that seropositivity after vaccination is lower for those patients on anti-TNF antagonist medications, but regardless, all of our IBD patients should be vaccinated against COVID-19 in accordance with current CDC recommendations. We have not found that COVID-19 vaccinations causes a higher rate of adverse events after vaccination compared to that of the general population. We did not find that they cause IBD flares, and COVID-19 infection, we did not find affects long-term outcomes in IBD patients. Thank you so much. These are my references, including some of the studies I mentioned, and I'm happy to answer questions during the panel discussion. Thank you all for your time.
Dr. Borum, you're muted. Dr. Borum, you're muted.
I'm so sorry. There I am. Thank you very much, Dr. Bhattacharya and Dr. Albayumi, for everything that you were able to share with us today. There was a question that came up during your discussion, Dr. Bhattacharya, about using the new vaccine, Novavax, in our IBD patients. And I just noted that there isn't a lot of data in our IBD patients in Novavax, so we can't make comments about that just yet. There was another question that came up about transmission, about GI, transmission of the virus and people who have GI manifestations. And in fact, we believe that certainly the transmission of virus is mostly respiratory, but there is some evidence that oral fecal transmission can occur. And I anecdotally gave the information from our GI societies, which had recommended that we, when we're doing endoscopic procedures on people who have active COVID disease, that we wear full PPE. One, certainly because if we're doing upper endoscopy, we can have respiratory droplets during upper endoscopy, but also during colonoscopy, because there has been evidence that there was potential aerosolization of fecal material. And we do know that feces can contain both inactive and active virus. And so we think that not only can you have oral fecal transmission, you can have episodes of oral fecal transmission, although the primary area of transmission is respiratory. I want to thank you certainly for showing the CDC guidelines, which we very closely follow with our IBD patients because of vulnerabilities. And I really want to thank both of you for being able to bring your perspectives, your experience, your understanding about COVID vaccination, particularly for all patients, in particular our IBD patients. So thank you very much. I really appreciate everything you guys came with today. And I'd like to move on to our next.
My pleasure.
Yeah, our next group of people who will be talking, and that will be our podiatry group. Thank you.
Hello, good morning, everyone. My name is Audrey Ngalu. I am pleased to serve today as the moderator for the podiatry section. It is with great joy that we are participating in this incredible discussion on the impact of COVID-19 in the African American community. I see that my comrade, Dr. Adrienne Atkinson Sneed, is on the call, and she, who serves as our vice chair with the NMA, would like to offer a quick welcome to the group. Dr. Adrienne?
Good morning. I'm sorry I'm doing double duty as mom today also. So we do want to welcome you to our section. We hope that you will enjoy our next three speakers. They are impactful and dynamic members of the NMA. And if you have not attended one of our podiatric medical and surgical section meetings, we invite you to join us this summer. We have a lot of impactful information that affects all areas of medicine. So I will give this floor back over to Audrey. And also I want to bring greetings also from our chair, which is Dr. Kevin Jefferson, who is unfortunately on a plane right now, so he could not join either. But welcome, and we hope you enjoy it. Thank you.
Thank you, Dr. Atkinson Sneed. We appreciate it very much. So I'd like to tell you all just a little bit about our three incredible speakers today. First up, Dr. Renee Settle Robinson. She is a podiatric surgeon practicing in Milwaukee, Wisconsin at a federally qualified healthcare center called Outreach. She is a recent graduate of the Climate and Health Equity Fellowship 2022, sponsored by the Medical Society Consortium on Climate and Health. Dr. Settle Robinson is currently chair of the Grants and Special Events Committee of the NMA and is serving her second term on NMA BOT as Region 4 trustee. Her topic today will be climate, podiatry, and COVID. Next up, we'll have Dr. Valeria D. Hairston. Dr. Hairston is a practicing podiatrist in Milwaukee, Wisconsin. She practices at Milwaukee Health Services, a federally qualified healthcare center. Dr. Hairston is double boarded in the subspecialties of podiatric surgery and podiatric orthopedics. She has been active in her community her entire life. She is active in her church as well as her sorority, Alpha Kappa Alpha Inc. Additionally, she has been involved in various medical organizations for which on many occasions she has held leadership roles. Just to name a few, she has served as the past vice president of the Cream City Medical Society, the current treasurer of the Cream City Medical Society, current secretary and board member of the Podiatric Medicine and Surgery Center of the NMA, and current treasurer of the Region 4 of the NMA. Her topic today will be COVID-19 vaccination hesitancy. And last but not least, my comrade from the beloved Crescent City of New Orleans, Dr. Greg Williams. He is a very proud graduate of Xavier University of Louisiana, as well as the New York College of Podiatric Medicine. He is the first African-American chief resident of Staten Island Hospital and participated in their 4-year foot and ankle residency and is trained. He is the CEO of Precision Foot Care Center for over 21 years, as well as the foot and ankle surgeon at Premier Foot Specialists. He is chief of foot and ankle at Excelf Primary Health Services and is medical director at both the RAS Health and Wellness, as well as Black Limbs Matter. His community involvement is vast, but he is a proud member of the Omega Psi Phi fraternity, the Zulu Social Aid and Pleasure Club, as well as a member of the Police Commission Advisory Board of the 4th District of New Orleans. His topic today is the rise of diabetic foot diseases, infections, and amputations as it relates to COVID-19 and vaccination hesitancies in the African American community. Again, I thank you for being here with us. With that, I will turn over so we can move on to the presentations. Please feel free to comment any questions or comments in the Q&A feature, and I will see you on the other side of the presentations for a live Q&A with our esteemed doctors. Thank you very much.
Good morning to some and good afternoon to others. I am Dr. Renee Settle Robinson. I am a podiatric surgeon practicing at a federally qualified healthcare center in Milwaukee, Wisconsin, called the Outreach Community Health Center. I am a 2022 graduate of the Climate and Health Fellowship, which is sponsored by the Medical Society Consortium on Climate and Health Equity in communication with George Mason University. And I have no disclosures. Climate change is multifaceted and affects so many areas of our lives, our health, physically as well as mentally. We understand that there's increased carbon dioxide levels with fuel combustion of fossil fuels that have created a layer of a blanket around our planet in the atmosphere, contributing to rising temperatures. Our planet has a temperature of 1.5 degrees higher than it's ever been in the history of the world. That rising temperature contributes to more extreme weather and is contributing to rising sea levels. And beneath this set of circumstances is a very dirty story about environmental injustice, which will be explained in this presentation. These rising temperatures contribute to more severe weather, which causes fatalities, as we've heard about more recently in New York, with the worst snowstorm in the history of Buffalo, New York, causing a significant number of people to die. And as you can imagine, a significant mental health impact. Weather changes that also contribute to more severe storms, contribute to air pollution being stimulated or circulated more. And those of you that work in our emergency rooms recognize that people have more frequent asthma attacks, particularly right after those big storms. The air pollution also contributes to cardiovascular disease, COPD, diabetes, and other major chronic health conditions. Our summers are longer so that the extreme heat contributes more to heat-related illness, and heat-related illnesses cause more death than even the cold-related illnesses. But we will explore some of these things in the course of this presentation. My particular concern with regard to how climate change impacts feet is the increased morbidity and mortality after floods that people experience because of their feet being particularly vulnerable. People who have open wounds because of diabetes and people who develop open wounds for other reasons, maybe they just had foot surgery, or maybe they've been injured in the process of getting to safety. Those things are majorly affected by floods. And we see an increase in infections that can potentially turn into a systemic infection and cause death, and at the very least, increase in amputations. The higher heat index is noted in our marginalized communities because these are the communities where a lot of the trees have been cut down, because there is a belief that criminals hide in our Black neighborhoods. And so if they cut down the trees, there's no place that the criminals can hide behind. And so you'll find that generally speaking, there aren't enough trees in our neighborhoods, and that the asphalt is a big issue. in our communities for that reason. Our lower income communities also have lower quality shoe gear, and the shoe gear that's worn well past its normal wear life. And oftentimes I pay attention to the kind of shoes that my patients are wearing at different times of the year, because I find that some of them come in with shoe gear that's inappropriate for the weather conditions. Like if they come in the wintertime in sandals, or in the wintertime in their bedroom slippers, and it's snowing outside and everybody else is in boots. I mean, that's kind of obvious, but how often do we document that in our notes? It should be documented in everybody's note, not just the notes of the podiatrist. So in those floodwaters, we have chemicals that have been mixed into those floodwaters from the streets and from different industries. We have sewage that also contaminates those floodwaters. And depending on what waterways are close by when those floodwaters rise, there could even be fish or snakes in that floodwater running down our streets. And those things can enter the blood through these open wounds on the feet, or even through fresh open wounds in the feet that are created with the things that or items that are just rushing through the waters as you're trying to walk through those waters to safety. People who are disabled or have other mobility issues are at greater risk of drowning because they don't have the ability to navigate those waters, even as well as an able-bodied person would be able to. Therefore, there's a need to put into place some kind of provision or evacuation plan for people who have been identified as being in need of those kinds of support issues. Okay, so what can we do to turn these types of circumstances around? We can plant trees. That provides a canopy to lower the heat index in the communities that we live. It also provides for a natural air filtration so that those areas that have greater indices of air pollution, those trees can lower that air pollution index. And so we need trees to be planted in our marginalized communities. The trees also can mitigate the flooding to a greater degree because the roots absorb so much of the flood water as well. With the canopy that those trees provide, the asphalt will not absorb as much of the heat as it does when there are no trees. And after the sun goes down, when the heat tends to dissipate, the heat that was absorbed by the asphalt all day long is beginning to be released. And that's why our red line communities are neighborhoods where our poor, marginalized Black people and other people of color and disabled people tend to be located. You'll find that the heat index is 10 to 20 degrees higher than any other community. So when you hear that we're having unprecedented heat waves today, think about those communities that have been marginalized and need more trees to be planted, and understand that their heat index is going to be 10 to 20 degrees higher, which means they're not going to be able to rest as well at night as other people. And so for all of these different reasons are far more vulnerable to the complications of COVID and every other medical health condition that you can imagine. So we need our civil engineers to do what they can to reduce the significance of that flooding in those communities that have been identified as flood prone, because they can convert the drainage in those areas to accommodate the flooding so that there's less flooding. And while they're at it, yes, they need to deal with the lead pipes. We need to advocate in our communities for our disabled people to make sure that they have an evacuation plan well ahead of notifying the public a severe weather event is coming and you need to evacuate, because they need to be able to plan to put into place those things that will allow our disabled citizens as well as our unable citizens who don't have access to cars, as we would assume, and cannot readily evacuate. So we need to make plans for them as well. We need more public education so that people understand the timeline urgency for all people to be able to get to safety, and to advocate for clean energy to lower those greenhouse gases and the impact it has on temperature in the environment. I think you need to know that there were more than 1,800 people that died in Hurricane Katrina. And the numbers of people that died in Hurricane Katrina was above 1,800, and it was disproportionately poor, Black, disabled, marginalized, people of color with low income who were left behind to die. So what is a redlined community? Well, that is something that happens on a map that identifies that that particular community has toxic levels of air pollution, pollution of the land, pollution of the water even. And those communities have been identified to the banks and the insurance companies as uninhabitable for human existence, and that the banks and the insurance companies can charge more because these are people that are going to have greater complications of those health risks that we all kind of take for granted. I used to always wonder, why is it that we have Black people that have the same problems that white people have: diabetes, high blood pressure, heart disease, asthma, arthritis, but we always have it 10 times worse, 2 to 10 times worse anyway, than our white counterparts. And it's because we live in communities that are polluted. So the air pollution carries particulate matter. And I think you can see kind of like a haze sometimes in areas that are more polluted. And that represents all of the various particles that are in the air as a result of air pollution. These are communities that businesses that want to pollute will frequently locate because they're not going to get the pushback that they would get if they went to the white communities, because in the white communities, they're very aware of the kinds of industries that will pollute the air and pollute the environment and lower the quality of life they're able to live in their communities. But in our Black communities, all they have to do is come in and say, we're going to bring jobs to your community. And who doesn't want economic development? Yes, we need jobs. Yeah, come on and locate in our communities. 9 times out of 10, they're not going to bring that many jobs. And 9 times out of 10, the people that live in that community are not even going to get the jobs there. But the pollution will be brought to our back doors. And that particulate matter, some of those particles are small enough to get into your lungs. And the very tiniest ones are not only able to get into your lungs, they're small enough to get into your bloodstream. And that contributes to higher levels of asthma attacks, diabetes, high blood pressure, heart disease, the whole 9 yards. Those particulate matter carry the COVID virus. And that's why COVID takes a heavier toll in our Black, poor, disabled, marginalized communities of color, people of color living in those red-lined communities. There's a greater need to vaccinate are vulnerable, marginalized, high pollution communities. So in our communities, we need to wear those masks. In the white communities, you don't see them wearing the mask, but the pollution is not as high in their communities, and therefore the incidence of COVID is not as high in communities that are not heavily polluted. But in our Black communities, we have an absolute need to wear those masks. And we have an absolute need to get vaccinated, even more so than our white counterparts, because this COVID is taking more of our Black lives than any other community. So together, there's nothing we can't do. I believe that if we have a clear understanding among our medical colleagues and among our citizens that live in our red line, marginalized, low-income communities, that we will get more people vaccinated and people will have a clear understanding that we have an exact need to wear those masks to prevent us from getting COVID. So at this point, I would love to open the audience for questions. Thank you.
Thank you, Dr. Renee Settle Robinson. I was so excited to get the presentation started. I neglected to get the pre-survey questions posted. So Solomon, if you would kindly post those, and I would encourage folks to take the quick survey, and then we will move on. Dr. Settle Robinson will move on to the next two presentations and then do a live Q&A following all three. Thank you. We'll take just a moment for you all to take this pre-survey. Thank you very much. Okay, we can proceed.
Day, fellow colleagues, and Happy New Year. I'm Dr. Valerie D. Harrison of the Podiatric Medicine and Surgery section. Today, we will discuss COVID-19 vaccine hesitancy. Since the beginning of the pandemic, the CDC has reported data collecting demographics on race and ethnicity. In fall of 2021, we can see below that 60% of whites have received at least one dose of the vaccine, followed by 17% Hispanic, 10% Black, 6% Asian, and the remaining were American Indian, Alaskan, Asian, or other specific Islanders. In July of 2022, a little over a year later, with only 36 states reporting, 86% were Asian that had received at least one vaccine, 67% were Hispanics, 64% whites, and 59% African Americans. And if you see from both of the charts, the African Americans are in the lower percentages of receiving the vaccine. Let's take a look at more numbers. The figures to your left is a breakdown of African American population in the District of Columbia. The total cases of the African Americans of COVID-19 was a little over 50%, about 56%. However, they obtained less than 50% of the vaccination and about 71% or so, close to 75% of the deaths, but they only represent little less than 50% of the population. So I'm sure you're beginning to see how skewed the data is for us. The slide to our right says District of Columbia, but in fact, it really is representing District of California instead. And this is referring to Hispanics. With the Hispanic population, they represent about 40% of the population. However, they represent about 50% of the deaths, and vaccinations were less than that, maybe about 25% or so. So we can see how the Hispanic population is being negatively affected because of their lack of vaccination. Let's discuss hesitancy and the reasons why people are hesitant about getting the COVID-19 vaccination. They're anxious about the COVID-19 vaccine itself. What about discriminatory health interventions like the Tuskegee syphilis study? What about the contraceptive trials in Puerto Rican women? The first birth control used Puerto Rican women as guinea pigs. The birth control came in a brown bottle. It was marketed for married women to control their menstrual disorders. However, in reality, it was a method used to control reproductive health. The initial clinical trials resulted in a massive amount of Puerto Rican women's death. However, those deaths were never investigated. Let's talk about Henrietta Lacks. In 1951, Henrietta Lacks presented to Johns Hopkins University Hospital. It was one of the few hospitals in the area that accepted poor African-American women. She complained about vaginal bleeding. Dr. Howard Jones at the time discovered a large malignant tumor on her cervix. A biopsy was done, and the cervical cells were sent to a lab run by Dr. George Geis. He discovered that Henrietta Lacks' cells did not die off like the other women's cells that he had studied. Instead, they reproduced every 20 to 24 hours. These became known as the HeLa cells. Because they were so different, they were studied. However, no consent was ever obtained from Henrietta Lacks' family. There's also hesitancy because there's a lack of diversity in medical discussions. There's deaths of Black men that have been unexplained. And we all know that our Black and brown people have been exploited by our healthcare providers, many of which do not look like us. Their fear of being ill. Our patients are fear of needles themselves. They're also afraid of the reports about heart conditions that may be caused by the COVID-19 vaccines themselves. They don't understand how COVID-19 affects the Black community. Let's go over some more reasons why they're hesitant. They lack understanding of how COVID-19 spreads. They have logistical problems with testing. Microaggressions is a factor. They don't trust the government, medicine, or public health either. And they've had some very personal experiences that have not been positive with medical institutions, public health agency, as well as social service agencies. They don't understand, don't comprehend, and they definitely don't trust public health intervention. They're skeptical. They've been subjects of racism, of shaming, and they don't understand the side effects that can result from the COVID-19 vaccination. And they certainly don't understand the makeup of COVID-19 vaccine itself. I've had some patients that have said to me, well, doc, you know, this is the government's way of keeping tabs on you. They put a little microchip in that vaccine to keep a tab on. I'm not taking that. I mean, we hear all kinds of stuff. And they certainly don't understand the power of the virus itself. How are these fears mitigated? conversations with coworkers, with friends, with family, sometimes job dependency. Lots of jobs, especially that in healthcare, have mandated that healthcare providers, healthcare workers get the COVID-19 vaccines. Municipal mandates and policies also is a form of mitigation, as well as the need to shop and care for loved ones. Let's discuss some common responses and reactions that I know all of you've heard. I don't trust the vaccine. I've had so many of my patients tell me that. The Black and brown communities have been victims of medical doctors in the past, and I just don't trust them. And then we've all heard the vaccine was just made too fast. So if we're talking about empowering our patients with the facts, these are some YouTube videos. They may help to address the vaccine hesitancy. So I will give you a few minutes to maybe point your cell phone camera so that maybe you can share this with your patients. Let's equip our patients with the right information. The COVID vaccine was created quickly. However, it was carefully tested for safety. Literally millions of patients were tested. It was scrutinized by healthcare professionals. And actually, it's the largest vaccine safety study so far, almost 1.7 million people. It certainly is a better alternative than the infection itself. And as of October of this past year, 12.7 billion doses were given worldwide, of which 613 million were in the United States. The vaccine side effects are only temporary. There's no live virus. A good way to maybe explain it to some of our patients is that the first dose gathers the troops, the second dose trains the troops, and the third and now the fourth dose retrains those troops. If you have any symptoms from the COVID vaccination, it's usually injection site soreness, which only lasts a few days, fever, chills, and body aches, which are very short-lived. In 2019, there's a 1/10 of a risk of getting the COVID-19 for vaccinated people. And the risk of serious illness less with vaccinated patients than vaccine naive people. We can also inform our patients that there was diversity in vaccine testing. If you notice on both charts, Caucasians are the predominant race that participated in the vaccine testing trials. Drawing your attention to the Moderna side, Blacks were 2.7 million, Asians 1.3, Hispanics 10.6. Going back to the Pfizer side, 32.1 million whites, Blacks 3.9 million, Asians 1.7, Hispanics 5.6. As you see from the data in front of you, Hispanics were the largest minority group that participated in the trials. If we equip our patients with more information, we can let them know that there's minimal allergic reactions observed. People of color are more vulnerable to severe COVID-19 infection anyway. Why? Because of deficiency in healthcare. Lots of times we don't get the healthcare we need. Our healthcare status, usually we are sicker than our counterparts. Our educational status is different, and there's certainly a wealth gap in many instances. If one has had COVID-19, receiving the vaccine just provides extra protection. Immunity from the second infection fades with time, so of course you need another dose, and new variants may be more contagious and potent. Lots of our female patients of reproductive years have a lot of concerns, and to try to ease those concerns, we can let them know that there is no deleterious effect on fertility. You can breastfeed and Getting the COVID-19 vaccine is okay in pre, during, and post-pregnancy. Also, let our female patients know that without the immunity, they're likely to be ill during pregnancy and have an underweight baby. Now let's discuss some fun facts to share with our patients. Vaccines will keep you healthy. All the vaccines like the shingles, the pneumococcal flu, Hep V, Hep B, polio, etc. All of these are designed to keep you healthy. Vaccines are as important as eating healthy and exercising. Vaccines can make a difference between life and death. Vaccination can mean the difference between life and death. Vaccine preventable diseases can be very deadly. Do you realize that approximately 50,000 adults die yearly from vaccine preventable diseases prior to the COVID-19 epidemic? Vaccines are safe. The US has a very, very strict process to make sure all the vaccines are safe before they're released to the public. Vaccines do not cause the diseases they're designed to prevent. Vaccines contain either killed or weakened viruses, making it impossible to get the disease from the vaccine. Young and healthy people can become ill as well. Vaccine preventable diseases are expensive. Not only do these diseases that have a direct impact on the individuals and their families, but they have a high cost on society as a whole, exceeding $10 billion a year. Also, when you get sick, that impacts your loved ones, children, grandchildren, parents, and it puts them at risk. And bottom line is your family and your co-workers need you. Here are my sources. Thank you so much for your attention. I hope that this has enlightened you about how to approach our patients to help to mitigate their fears about getting the COVID-19 vaccination. Thank you so much for your attention and this opportunity to share this information.
Thank you, Dr. Hairston. And last but not least, we have Dr. Greg Williams. Thank you again, Solomon, for taking care of all the technical work behind the scenes.
And I am a practicing podiatrist, foot and ankle surgeon for over 20 years. I would like to get this opportunity to thank the NMA for making this opportunity possible for me to participate in the symposium. I've been practicing in the New Orleans area for over 20 years at Premier Foot Ankle Specialist and Precision Foot Care Center. I am also the director of Foot and Ankle, which is Excel Primary Healthcare Center. I am also the medical director for R&S Health and Wellness and a medical director for Black Lives Matter. My topic of discussion today is the rise of diabetic foot disease, infections, and amputation as it relates to COVID-19 and vaccine hesitancies in the African-American community. The COVID-19 pandemic. Over this period of time since 2019, we saw older patients with other comorbidities, including diabetes, were at greater risk of poor outcomes and death. At the height of the pandemic, there was a lack of attention being paid to non-communicable diseases such as heart disease, cancer, and diabetes. The COVID-19 pandemic raised major challenges to the entire diabetes communities, especially vaccine hesitancy in the diabetic community led to increase in day-to-day exposure to infections. One of the challenges in management of diabetic foot ulcers during the pandemic led to the ineffectiveness of using telephone consultations and telemedicine. As a practicing foot and ankle surgeon, it is very difficult to be able to do telemedicine, especially dealing with anything surgically with the foot and dermatological aspects of the foot and ankle. It was very great challenge to do face-to-face clinics that were canceled throughout the area. There was a lack of full examination of the lower extremity to properly assess diabetic foot ulcers, ischemia, Charcot neuroarthropathy. Especially in our community, African Americans were hesitant to get tested and take the vaccination. There was lack of resources and public transportation. Hospital closure due to the non-COVID patients. There was many opportunities, especially with patients trying to come into the hospital. Most of the hospitals were filled with COVID patients. So no elective or emergency cases, no ER visits, and closures of many of the outpatient clinics led not only to the rise of diabetic foot infections, but diabetic infection disease and also diabetic foot amputations. Diabetes and COVID-19, the threats to management of diabetic foot disease. We saw a suspension of all routine labs, tests. We saw a suspension of routine investigations such as x-rays, MRIs, and other imaging tests. There was a suspension of routine non-invasive vascular laboratory tests. And there was also a suspension of non-emergency surgery, including bypass, peripheral arterial disease, coronary arterial disease, and minor amputations. So just imagine, it was very, very difficult if a patient came into my office or any podiatrist's office to try to get some sort of evaluation of their foot. And if they needed some type of surgery, all the rooms in all the hospitals in the area were filled with COVID patients. So these patients had to pretty much either self-treat or pretty much just wait for the next appointment that they can see a specialist, a foot and ankle specialist. Many African Americans refuse to take the vaccine, which leads to vaccine hesitancy leads to neglect of treatment. Fear of going to the hospital resulting in increased foot infections, fear of catching COVID at the clinic or physical physician's office. There was a great chance of complications of diabetes in subsequent years. So just imagine not being able to see a doctor or get that amputation or get some type of surgical debridement in the hospital. Down the road in the future, those complications just went on and on, which pretty much led to an amputation. Many got COVID-19 because not receiving the vaccine, or therefore they was around others who was infected. Many family members had to take care of others who lived in the same household who may have had COVID, therefore they received COVID. There's a lack of trust in the medical health system from past years and experiences as it relates to the African-American patient. Lack of transportation and testing and vaccine sites. People not living in those areas, especially in the rural areas, trying to get out to those places to get the vaccine or even get tested. And the initial lockdown led to increased amputation and hospital admissions. This is a particular case of mine. I have two. This is a clinical sign of a sausage toe, infected toe. As you can see the probe going from one end to the other end, definitely down to bone. This patient, diabetic, already had a previous fifth toe amputation, partial array. Now the fourth toe probes the bone, suggesting osteomyelitis. No x-rays possible in this case, as this was day one of the lockdown. Doctor's offices were closed. He was taking care of a sick family member, really neglected care for himself. And before you know it, this infection spread. Transportation was an issue and did not have a way to the hospital in a timely fashion. Hesitant to go out because of getting COVID. Case two, this is a patient that developed an infection, went to a hospital where it was done by another physician, did not have the proper transportation to that hospital, so therefore EMS took her to the nearest facility, was seen in the ER and was told to see a podiatrist, had complications after surgery and could not be seen again because of COVID. In conclusion, in dealing with the future, the International Diabetic Foot Care Group and Diabetic Foot International Foundation published a fast-track pathway for diabetic foot ulcers during the COVID-19. They recommended trying to put this into a tier system that when you're evaluating foot infections, we need to look at them in this group. Number one, uncomplicated diabetic foot ulcers. Number two, complicated, more defined as a potential ischemia or osteomyelitis. And then the third type of foot infection is the severely complicated diabetic foot ulcers, gangrene and abscesses. These are the patients that's most likely need to be admitted and to have some type of surgical debridement and brought to the OR in some fashion. When these patients are not grouped or not put in this proper perspective, there is a possibility that these patients can lead to further infections, which can lead to gangrene and then down the road, amputation. I found that many of these patients that I've came encountered with pretty much went straight from the ER to the ICU. Sugars were over 600. Hemoglobin A1C was over 14. So these patients definitely was not getting the proper care. And I think this is going to be a useful algorithm that can be used around the world and also for future use, probably in the United States. We can also do better with early screening, investigation, awareness, education to ensure that patients do not have COVID and make sure that they can get the proper treatment. There's a major emphasis that not to neglect these diabetic foot patients and its potential complications during the pandemic. But there's a need to transform our approach to the management of diabetic foot diseases, making sure that they get to the primary care, and that the primary care makes sure that they get to a foot and ankle specialist in a timely fashion. But can you imagine during COVID, where a lot of the hospitals were on lockdown, a lot of the doctors' offices were not open. Telemedicine was just something new that we was trying to get to. And as a specialist, I have to see those patients. I have to be able to evaluate to make sure that how the skin looks, making sure that if the wound probes the bone, because it's quite easy to misdiagnose something. I think in the future, there should be new ways of innovations in the areas of digital health, smart technology, including pressure or temperature sensing insole, telehealth technologies. Those will be quite a few things that can be done. And also, let's look into our wound care centers. I think wound care centers without walls, where we can have an approach aggressive enough to triage these patients, the provided care to patients with hospital provisions, making sure that the wound care has an extension with these patients at the home, outpatient facilities, and hospital for services. So by taking all these entities and working together, we can come with a complete plan to know how we can also eliminate these diabetic foot infections, how to better treat them, and also how to get better outcomes. This is the conclusion of my presentation. I think it was very informative when I was doing the research. It shed some light on the things that we can do better when it pertains to diabetic foot infections, diseases, and reducing the amputation rate. So this was a great opportunity to be able to elaborate a little bit more in detail of how we can do a better job in managing diabetic foot infections. This is something I see regularly in my office at a high rate. I had patients that come into my office from public transportations with sugars over 700, hemoglobin A1C over 15, and they have to go straight to the hospital. So in conclusion, I think we have a lot of work to do, but I think that the pandemic gave us at least some ideas of what we can do better. I would like to thank the NMA for giving me this opportunity to be part of this symposium. I would like to give the podiatry section of NMA for keeping the communication with me and making sure that we formulate a great plan as far as for how we deal with the vaccines and the vaccines affecting our profession. So thank you and God bless.
Thank you so much, Dr. Williams, Dr. Settle Robinson, and Dr. Hairston for great information and insight. I would ask that we post the post-survey questions, and then we will get to the Q&A. We've got some questions that have come in, but I will pause on that to give you all just a moment to take the post-survey. if any of you have trouble taking the survey, please just ping me so that we can see if we can't resolve any technical issues. And we'll do this for about 30 to 45 seconds. I think that may be enough. No, maybe we'll give you a minute. How about that? And I'd ask if, besides the three doctors who will speak in a moment, if anyone else is unmuted, if you would mute your line just so we can minimize any background noise. Thank you. Okay, I think that we are. Is that enough time? I think we're ready to start the Q&A. Let's see. And I will toss this one to Dr. Williams, but anyone can chime in. In terms of perspective and speaking to access, what percentage of Black patients, Black diabetics, who should be under the care of a podiatrist are evaluated at least annually? Thank you. Thank you, Dr. Chung. Dr. Williams, would you like to take that?
Can you hear me?
Yes, I can hear you now.
Yeah, can you repeat that question again?
Certainly. In terms of perspective and speaking to access, what percentage of Black patients, Black diabetics, who should be under the care of a podiatrist are evaluated at least annually?
That's a very good question. I think it varies from region to region. The studies have shown that across the board, many African Americans do not even go to their primary care. So without going to the primary care, it's very difficult to get to a specialist. I think what we have to do is, I think we have to continue to do more education. I think one of the things we have to do, I think I was talking to Dr. Sneed, we have to do something as far as for maybe legislation, when especially making sure that when these patients have a problem, especially if they have to go to the ER, that the podiatrist be the first line, especially when it comes to a diabetic foot ulcer. Because if that's not the case, a lot of times these patients can get in a crossroad, may not be able to get the proper care, and therefore you start seeing these diabetic foot start increasing at a high rate. I think this past Sunday on CNN, the CDC had reported that they're going to see a diabetic surge, a surge in diabetes, where we're going to start seeing patients under 20 having diabetes. So when you start talking about under 20, now we start to get into teenagers and kids. And this is where it becomes a major problem. So we still have a lot to do. We just have to make the medical community aware of the services of what podiatry provides, making sure that we're on the front line when it comes to diabetic foot ulcers. And I think that's where we're going to start chopping down this tree and start getting these numbers lowered, and definitely getting patients to start trusting more, not just in the medical community, but also trusting in who podiatrists are and what we're able to provide to the medical community.
Thank you, Dr. Williams. Dr. Settle Robinson, would you like to also weigh in on that? What percentage of Black patients, Black diabetics, should be under the care of a podiatrist? How many, what percentage are evaluated at least on an annual basis?
In a perfect world, Audrey, 100% should be under the care of a podiatrist. Mm-hmm. And ideally, they should be evaluated annually. Thank you.
Okay, thank you. Dr. Hairston, in terms of COVID hesitancy, is there data that you know of that's broken out by age? That's from Dr. Beverly.
Not to my knowledge. Most of the data was collected was with regards to race. I personally didn't see any by age.
Okay, a follow, or in addition to that, does a 19-year-old Black individual's reason for hesitancy, do you think that's the same as perhaps his or her grandparents' hesitancy during the Tuskegee study or Henrietta Lacks? You're muted, Dr. Harrison. You're muted. There
Oh,
you go.
I'm sorry.
That's okay.
No, I think that the reasons might be different. A lot of times a 19-year-old is not even aware of the Henrietta Lacks or the Tuskegee study. They're not even aware of that. And I think that their reasons are far different. I think an older generation is aware of that, so they may be hesitant because of that. I think that the reasons are different per age group
Okay.
and maybe per economic group as well.
Okay. I'll toss this to all of you. What are the current Black versus white COVID vaccination or booster rates? Does anyone want to chime in on that one? Dr. Williams?
Just in my community alone, I would think that I think the booster rates have actually increased somewhat, but I would still say that compared to whites and Blacks, I think the numbers are still low. I don't have the quite numbers, but we still having people that I see on a regular basis that may have received COVID and they'll come back and say, well, oh, I didn't get my second or third shot, may have gotten the first one, still hesitant. So we still have a lot of work to do. And just like I said in my report, a lot of it has to do not just with being hesitant, but just think about in those rural areas, trying to get for our people to try to get out to those areas to get a vaccine and to get a shot and to get the vaccine, let alone trying to get tested. A lot of times we have patients who have a difficult time just getting to the doctor's office, trying to get a family member to bring them, trying to take public transportation, trying to take something as the lift. So if you are to get around to your doctor's appointments and you have to get on a public transportation where you don't know what time you're going to be brought to your office, to the medical office, and what time you're going to be picked up. So a lot of times people just like, forget it. So I think the numbers are still low as far as for dealing with the booster shot. And I think, like I said, I think we still got ways to go and improve.
Thank you. Let's talk about that for a minute. How do you think these lessons learned, these observations, these insights that all three of you all have offered today, how do you think that will prepare us for perhaps another pandemic or some other wave of illness or ailment that particularly disproportionately impacts the minority and the rural and inner city communities? Do you think that we are positioned to be prepared for that? That's my question.
Okay. I think to be honest with you, I mean, for someone that, this is crazy, but I was talking to my chief nursing officer about a month ago, and he explained to me, he told me in my hospital, he said between the month of September and October, I had more direct admissions from our office than any other doctor in the hospital.
Wow.
So that lets you know direct admits from my office pertaining just to diabetic foot ulcers, that lets you know what we're dealing with. That lets you know how big and how problematic this is. Yeah. And we have to get on top of this big time, because if we don't, and I think I spoke about this last year in Atlanta at the NMA conference. If we do not get on top of this, United is going to start affecting kids at a high rate, because you got to realize, let's take in consideration what happened during COVID. Kids were out of school for a whole entire year, virtual for a year and 1 quarter. So kids were at home eating what they wanted to eat. No one was exercising. So the domino effect, we're not going to see the domino effect until 2 years later after the initial lockdown, after the initial pandemic, which was in 19 and 20. And so now you're starting to see these patients starting to come into the office. You're starting to see the referrals. But what we have to do is we have to kind of change the culture and understand and make sure that we get to the primary care, the internal medicine doctors, the hospitalists, to make sure that they refer and make sure they consult us at the very, 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 very beginning and not wait to the last minute. And that's the thing. But until we change the culture and how we look at this on a whole in this country, the numbers are just going to continue to go up and go up. And think about this. You got a 45-year-old that gets an ulcer and they end up getting their leg amputated. Now, this is a person that was working, had a great job, had a mortgage, was paying on their car note. Now, all of a sudden, they have an above-knee amputation or below-knee amputation. So the likelihood of them probably going back to that original job is null and void. And so now what happens to that person? That person now pretty much has to find some other form of employment, probably some type of sedentary job. They probably have to develop certain type of skills to do that job. And then we got to worry about the depression. You know, it's been well documented that the mortality rate under above knee, below knee amputation is 5 years. And that is greater than colon, colorectal cancer, prostate, breast, and lung combined. So this is the situation where diabetes is right now as far as for dealing with diabetic foot ulcers in the African-American community. So we're going to have to kind of change the approach of how we treat these ulcers, because this is the one entity, one of the few entities in medicine that you can come into a hospital with your leg and the next day lose it. So just imagine what that does to your mental state. What that does, and so many times in my office, I have seen 50-year-old men wheeled in a wheelchair by their 70-year-old mother.
Wow.
And their 70-year-old mother has high blood pressure and diabetes herself. She took care of her son from the time he was born to 18. Now she's taking care of him from the age of 50 up until, and now she's stressed out. So it's a domino effect. It just doesn't affect the patient. It affects their family member, therefore it affects the community.
Thank you. Dr. Settle Robinson, looks like you're chomping at the bit to either echo that or add something to it.
Well, I just want to add that shoe gear should be a social determinant of health, because our patients depend on their feet to get them someplace when they have nothing else in the way of transportation. So social determinant of health, that should be documented. I just wanted to respond to Dr. Virginia Kane's question about oral antibiotics and treating diabetic feet. How do the patients pay for the antibiotics if they have no insurance? I have the pleasure and privilege of working at a federally qualified healthcare center, which also has a pharmacy, and they make all of their medications available to patients at a price, if it has to be in cash, at a very low fee. And so I would say direct those patients to FQHCs, which are located in all of our big cities.
Thank you very much.
And if I can if I can chime in on what Dr. Settle Robinson just said, I also have the pleasure of working in FQHCs, and there are programs that a lot of times we are connected with the pharmacies that actually make the antibiotics that will give the patients the antibiotics at no cost at all. So that program exists as well in the FQHC agencies.
Thank you.
And guess what? I want to piggyback on both of you all. The same thing here. When I mentioned I work at Excel, so it's a federally qualified clinic too, and we actually have every day we actually have a pharmacist who goes over the medication with these patients, giving them also education. That's the key point too. Making sure that the patients, sometimes many of our patients are on 20 medications and may not understand what these medications are all about and what they are doing. So that's all part of it too, not just giving them medicines, but also educating them about the medicines so that they can know what they are for and what are they using it for. And if there are any complications, there's someone there that they can make an appointment to come and see about these medications, and also making sure that any changes needs to be done. So these federally qualified clinics are amazing, and definitely the service that is needed in our communities. In the clinic I work in, I see a variety of not only African Americans, I have a high Haitian community, high Pakistani community, and a high Asian community. So definitely well-deserved in minority communities, these clinics. So definitely well needed. And that's one of the ways we also can be able to combat these issues by definitely putting more clinics like this and definitely get more podiatrists on staff and working with a wide variety of disciplines of all medicines.
Thank you again. I know that we are just at about time. We did hopefully get a few extra minutes since we started a little bit behind schedule. If one of you all can answer this last question in about 30 seconds, how do you assess patients for COVID toe manifestations? 30 seconds or less.
Listen, I mean, one thing when I was doing the research, the COVID toe thing is something that's still fairly still being studied and investigated. There was a lot of studies I think that I did when I found pretty much more in China than in the United States. But what we was finding that is that a few of the incidents that I've seen with the COVID toe is pretty much the dermatological manifestations, where you see the excoriations, the petechiae on the toe, those type of infections. But that pretty much kind of felt in line with the diabetic foot, just not, you already got the comorbidity as far as for diabetes, high blood pressure, end-stage renal disease, PVD. So when you have those 4 things going on, it is definitely an increased chance that you can end up getting something like a sausage toe or COVID toe. You just start seeing the manifestation because of the breakdown of the circulatory system. And then therefore, as the circulatory system breaks down, the skin becomes very, very fragile. And without that protective barrier of the skin, you end up getting not only skin exposure, but you end up getting bone exposure. So it's just a matter of just evaluating that patient, doing the x-rays, if need be, taking a culture of that particular wound, and need be, you may have to get an MRI. So it's a lot of things that you have to do before you to examine that patient. But the main thing is that when you see it, you're looking at the whole body. And that's the great thing about, about us in this profession. We are the first line when it comes to the foot and ankle. And you're dealing with the vascular aspect, you're dealing with the dermatological aspect, you're dealing with the skeletal aspect. So we have to do so many things. And like Dr. Robinson stated, the one thing about having your feet is you don't need to drive. You need your feet for walking. So you can still get from A to B with your feet. But once those feet are gone, then where can you go? And you're going to definitely need the assistance of someone. So I just wanted to share that thought.
I thank you, Dr. Greg Williams, Dr. Renee Settle Robinson, Dr. Valeria, I hope I'm saying it right, Valerie Hairston. Guys, this is a precursor for all of the attendees. We are grateful for your time this morning. This is really a precursor of the incredible information that you will be able to be a part of when you attend the NMA in New Orleans later this year. Insightful, educational, inspirational. We thank you very, very kindly again for all the attendees as well as our great speakers. I wish you all a wonderful, wonderful day. Thank you.
Thank you so much.
So I think I'm going to be transitioning to the next segment, which is the segment from the obstetrics and gynecology section. Not so much a smooth transition, but our colleague did mention some concepts that we will talk a little bit about regarding COVID-19 vaccination and pregnancy. My name is Dr. Camille Claire. I'm the obstetrics and gynecology section chair, and we'll be introducing our moderator and our speakers. Our moderator, Dr. Cassandra Henderson, is having a bit of technical issues, so hopefully she'll be able to join us shortly. And then following my introduction of her, I will assist with the moderating until she gets on. And then we will have our presentations by 2 of our speakers, Dr. Ashanda St. Jean, which will be a pre-recorded session, followed by Dr. Keisha Gaither, and I will introduce them when the time comes. So initially, let me just bring up the introductions and bio of Dr. Henderson. Hopefully she'll be able to join at some point during the session. She is a board certified maternal fetal medicine specialist, obtaining her postgraduate residency education, as well as her fellowship training at the University of Chicago in Illinois. She has sat on multiple and is a member of multiple organizations, including a board member of the New York State Office Life and Law, as well as the Office of Professional Medical Conduct. She's a member of the Society of Maternal Fetal Medicine, a fellow of the American College of Obstetricians and Gynecologists, the American Medical Association, and she also currently serves as the Secretary Treasurer of the OBGYN section. So I don't want to prolong that very long. And then we will first hear from our pre-recorded sessions. Our first speaker will be Dr. Ashanda St. Jean, which will be a pre-recorded session. She's a graduate of the Sophie Davis School of Biomedical Education, CUNY School of Medicine. She received her medical degree from New York Medical College and completed residency in obstetrics and gynecology at Danbury Hospital, Yale, New Haven. Affiliate, she is board certified obstetrician gynecologist with over 20 years of experience working in New York City, focusing on delivery of quality care of those who are underrepresented individuals. Her life work is really devoted to excellence in healthcare delivery via patient-centered comprehensive care, inclusive of mental health wellness, combating social determinants, as well as addressing disparities, health equity, inclusion, maternal health and quality policy and access. She's currently the chair of obstetrics and gynecology at Health Alliance Hospitals of Hudson Valley, which is a part of the Westchester Medical Center Health Network, and associate professor of the Department of Obstetrics and Gynecology at New York Medical College. She also serves as a consultant for the New York City Department of Health, Diversity, Equity, Inclusion Advisor for the American College of Obstetricians and Gynecologists, District 2, as well as a member of the COVID-19 Perinatal Task Force and the New York Coalition for Doula Access. And our final speaker will be Dr. Keisha Gaither, and I will bring up her bio right now. Just one second. Dr. Gaither is a double board certified physician in obstetrics and gynecology, as well as maternal fetal medicine. She holds a master's degree in public health, as well as being a perinatal consultant and a women's health expert. Most of her expertise is grounded in research, as well as her professional clinical experience caring for individuals with multiple medical and surgical and fetal conditions in pregnancy. She currently serves as the Director of Perinatal Services and Director of Maternal Fetal Medicine for the New York City Health Plus Hospitals Lincoln in the Bronx. She is also Associate Professor of Clinical Obstetrics and Gynecology with Weill Cornell Medicine. She's a native of Harlem, New York, and her professional experiences, again, is in perinatal care for all pregnant persons and individuals, as well as being a correspondent and a consultant, as well as providing multiple presentations for multiple media outlets, including CNN, Fox News, Parents Magazine, Women's Health Magazine, among others. She is also a reviewer and well-published in multiple scientific journals, as well as producing multiple areas of expertise in media. She received her BA in biology from Barnard College, and her medical degree from the SUNY Health Sciences Center in Syracuse, and completed her obstetrics and gynecology residency at Riverside Regional Medical Center, which is a subsidiary of the Medical College of Virginia. She completed her maternal fetal medicine fellowship at the University of Medicine and Dentistry, Rutgers in Newark, New Jersey, and obtained her Master of Public Health and Health Policy and Management from Columbia University, and most recently completed a dual MS and MBA degree in healthcare policy, research, healthcare leadership from Cornell S.C. Johnson School of Business. She's also a member of multiple organizations, including the American College of Obstetricians and Gynecologists, for Society of Maternal Fetal Medicine, among many others, very numerous to obtain, and she's received multiple awards and honors for all of her expertise. So not to belabor the introductions, but we will get started first with our poll. So if Solomon can bring up our poll of our pre and post test questions, and then we will begin our presentation. So just a moment as we pull that up. I think we can close the poll right now, and then we will start with our first speaker presentation, which is a pre-recorded session by Dr. Ashonda St. John. So Mr. Solomon can bring that up right now. And she will be speaking about the impact of COVID-19 on pregnant and birthing persons and how to alter the course with COVID vaccination.
Hi, my name is Dr. Ashonda St. John. I'm the chair of OBGYN for Health Alliance Hospitals of the Hudson Valley, and I'm also an associate professor of OBGYN for New York Medical College. As part of the CDC essential factors for promoting the increase of Black community COVID-19 vaccine uptake, we are going to discuss today the impact of COVID-19 on pregnant and birthing patients, and also how we can alter the course. I do not have any disclosures. I have no conflicts of interest. So let's start at the beginning. COVID-19. It is the virus that causes COVID-19 has been designated as a severe acute respiratory syndrome. Now, this disease has a severity of symptoms. They can be both mild and also severe. Mild symptoms include fever and malaise, cough, and upper respiratory symptoms. What's important about mild symptoms is that it does not require hospitalization. Now, let's discuss the severe symptoms, which includes dyspnea, which is shortness of breath, hypoxemia, which is a decrease in the O2 saturation in the blood. And typically that's below 94% on room air. And also the need for oxygenation or even ventilator support. Now, these severe symptoms do in fact require hospitalization. So let's talk about the impact of COVID-19 and pregnancy. Pregnant and recently pregnant patients with COVID-19 are at an increased risk of severe illness than their non-pregnant peers. This severity of illness includes an increased risk of hospitalization, ICU admission, mechanical ventilation, ventilatory support such as ECMO, but also death. Now, how does it impact BIPOC, so Black, Indigenous people of color, and also minority populations? Well, Black and Hispanic individuals who are pregnant appear to have a disproportionate amount of COVID-19 infection, but also death rates. And the CDC includes pregnant and recently pregnant individuals as increased risk in terms of their categorization for severe COVID-19 illness. So let's look at the data that was collected from January of 2020 to February of 2022. There has been a total of 171,428 total cases across the United States. Of those cases, 29,008 were hospitalized cases of pregnant people across the United States. And there was a total of 273 deaths of pregnant people across the United States. Now, this chart looks at the cases of COVID-19 among pregnant patients, but also by the week of diagnosis. And as you see, there are spikes that are in accordance with celebratory holidays across the country. So if we look in November of 2020, we see a spike then, and that kind of reflects the time of Thanksgiving. But also if you look at December of 2021, that also reflects a Christmas holiday, which is also sometimes a gathering of families in terms of celebrations. Now, when we look at pregnant women with COVID-19 by age in the United States, we look at these age groups. Well, the highest age groups that occur were between 25 and 29 years old. And then we're looking at 30 to 34 years old. So relatively healthy people who necessarily would not be very sick, but with pregnancy and COVID, they certainly can also represent a population of people that are severely affected by COVID. Now, when we look at pregnant women with COVID by race, ethnicity in the United States, again, in that 2-year interval, we look at Hispanic or Latino patients having, very high numbers in terms of cases, whereas we're looking at white patients actually represent the largest numbers of pregnant people affected by COVID-19. And then we also have Black non-Hispanic, and then Asian non-Hispanic, and then also our multi-other race non-Hispanic category. So again, talking about the severity of illness of COVID in pregnant patients, here we are able to look at what the severity of illness of COVID does to our pregnant patients. So we see that there is a large number that required admission to the hospital, but also admission to the ICU. And that first block represents that. In the second two blocks, you'll see that more than half did not require invasive ventilation, and less than that required ECMO. So again, we're looking at the clinical manifestations and risk factors for maternal and perinatal outcomes. So again, what are the risk factors for COVID? Well, they studied 77 studies were reviewed, and this included a population of over 13,000 pregnant people and over 83,000 non-pregnant patients. And so when we looked at that, we saw that the risk factors for COVID included advanced maternal age, a higher BMI, so moderate or severe or morbid obesity, chronic hypertension, and also pre-existing diabetes. And then when we looked at the maternal outcomes, all-cause mortality was 0.006. However, if we look at the ICU admission and invasive ventilation, those numbers are much higher. And then now if we kind of change the lens into the fetal or neonatal outcome, we can see that COVID-19 in pregnancy has an increased risk of preterm birth, stillbirth, cesarean delivery, and also NICU admission. So again, a lot of these charts are very, very busy, but what I want us to be very cognizant of is that these are the outcomes that affect our patients, our pregnant patients who actually are impacted by COVID during the course of their pregnancy journey. There is that risk of ICU admission, invasive ventilation, and also ECMO. But also, we want to also reflect that there's also an increased risk of maternal death. There has been some increased numbers in preeclampsia, preterm birth, but also the numbers for stillbirth have increased, and also NICU admission for our newborns. So again, let's review the fetal and neonatal outcomes. Now again, the science has not been conclusive in terms of vertical transmission. Actually, it's actually shown that there's a very low incidence of neonatal vertical transmission. But what we do know is that there is an increased risk of preterm birth, an increased risk of pregnancy complications, and also an increased risk of NICU admission. So we have seen some new data that is very positive for our patients. Pregnant patients who have been vaccinated or who've had natural COVID infection during the pregnancy, their newborns have had COVID-19 antibodies for up to 6 months of life. So again, another way that we can really educate and discuss with our patients the positive outcomes of vaccination, especially if they are pregnant or thinking about pregnancy. So let's review the timeline of the ACOG of ACOG and the COVID-19 vaccination recommendations. So in December of 2020, Pfizer vaccine was recommended. Pregnant patients were excluded from clinical trials, and only animal model data in pregnancy was able to be utilized, but it showed no safety signals that were indicated. And then on December 13th, 2020, ACOG recommended pregnant patients to have access to the COVID-19 vaccine and recommended a risk-benefit conversation with their clinician. And then on December 21st of 2020, the Moderna COVID-19 vaccine was recommended. And ACOG, in their practice advisory literature that they provided to all of their obstetricians and gynecologists, was they recommended access to both mRNA vaccinations. In January of 2021, ACOG received reports of pregnant patients being denied access to COVID-19 vaccines and developed 8 key recommendations for COVID-19 vaccination sites. So as we're traveling through this timeline, it's very important to understand that there were many efforts that were made to make sure that pregnant patients had access to COVID vaccine, but also that we fostered vaccine confidence to our patients. In January of 2021, the CDC began reporting numbers of patients enrolled in VSafe after vaccine health checker who identified as pregnant. So again, we're going to talk about that in a bit, but I just want to walk through this timeline. February 3rd of 2021, ACOG leads a statement saying that maternal immunization task force and partners urge that COVID-19 vaccine be available to all pregnant individuals. And again, it's really important to understand that there was a time sequence that we were able to arrive at this recommendation, but also we want to be very transparent to our patients that we want them to have the best outcomes possible. And then in March 1st of 2021, our first safety data from the VSafe pregnancy registry was reported. And it also indicated that there were not any safety concerns. So again, let's start out. How does the COVID-19 vaccine work? Well, it is genetic material that instructs your body to make a protein that is part of the virus that causes COVID-19. The protein tricks your immune system into thinking it sees the COVID-19 virus. Your immune system makes antibodies and other defenses. And if a person is later exposed to the actual COVID-19 virus, the body now is able to recognize the virus and make antibodies to fight it. So again, we need to just make sure that initially these were the vaccines that were available in the United States, which was the Pfizer and the Moderna vaccine, which are both mRNA vaccines. And then there was also our Johnson & Johnson. The ACOG no longer recommends Johnson & Johnson for our pregnant patients. So let's talk a bit about the mRNA vaccines. They consist of messenger RNA, which is encapsulated by a lipid nanoparticle for delivery into the host cells. It utilizes the body's own cells to generate the COVID virus spike protein that stimulates immune cells to create antibodies against COVID-19. So these are some very key points that we want to make sure that we convey. It is not a live virus vaccine. There's no adjunct. It does not enter the nucleus. It does not alter human DNA, nor does it cause any genetic changes. Now, this schematic goes over how the virus actually works. We went over the overall kind of gist of how it is represented, but this is our schematic just for our biochemistry experts so that they can see how the messenger RNA vaccines work out. Okay, we're gonna, okay, so let's talk about the efficacy. All current available COVID-19 vaccines have demonstrated high efficacy. Evidence suggests fully vaccinated people are less likely to have asymptomatic infections or transmit infections to others. And those with up-to-date vaccinations are less likely to experience severe illness and severe adverse outcomes. Again, COVID-19 vaccines are effective. They can keep you from getting and spreading the COVID-19 virus. They can prevent you from serious illness. And getting vaccinated may also protect the people around you, especially people at increased risk for severe illness. And those include pregnant patients. So let's look at the efficacy during pregnancy. So when we looked at this study, it looked at 7,530 vaccinated pregnant people and 7,530 unvaccinated pregnant people. And what it showed is that when we looked at the incidence of COVID-19 infection over time, those that are vaccinated had a lower incident of infection and thus a lower risk of infection. So those that have been vaccinated have a lower incidence of infection, but also infecting other people around them, especially pregnant people. So let's talk about the side effects, because often our patients are quite concerned about the side effects, and we want to make sure that we inform them in totality what impact that the COVID vaccine can have in terms of side effects. So if we look here, the Moderna vaccine, the major side effects that are reported are injection site reactions. A little less patients, 68.5% report fatigue, 43.4% report chills, 59.6% report muscle pain, 44.8% report joint pain, and 63% report headaches. When we look at Pfizer, they have a little bit of a less injection site reactions at 84%, and the majority of their side effects for the patients who receive the Pfizer vaccine is fatigue at 62.9%. So again, let's talk about vaccination during pregnancy. ACOG, which is the American College of Obstetrics and Gynecology, strongly recommends that all eligible persons greater than 12 years old, including pregnant and lactating individuals, receive the COVID vaccine and or the vaccine series, which includes the boosters. Any of the current authorized COVID-19 vaccines, and that includes our Pfizer and Moderna, can be administered to pregnant or recently pregnant patients and even lactating patients, so patients who are breastfeeding. Again, we've reviewed that we no longer recommend the J&J vaccine to pregnant patients, but we do recommend both Pfizer and Moderna. And again, ACOG recommends that pregnant and recently pregnant patients up to 6 weeks postpartum receive a booster dose of COVID-19 vaccine following the completion of their initial COVID-19 vaccine or vaccine series. So is it safe? Because that's what our patients want to know. You know, they have a life inside of them. It's a very exciting, delicate time, but also during this global pandemic, it has been a very scary time for our patients. So we want to make sure that we give them the fortitude of information and knowledge and education. And that way we want to really stress to them the safety of the vaccine during their pregnancy. So number one, there's no safety concerns that were found in animal studies. There's no adverse pregnancy-related outcomes that occurred in previous clinical trials. And then also that the COVID-19 vaccines do not cause infection, including in pregnant people or their babies, because that's what our patients fear, that the vaccine will give them infection, or it could cause infection in their infants or their newborns or their fetuses. And it's actually the reverse. It helps with the development of antibodies for their newborns. So let's talk about some of the myths. So one of the other concerns that our pregnant patients or our reproductive age patients are concerned about is fertility. So there are no claims linking COVID-19 vaccine to infertility. So that is very important to understand. There is no scientific evidence that supports any kind of infertility related to COVID-19 vaccinations, and any claims are completely unfounded. Now, given the mechanism of action and the safety profile of the mRNA vaccine in non-pregnant individuals, COVID-19 mRNA vaccines are not a cause of infertility. So again, this message has to really, really make sure we hit home, because again, our non-pregnant patients, but those patients of reproductive age or who desire future fertility, that is a major concern. And we want to make sure that we address that. And we hear you, but we want to make sure that you understand there is no scientific evidence that supports any infertility claims or any problems with long-term fertility. So in a prospective cohort study of couples trying to conceive, there was no meaningful association between COVID-19 vaccination and either partner. So as we talk about the COVID-19 vaccination impact on lactating individuals, and those are patients who are breastfeeding, it's very important to understand that ACOG strongly recommends that lactating individuals be vaccinated against COVID-19. And again, the theoretical concerns regarding the safety of the vaccination in lactating individuals do not outweigh the potential benefits of receiving the vaccine. There is no need to avoid initiation or discontinuing breastfeeding in patients who receive a COVID-19 vaccine. And current data demonstrates that lactating people who receive the mRNA COVID-19 vaccine have antibodies in their breast milk, suggesting a potential protective effect against infection in the infant, although the degree of clinical benefit has not yet been known. But as I told you before, we have seen that our newborns do demonstrate COVID-19 antibodies up to 6 months of life. So again, this is how the vaccine is safely monitored. There is a vaccine safety monitoring system. And again, where vaccine adverse events, there's a reporting system. So again, we are, the CDC is looking at any kind of adverse events, and those are reported and those are studied and analyzed. So again, we are making sure that there is a monitoring of vaccine safety, especially in our pregnant patients. So let's talk about the impact of COVID-19 on pregnant patients. So what has happened during this global pandemic? Well, we know that there's been an increase in maternal mental health issues, including anxiety and depression. There's also been an increase in domestic violence. There's been a decrease in prenatal care visits, and working families struggled with the increased demands of child care, but also there has been income loss and unemployment. And there have been barriers to seek care during the pandemic, especially when people were staying at home, and there was this opportunity to elevate the platform of telemedicine and televisits. But for our patients who lack smart devices, broadband, Wi-Fi, or cellular data, they weren't able to participate in this. Also, there was transportational needs. During the pandemic, there was homeschooling, so there was a lack of childcare. Also, many patients had undergone unemployment or lack of medical insurance coverage. Also, there has been an increase in mental health concerns and anxiety and fear of medical facilities and offices. And then also if they have the COVID symptoms themselves or are in quarantine. Well, what has been the impact on Black pregnant patients? Well, only about 1/3 of pregnant patients were vaccinated. So that's about less than 15% of Black pregnant patients were vaccinated. And there's been marked racial disparities in COVID vaccination, and structural racism is associated with the magnitude of these disparities. And to address these racial disparities, we must confront the structural barriers that inhibit equitable vaccine distribution. So I am from New York, so I can give you the stats on New York. Greater than 1/3 of Black and Hispanic New Yorkers were infected in the initial wave of COVID, twice the infection rate compared to their white New Yorker counterparts. 39% of the COVID-related deaths occurred amongst Black people, while Black people only make up 15% of the population. So the social determinants of health, they have strongly impacted COVID vaccination in BIPOC communities, but also they have also impacted our patients and people from getting healthcare addressed, their healthcare needs addressed, because there's a healthcare access issue. There's also lack of insurance coverage, unstable housing, food insecurity, lack of transportation, income, and education. So how do we build vaccine confidence? How do we alter the course? How do we change this from a negative to a positive, right? COVID vaccines are new. We have to understand our patients have concerns. They have questions. We have to make sure we make the time and listen to their concerns. So what we want to do is kind of look at this circle of vaccine confidence. First, we want to listen, and then we want to share. We can share our own personal stories, our testimonies, even our own family stories, and then educate our patients. And we want to support them. And what we want to hopefully happen in the end is that they will get vaccinated as well. So building vaccine confidence, we have to address what are the myths, right? It wasn't rushed. It is safe. The myth that, the fact is that researchers took no safety shortcuts. Large studies show that the vaccine is safe. But here's another myth. It changes your DNA. Well, here's a vaccine fact. It's impossible for a vaccine to change your DNA. Here's another myth. It can cause you to have COVID-19. It cannot cause you to have COVID-19. It contains egg protein. Well, the fact is it doesn't have egg protein and can be given to patients who have egg allergies. It causes side effects. So we've gone over the side effects. There are some side effects, but not everyone has those side effects. Okay, and the last myth is it makes women infertile. The fact is there is no evidence that the vaccine causes infertility. So again, vaccine confidence to foster those with, to foster vaccine confidence, we have to understand community, right? We have to understand the communities that we serve. We have to have engagement and understanding. We want to partner with faith-based organizations and leaders. We want to understand the impact of social media and misinformation that does exist. We want to also elevate personal stories and testimonies, and also ensure that culturally sensitive themes are present. So again, as we think about community, we want understanding, we want trust, and we want sharing. So how do we really want to go out there and really foster vaccine confidence, right? And really address vaccine hesitancy, because we know that that is happened, that's present, is again, we want to be generous of our time and spirit. Our patients deserve that. We want to provide judgment-free, respectful care. We want to afford our patients empathy, compassion, humility, thoughtfulness, understanding, and grace. There are many patients that I have seen who it took maybe the third or fourth visit before they felt okay with having the vaccine, and that is okay. We will do it on your time, as long as you understand, I want the best outcome for you and your baby. And again, and also for your whole family. I have shared my story about, my own vaccine hesitancy that existed in my own family. And having that real life conversation and really sharing lived experience is what really allows me to bond with my patients, but for them to understand that although there is some hesitancy there, we want to really foster confidence and understand the efficacy, and we want to save lives. So again, the CDC has put forth a health equity strategy, and it's using data-driven approaches and fostering meaningful engagement with community institutions and diversity leaders. They lead culturally responsive outreach, but also reduce stigma, including stigma associated with race and ethnicity. So again, when we talk about COVID vaccine confidence, what we want to do is educate, but also amplify the voice of our patients. Make that be what is heard so that we can really address their needs, their concerns, and answer any questions that they have. And in this, we are normalizing shared decision-making. And again, we go forth with respectful care, judgment-free care, but also sharing of our lived experiences together. I want to end with this quote from Dr. Martin Luther King: "Make a career of humanity. Commit yourself to the noble structure for equal rights. You will make a greater person of yourself, a greater nation of your country, and a finer world to live in." Thank you.
So we thank Dr. St. Jean for that presentation. We will now go to Dr. Gaither, who will do her presentation next, and then we'll have Q&A after that. So Dr. Gaither.
Okay, I'm trying to share my screen. Can you all see that?
Yes, we can.
Okay, beautiful. Good morning or good afternoon. I want to thank the NMA for having me present here. We're going to be talking today about COVID-19, mental health, and vaccination and pregnancy. I have no disclosures to report. On December 2019, the COVID-19 virus emerged from Wuhan, China, and quickly spread beyond its borders, such that by March 11th of 2020, the WHO declared it a global pandemic. To date, with more than 659 million people infected globally and a spread that is far from being contained, investigating the clinical as well as the psychological impact on the populace, particularly the perinatal demographic, has become increasingly important. In the last 2 decades, first responders and frontline healthcare workers' mental health concerns have become a prime focus, particularly in the aftermath of the September 11th terrorist attacks. There exists a plethora of research surrounding this segment of the populace, but of the perinatal demographic. This, a pocket of data exists in comparison. Attention to such has blossomed in the wake of COVID, not only as a major public health concern, but now as a recognition that the psychological implications of contending with the COVID pandemic in the perinatal period can lead to adverse clinical perinatal complications, neonatal compromise, and ramifications for childhood development. For those pregnant women who already have underlying mental health issues like depression, bipolar disorder, and schizophrenia, this compounded stress can be catastrophic with increased hospitalizations, suicide attempts, postpartum depression and psychosis, and infanticide. Pregnancy is a time of great adaptation and vulnerability for women, which can portend to the development of increased stress, a higher prevalence of anxiety, depression, and insomnia compared to the general population. The primary concerns of pregnant women center around their physical status, impending parenthood, interpersonal relationships, identity, childbirth, and their newborn's health. This particular type of stress in pregnant women is deemed pregnancy-specific stress. The COVID-19 pandemic unleashed a global health crisis characterized by a progressively emerging life threat. This plague triggered multiple changes in economic, sociocultural, personal, and interpersonal relationships via lockdowns, quarantines, loss of housing, employment, social support, issues which really still haven't been fully resolved for many. Pregnant women are considered to be one of the most vulnerable groups in this pandemic. The risk of complications associated with COVID infection are high, and the environmental circumstances for pregnant women were extremely adverse and unsupportive with the advent of the pandemic. Most of the traditional resources and strategies to monitor pregnancy and pregnant women for birth were blocked or delayed in an attempt to contain the ever-expanding COVID infection rate and to provide spaces to respond clinically to the pandemic. Research is now gaining a better understanding of the impact of COVID-19 on psychological outcomes. Maternal mental health difficulties, such as depressive or anxiety symptoms, can have an immediate impact by interfering and impairing the formation of a positive relationship with the fetus. Maternal antenatal attachment is a multidimensional construct that includes maternal thoughts, behaviors, emotions, and attitudes towards the unborn child. Prior studies have noted that women with higher levels of depression or stress have lower levels of maternal antenatal attachment. Stress during pregnancy, it is well known, can impair normal fetal growth. Now, in the wake of COVID, there is an acknowledgement that prolonged undue stress can impact fetal brain development, impair postnatal attachment, and long-term developmental outcomes for the child. So, with the recognition that the COVID-19 pandemic has unleashed profound psychological ramifications impacting clinical neurodevelopmental outcomes, what modalities have been presented or promoted to decrease prenatal stress among the perinatal demographic? I've listed a number of modalities here, and we'll go through them one by one, all which can be utilized to improve mental health for pregnant women during the time of COVID-19. Now, vaccines are a critical tool in the armamentarium utilized to curb the COVID-19 pandemic. COVID-19 has had a marked disproportionate impact among underrepresented communities of color, specifically African American, Hispanic American, Native American, and particular subgroups of Pacific Islanders and Asians. This finding, as a constant undercurrent, is primarily due to pre-existing health disparities, social inequities, and access to healthcare. The COVID pandemic has made these issues glaringly apparent. Additionally, this demographic is more likely to cohabit in multi-generational homes, live within higher housing densities, utilize public or shared transportation, and have frontline service jobs, all increasing exposure to the virus. Now, despite the disproportionate morbidity and mortality experienced among people of color in relation to COVID, there has been noted hesitancy toward vaccination against the virus. Various rationales for hesitancy have prevailed and range from mistrust of the medical profession, suspicion of the warp speed at which the vaccine was made, misinformation concerning its impact on fertility, wariness of the utilization of mRNA technology, having a wait and see approach, concern for side effects to both mother and fetus, to the suspicion that mind-altering nanotechnology exists within the vaccines. Pregnant women, as stated, are already psychologically vulnerable. Prenatal stress plus the stress of COVID, in addition to physiologic vulnerabilities specific to pregnancy, specifically decreased lung capacity, function, and diminished immunologic competence. Underlying comorbidities like obesity, hypertension, and diabetes further increase the risk for poor outcomes with COVID-19 infection. The scientific literature and media are replete with adverse perinatal outcomes among unvaccinated pregnant women infected with COVID-19, inclusive of increased risk of fetal, neonatal, and maternal death, preterm delivery, low birth weight infants, thrombotic phenomena, and hypertensive disorders, to name a few. Variants in acceptance rates of the vaccine diverge in the United States, depending on demographic characteristics like age, sex, household income, and geographical location. Specific areas of the country and population noted to have the highest rates of vaccine hesitancy are among Black pregnant women and includes area of the South like Arkansas, Mississippi, and Alabama as examples, and New York, specifically in the South Bronx, which is my demographic. Data supporting the use of the COVID-19 vaccine in pregnancy continue to emerge. It is well accepted that mothers who receive the vaccine afford protective antibodies for their unborn children via transplacental mechanisms. Organizations relegated to the care of the gravida like ACOG and SMFM, or the Society of Maternal Fetal Medicine, have put forth recommendations that COVID-19 vaccines should not be withheld from pregnant individuals. Worldwide experience of COVID-19 vaccination during pregnancy has yet to identify any indicators for concern. So, what of decreasing stress? Research has noted that COVID-19 vaccinations have resulted in significant improvements in mental health, declines in stress, anxiety, reducing anticipatory fears of infection, hospitalization, and death. So, what are other modalities effective in reducing perinatal stress? Let's talk about group therapy. Providing group therapy on sociological and psychological issues is an effective reducer of stress. There's an increased sense of membership, protection from social isolation, decreasing loneliness, and increase in confidence can occur. Additionally, the ability to transfer an enormous amount of information in a short period of time can also occur in groups. Strengthening spiritual behaviors. The COVID-19 pandemic has caused dramatic changes in life experiences globally. As such, it is vital to consider spirituality as one of the prime components of well-being. Maintenance of cultural rituals and spirituality empower people to contend with life challenges and decrease stress by giving a sense of peace, purpose, and forgiveness. Religious rituals can increase resilience and perseverance and improve self-efficacy. Spiritual health can train people to find meaning in daily life, transcendence, and a sense of purpose. Providing accurate information or misinformation prophylaxis is important as well. In the time of crisis, lack of accurate information from official authorities has increased the prevalence of stress-related emotions. In studies which evaluated stress levels in pregnant women during the height of the pandemic, it was noted that a significant decrease was had after the publication of official and accurate information about the disease via reliable sources. Governments and policymakers and public health officials can do much to control the accuracy of information and prevent the diffusion of misinformation and thus decrease stress, distrust, confusion, and anxiety. So let's talk about self-care. To thine own self be true. Many pregnant women do not indulge in self-care, prioritizing their concern for their unborn child first. Research has indicated that effective self-care practices involve self-awareness, self-compassion, the practice of altruism, and the implementation of a variety of strategies across physical, social, and inner self-care domains. This can be done by frequently checking in with and being aware of one's own emotional and stress level, like taking breaks whenever possible, practicing healthy daily routines, eating healthy foods, mindfulness, meditation, and my personal favorite, shoe shopping. Practicing self-care can allow pregnant women to build emotional resilience, improve physical, mental, and emotional well-being. It aids in creating structure and predictability amidst chaos, and it helps to manage high levels of stress. Now, this COVID-19 pandemic is an unprecedented phenomenon affecting humanity globally. It's far from over, and its impact will be imprinted on individuals across all spectrums of life. Widespread stressors will continually emerge and pose challenges to pregnant women. As with any challenge, opportunities can arise at every level to make a difference to the mental health of pregnant women. The COVID-19 vaccination serves as a primary modality, obviating both the physical and the mental complications of pregnancy. So with that, I thank you for listening to my speech. And at this point, we will welcome any questions. Thank you.
Before we get to questions, we will have Mr. Solomon please bring up the post-test questions in the poll for folks to go ahead and answer. And while folks are doing that, if there are any additional questions, please put them in the Q&A box, not the chat box, and we will get to the questions. We have 2 questions already in the Q&A box, which we will address, but please, if you can pull up the poll, we can have folks go ahead and answer those poll questions. Mr. Solomon, I don't know if you're having issues with pulling up the post-test questions, but if you could do that now, that'd be great. If not, we can go ahead and do the Q&A, but I think we're supposed to show those before the Q&A. Thank you. Those are the questions, so go ahead and answer those. think you can close the poll. I think hopefully everyone has gotten a chance to answer. The first question that came up in the Q&A box, Dr. Gaither, if you don't mind taking a stab, and I could also take a stab at these questions as well. There's been some information on COVID vaccination impact on the regularity of menstrual cycles. Any reliable data on this process?
You know, I did research that, and, you know, the data is conflicting. There are journals that have research that says that, yes, it does cause some irregular menstrual issues. And then there are others that say that it doesn't. So at this point in time, you know, I think that it's an individual type of issue to clinically take a look at. I can't say that there's one clinical journal or research that has definitively said that it does cause menstrual irregularities. I think it's still too early to really say that definitively.
I would say, though, there was a large study actually when the initial concerns about the vaccination was coming out, probably earlier in 2021, before we had more data. We had a lot of anecdotal evidence regarding individual issues with menstruation. And so because of that large study, they actually found that the length of the menstrual cycle was probably at most 1 day longer, and there was not any increase heaviness of flow. So I think we can reliably tell folks that, you know, there's really no prolonged difference in the cycle, as well as the heaviness of the flow. So with vaccination. So there may be other issues that are pertinent and not the vaccine itself that's related to their menstrual cycle, as Dr. Gaither mentioned. So those issues should be evaluated by a gynecologist to make sure there's not any other issues that just happen to be coincidental with someone receiving the vaccination. So that was a very good question. And then the second question by Dr. Scott, what do you say to pregnant patients who worry about potential long-term side effects or fertility issues with COVID-19 vaccination?
Well, there has not to date been any issues with any long-term impact from the COVID-19 vaccination that we are at this point aware of.
Yeah, some of those slides were alluded to in Dr. St. John's presentation. They looked at fecundability, in other words, someone's ability to get pregnant. It takes someone usually up to a year. 85% of people can get pregnant up to a year. And they looked at that as well as people that were undergoing fertility treatments. And they found that there was no difference in the quality of the fertilized embryos that were created, and no differences in the rate of fertilization in people undergoing treatment. So we can definitively say there's no impact on fertility with vaccination. The other thing, though, which I also like to mention to my patients, is that in male partners that had the infection, so not the vaccination, but were infected with COVID-19, those male partners had increased rates of problems with ejaculation. And so that may be an explanation for those who've been infected. So a good reason to speak to our patients regarding having their male partners being vaccinated to prevent some of those complications in getting the infection. So no impact on fertility with vaccination, but an impact on male fertility with the infection. So that's how we clarify that. I didn't see any additional questions in the Q&A box or in the, oh, here we go. Dr. Beverly jumps in. In terms of pregnancy, is the vaccine equally effective for the birth of I believe she means singleton, and versus multi-fetal pregnancies or multiple gestations?
That's a good question. I have not seen any research specifically relegated to that, but anecdotally, it doesn't seem to make a difference. Both babies, you know, have the transfer of antibodies, but that's a great question and certainly a good research topic for future study.
Excellent. Are there any other questions that participants had in the Q&A box? These are the answers. to the questions from the poll. I would like to, we're finishing a bit early. We're able to make up time, which is great. I do want to encourage our participants that if there are any questions, which we found even among physicians that may have a lot of misinformation regarding pregnancy, please address those to individuals like ourselves that can help you answer those questions for our patients. We thank you for the opportunity for the obstetrics and gynecology section to participate. I do want to announce that on Thursday, January 12th, we will be having a webinar, an NMA-sponsored webinar from the obstetrics and gynecology section on Black maternal mortality and morbidity. I did put it in the chat for the hosts and the panelists, so please feel free to share Thursday, January 12th at 6 p.m. Eastern Time. We would love to see you for that. And for that, I'll turn it over to our next presenters. Thank you so much.
Dr. Khalid, you want to take over? It's community health section now.
Hi, good afternoon. How are you? I want to welcome you all to the community medicine section in presenting actually one of the most challenging and most important topic that is facing our country and the world wide. It is about the vaccine uptake among African-American, Black people, and people of color in general, and how this is impacting our society and increasing mortality and morbidity. I have two of the experts that are in the field here in the US that are going to dive into this issue. They were at the center of the storm during the pandemic. They have excellent broad experience in this topic. And they have actually populated a lot of data from the CDC and other resources to give us a very informative information about the depth of the problem of vaccine uptake in our community, and also to give us like solutions and techniques and a prospect of the future of how to resolve this important issue and what should we do next to enhance vaccine uptake among our people. And my name is Khalid Al-Bashir. I am a hematology fellow at SUNY Downstate Kings County Hospital. And I also am a public health person. I also have an MPH in public health, and I've done research in the United States and also in Africa. And I would like to introduce our first speaker, Dr. Wiley, Zanisha Wiley. Dr. Wiley actually does not really need introduction. She has done a great job in Georgia and in the United States, and she was one of the first responders in the front line during the storm of COVID. And we cannot actually thank her, enough for all the great work she did. And she's an associate professor in University of Emory, and she's an infectious disease specialist, which is, this is actually her area. She's internal medicine. an infectious disease specialist. And she also presented these topics, which are very close to her heart, about COVID and how we enhance the COVID vaccines uptake in our community. She's a great daughter. She's a proud daughter. Was born in Alabama, and she's a very resilient, strong woman, and I could predict that she will have a great future in this country and in the health field and other field. And without further ado, over to you, Dr. Wiley.
Thank you, Dr. El-Bashir. I wonder, are we supposed to do the pre-questions first, or do I
Yes,
go
so
ahead and present?
Mr. Solomon, can you pop up the pre-questions just like for us to see? And then we'll do it later on at the end of the presentation as well. So Dr. Wiley, can you read the questions for us, please?
Sure. So the first question is the updated COVID-19 bivalent booster should be administered at least X months after completion of the primary series or last booster. So there's one choice there. And the other question is from Dr. Payne Foster, who would like you to enter a few thoughts about some of the underlying themes with respects to vaccine hesitancy in rural Alabama. And we will revisit these questions at the end.
So, yeah, they were like very important questions and create a lot of misconception among the population. So, yeah, Dr. Wiley, go ahead.
Okay, so I'm going to share my screen. Okay, and please let me know if you're able to see.
Yeah, it's very clear. Yeah.
Okay, very, very nice. So again, I really want to thank the NMA and CDC and Dr. El-Bashir for the kind introduction. My name is Xanthia Wiley, and I'm an infectious diseases physician who is really passionate about doing work in the community as well. COVID has really stressed the importance to me of being sure to involve and include and collaborate with the community. So I'm going to talk about COVID-19 vaccination specifically in the Black community and what we need to know. So my objectives are to describe the current state of COVID-19 and COVID-19 vaccination in the US, describe some of the methods that I use to help communicate the importance of COVID-19 vaccines and boosters. And I use some of these methods not just for my patients, but also when I'm out in the community, communicating with people who are perfectly healthy. And I'd like to describe some of the community collaborations to promote COVID-19 vaccination in, and I say our community, I'm a Black woman. So this does not surprise everyone here, looking at, but over the last 3 years now, COVID-19 community levels over time. So this is just to show you that we have had times where we're mostly green and that there's low amounts of COVID. We've had times where we've been, really intensely orange, and these things have, these levels have shifted almost sometimes on a monthly basis. So this is showing US community levels over time, but I'm also gonna show you how to look at your own community levels and why it's important for all of us to kind of look at things, not just kind of broad, but also in our on a county level. So this is as of December 29th. So this is when I made these slides about a week and a half ago. And I'd like everyone to just take a look at your personal county here and just think about where you are in your community. Are you green, where there's low community level? Are you at a medium level like I am here in Atlanta with respects to COVID-19 community levels? Or are you at a high level? Like, some people in South West Texas and in South Florida are at higher levels. So again, looking at this big picture, but also really, knowing where your community is, so you can make some of these like informed discussions with the community and with your patients if you are a clinician. So this is looking at county levels of transmission again over time. So what I'm hoping is that at some point we don't even have to look at these tables, but while we're within the pandemic, ultimately we want the lowest amount of community transmission. And as you can see, back in I'll say October, November, we had a much higher level of low level transmission. And as you go to the right side of this, we're seeing, more high level transmission. So this is the perfect time for us to be having these discussions again with respects to the importance of vaccination. So to get down to when and how does one look at your own community levels? So this is the CDC's COVID data tracker that I'll be honest with you, I look at probably on a weekly basis, and during the peak of the pandemic in 2020, 2021, probably looked at this on a daily basis. So it gives you just a kind of big snapshot of where we are right now. So I accessed this December 30th, and it gives you the US at a glance. You can see, unfortunately, we've lost over 1 million human lives, but really want to bring your attention to how to look up your own COVID community levels. And we're going to come back to, if you look all the way on the right at the bottom, this is why we need this webinar. This is why we need to discuss this, because as of a week ago, and it has not changed much, only 15% of people 5 years or older have received their updated COVID booster dose. So if you log on here, again, this is free through the CDC, and you click this COVID-19 community levels. So what I did under state or territory, of course, I put Georgia. I'm from Atlanta. Under county or metro area, I chose DeKalb County. So it will pull up, you see Georgia there, and DeKalb County, you see that it's highlighted a little bit more in a darker gray. So just like I mentioned before, we are at medium level. The wonderful thing about this, looking at things at a community level, the CDC will tell you recommendations based on the current community level of medium equals, we all want everyone to stay up to date on their COVID vaccines, get tested, wear your mask on public transportation. So this is a wonderful way when you're seeing your patients, when you're out in the community and people are asking, hey, what am I supposed to be doing right now, here in my community? Then you can say, we are at high level. This is what you need to consider. We're at a lower level in my county. This is what we should consider. And also they offer additional information on cases and deaths, testing, vaccination, et cetera. So, I highly recommend utilizing it. And I have used it really, really often over the last couple years. So, getting some more detail on vaccinations in my county. Of course, this may differ for your county. So it gives you the total number of people vaccinated, those over 5, 12, 18, 65 years old. So I'm assuming that most of us on this call, but I shouldn't make assumptions, are over the year of 18. So as you can see, if you go over, those of us over the age of 18 here in my county, in DeKalb County, Atlanta, Georgia, 15.9%. Only 15.9% have received their updated bivalent booster. Fortunately, if you go down just two rows below that, what I must say, thank goodness for our population of over 65 years old, they have left most of us in the dust with respects to getting their vaccines and getting and they're of course leading the way with respects to the updated booster dose. So just showing you these to show you that you can find really kind of, county level data so you can truly inform your community with respects to where we are. So let's go back and look big picture with respects to race and ethnicity and why we have a lot of work to do. So this is actually looking at vaccinations, and these are the numbers of vaccines administered up until about a week and a half ago. And we're going to look at this by race and ethnicity. So you see AIAN, so American Indian, Asian, Black, Hispanic, multiracial, Native Hawaii or Pacific Islander, and white. So Black persons, including myself, we're right here in the orange. And if you look at completed the primary series, we are the lowest, okay? With respects to the updated bivalent booster, only 7.9%. We must do better, and we really have to get out in the community to improve these numbers. Now let's take a look down here at the bottom at the tables. So you'll see at least one dose, completed the primary series, and updated booster dose. We don't have to talk about numbers, but just look at the dotted orange line. You see that we are the lowest with respects to at least one dose. Black persons are the lowest in completed primary series. And honestly, everyone is really low with respects to the updated bivalent booster dose. But if you look closely, we're the lowest. Black persons are the lowest there as well. So a lot of work to do. Sometimes talking about, COVID vaccinations and the Black and other minoritized communities can be depressing and discouraging. So I always look back at this study because it really lets me know that what we do and the education that we provide makes a difference. So this is looking at public trust in COVID-19 vaccines, really early when vaccines were available, and they compared it over several months. So take a look at the table, and you'll see here October 2020. So remember, October 2020, vaccines were not even available for healthcare workers just yet. And then from at March 2021, when we had kind of expanded availability for the public. If you look under race and ethnicity at Hispanic and the Black population, within a few months, there was a decrease of 15.8% with respects to COVID-19 vaccine hesitancy in Hispanic communities, and the most decrease in COVID-19 vaccine hesitancy was in the Black community. And I am convinced that it is because of the work that all of us, many of us on this call, physicians, public health leaders, CDC, the NMA, what we do, this education that we are providing does make a difference. And if you look at all of these other demographic characteristics with respects to age, sex, level of education, income, the greatest decrease was in Black communities. So I always come back and look at this. Something else it's really important. I always like to, I'm always interested in people and who's writing these things and why they're interested. And so as you can see, Dr. Daly here, I show these images to let everyone know that this is not just the work of Black and Latinx and minoritized physicians and healthcare workers. This is all of our responsibilities to think about this, to research this, and to report this. So, why is it important? Everyone this morning who has already spoken, we know why it's important, but I always like to share this because these are some of the things that I share with the community and with my patients as well. Why do we need to do this? It's about life. It's about, human beings. So this is looking at COVID-19 incident death rates per 100,000 population from the beginning of the pandemic to, and this was actually accessed this also on December 30th. So what I really want to point to is look at these peaks in death and who they're affecting disproportionately. So that initial peak that we had in March, April 2020, who was the most affected? Black non-Hispanic persons. The second peak that we had in January 2021, the most affected were American Indians and Hispanic. So you keep looking at these peaks, and the highest death rates that we're seeing over and over again are in underrepresented minoritized communities. So this is about life. And if you look at kind of like life expectancy has decreased, and we are at, honestly, the lowest in the past almost 30 years, and it's linked to COVID-19, and even more so of a decrease with respects to US men and US women. And you won't be surprised by the next slide with respects to who is being disproportionately affected. Let's look at change in life expectancy at birth. This is between 2019 and 2020. Just look at the change in years. A 3-year decrease in life expectancy for non-Hispanic Black men. The next largest is in Hispanic men. The next largest is in Hispanic women. And it's, a lot of us are, academics. You look at figures and talk and, slides and graphs all the time, but I like to think about 3 years from my Black male uncle, okay? Many of my colleagues are Hispanic men. 2.4 years from my colleagues, my loved ones, my friends, life lost from we're not just talking about figures, we're talking about human beings. So why is vaccination important? Because of lives. And, I always share with my patients, if you look at unvaccinated patients compared to vaccinated patients in study after study and research after research, what we see, this is looking primarily from April 4th to July 2022, but almost all of these figures and data say the same thing. The lowest rates of death are with those who are vaccinated, and even better with those who are vaccinated and boosted compared to the unvaccinated. We have proven this and seen this and studied this and reported this over and over and over. So what do I tell the community? Literally that COVID vaccination saves lives. And something else that I am, really interested in researching and thinking more about, and I know we're already seeing tons of this, is the disproportionate effect with respects to long COVID in the Black community and other minoritized communities. So this is a study that was published pretty early in the pandemic. One of my colleagues, Dr. Paulina Repledo, was one of the authors here, showing that so many people are having fatigue, the most common symptoms. Other symptoms, headache, shortness of breath, joint pains, etc. So we are in the midst of the pandemic. Are things better than they were in 2020, 2021? Of course they are. However, what are we going to see as infectious diseases physicians, primary care physicians, community, members? What are we going to see in the community with respects to long COVID? And one of the things that bothers me and that I worry the most about is a lot of these symptoms are not objective. So what happens when you have a single Black mother who is raising her child? My mother was a single Black woman who has long COVID, who may not have a primary care doctor, who is suffering. Where is she going to go? How is she going to get care? And already in the media, you will see this over and over again. So this says Black COVID long haulers felt invisible to the healthcare system, so they formed their own support groups. So we're already seeing a lot of long COVID. And since many of these symptoms are subjective, people going to their doctors and saying they're fatigued, but no one knows, number one, how to make that diagnosis, and two, how to treat. So that's another reason for vaccination. You know, it's difficult to get long COVID if you don't get COVID. And how does one decrease the likelihood of getting COVID? Through vaccination. So I also have added into the conversations that I have with my patients, I would like you to get vaccinated also, because I am seeing, you know, people, loved ones, those in my community, my patients who are suffering from long COVID. So, you know, first things first, who should get vaccinated? So these next few slides are primarily so I can share with you how I communicate and I do my best to do it in a really simplistic way, a lot of times with imagery for the community and for patients. So you may say, oh my goodness, like why is she, you know, making this so simplistic? This is to show you how I communicate with those who may not have much medical health background. So when people ask me simple questions like, well, who needs to get vaccinated? And I have a very simple answer. Everyone who is 6 months or older are eligible and should receive COVID-19 vaccinations unless they have an absolute contraindication and they cannot receive it. 99.9% of people do not have an absolute contraindication. And over the next few slides, you're going to see a lot of imagery. And where do I get this from? These images from? So I am barely on social media. I have an Instagram account. I follow the CDC on my Instagram account, primarily so I can get some of these like educational images. So I don't post, I just look at them and I really like the imagery. So everyone over the age of 6 months, you know, when people say, because it's not been easy keeping up with what is authorized for who and at what age, keep it nice and simple. Under 6 months, you know, COVID vaccination is not approved or authorized. But I will show you in a second how a mom or, you know, a person who has a child can protect their child, their baby. 6 months to 17 years old, what can they get? Pfizer, Moderna. Over 18, all of these are available. And, you know, Dr. Gaither mentioned earlier, totally correct with respect to a lot of people are hesitant about the messenger RNA platforms. So if they don't want the messenger RNA platform, I talk to them about Novavax, which is a COVID vaccine that's available for adults over the age of 18. And so many people have received hepatitis B vaccine, so they kind of understand that. So I say, you know, it uses the same technology as hepatitis B. So if you don't want messenger RNA, no problem. I have another option for you if you're over the age of 18. So, you know, keeping things nice and simple. Over 6 months, you need it. If you're over 18, all of these are available. You know, I do appreciate that this does say that, you know, with an asterisk that Johnson & Johnson in most situations, okay, that it's recommended for Pfizer, Moderna, and Novavax. And that is how I practice as an infectious diseases physician as well. And tons of questions from parents who were worried, especially early on in the pandemic, about giving these vaccines to their children. And I make it very clear that they are safe and effective for children. Okay, again, over six months of age. And when they ask, you know, why should I consider it? You can worry less, decreasing the likelihood of, you know, hospitalization and illness and death. Your child can go out and play, and you may have less worry. So, you know, and showing imagery with people who look like our patients that and those in the community that we're taking care of. When I give these talks to the community, I make certain that I know who I'm talking to and have imagery that is representative of the people who are asking about the vaccines, because that's very important that you see yourself. And I can't, stress this over and over and over. We just finished the OBGYN talks, and I appreciate them being really clear. It is safe and effective in pregnancy. I tell my, pregnant. I don't really have a lot of pregnant patients as an infectious diseases doctor. They're not necessarily coming to my clinic, but the people who have complications have not been vaccinated, to stay up to date on your vaccines. And for, parents who ask, what about my child who is 6 months or less? Even more important for mom to get vaccinated, because she can pass on protective antibodies to the baby. So, when someone who is pregnant has asked me, hey, why should I get this? I'll just wear my mask and be safe. When you mention protecting their baby, they really think hard about that. So what do I tell the community about the updated bivalent COVID-19 booster, and when should you get it? Again, the communication's short and sweet and simple. So what is the new one? It's bivalent, and I make it, short and sweet. It protects against more than one viral strain. We don't have to complicate it. It provides protection against the original strain, and it provides protection against these updated these subvariants. So that's what it is. And if they ask, this says BA4, BA5, but it provides protection against the most recent ones as well. And the figure here on the right, this is just to show you how on a week-to-week basis we are and have seen changes in these subvariants. So this just goes from July until October. There have been changes even from October to until now. So a lot of patients and a lot of people in the community will ask me, well, will this updated one work against the new variant? And my answer is yes. Okay, short and sweet, yes. And also has not been easy to keep up with. When does one get this updated bivalent? Let's keep it simple. 2 months after completion of the primary series or the last booster. They became available a few months ago. So if you have a patient that had their last COVID vaccination in the summer, they're due for their updated booster. The last one in August, they're due. So short and simple, 2 months after completing their primary series or the last booster. So, as you're seeing your patients and the people that you go to church with, et cetera, and everyone's really proud to say that they're up to date on their vaccination. What I always ask them is, have you gotten this most recent one that came out in the fall? And once again, this is kind of not necessarily this isn't necessarily anything that I would probably show to the community, but I would show this down here at the bottom. Most U.S. adults haven't gotten their bivalent booster. Remember, I showed you earlier, as of last week, only 85% had not gotten the updated one. And let's keep it simple. The updated booster may reduce your risk of severe COVID by 50% or more. Short and sweet and simple. So how can we get the word out to the Black community about the importance of COVID-19 vaccination? I think this is a wonderful venue by pulling together all of these, subspecialties, and then allowing us to get this word out to the community. So some of the work that we've done here in Atlanta and in Georgia is kind of thinking about the framework for mobilizing healthcare within the COVID pandemic. So we published this in probably April 2021. And what I really like to show on this is this circular collaborative partnership, because this is partnership. This is about engaging community leaders, and the biggest community leaders here that we've engaged here in Georgia are faith-based community partners who have all been in the community for how long and doing amazing work. We need to include them. Health systems collaborators, academic collaborators. So there's no hierarchy here. It is all of our responsibility. Also, if you look at the first author here, Dr. Epps is a PhD registered nurse, had already been in the community way before COVID in churches talking about dementia. So engaging people who are already within the community. Dr. Epps is right next to me in the with the pearls on. And again, this is everybody's work. PhDs, RNs, physicians, MPHs, Black, white, of all academic ranks, et cetera. This is everyone's responsibility. And with respects to inspiring COVID-19 vaccine confidence in African American and Latino communities, we published this actually earlier this year. It's not too different. Again, there's no hierarchy, but we kind of fine-tuned it a bit, including historically Black colleges and universities. Here in Atlanta, we've collaborated with Morehouse. Thinking about local and national government. Here in Atlanta, it's been wonderful working with the Latin American consulates with respects to Latino population. NIH has an NIH SEAL disparities group. I'm a part of that. We get a lot of work out. Professional medical associations, the National Hispanic Medical Association, and one of the event coordinators of this, the National Medical Association, and community-based organizations. It's all our responsibilities. How does one get that work out? One of my infectious diseases colleagues, Dr. Marcellin, addressing and inspiring vaccine confidence. Not going to go through all of these, but when we talk about increasing trust in vaccine hesitancy, this is also about access. We are, the community has to, we can't have barriers in people getting the vaccines. So mobile clinics, pop-up clinics, making sure that things are free, again, engaging community members, customizing education. Things need to be in the language of the community that you're reaching out to. Going to local radio stations. If, someone listens to this DJ every morning, involving them and getting the word out, leveraging professional organizations such as the National Medical Association. And speaking of, this made me so proud to be a part of NMA. This was just released about a week and a half ago, where NMA really put their foot down and said, this is our position statement on COVID-19 vaccines and bivalent boosters. So they were really clear that the task force on vaccine and therapeutics of the NMA is obligated to issue the following support for the current FDA-approved vaccines. The pandemic hasn't ended. We're seeing surge in cases, hospitalizations, and death. Misinformation and false statements concerning the risks associated with COVID-19 vaccine will exert a disparate negative impact on members of under-resourced Black communities where high rates of vaccine hesitancy persists. This is exactly what we need. Our U.S. National Medical Association saying we are committed, this is the right thing to do, and that we support it. So I'd like to personally thank the NMA and those on the NMA task force, because it's brought me much joy seeing this. And you got to get out in the community. This is just some of the things that we've done here in Atlanta. We have talked at churches, at schools, to historically Black fraternities and sororities. Depending on who we're talking to, you make sure that it's in English. Sometimes it's in Spanish. My colleague and I, we had a piece in the New York Times as well. So you can't just kind of walk the walk. You have to get out there and do things with the community. So the last few slides, with respect to why is COVID-19 vaccination so important to me? Honestly, I'm a Black woman. I'm a Black woman from rural Alabama, in the Southeast. Just like everyone who's listening to the call, I love my family. Here in the middle, there are 3 generations: me, my mother, and my grandmother. I want all of us to live healthy lives. This is a lot my aunts and uncles. I've seen the disproportionate impact that COVID has had on the community, including my personal family community. So it's important to me because of my family, my healthcare family. I'm an infectious diseases physician at Emory Midtown Hospital. And when we think about community, most times people think about community as outside of the healthcare system. I think it's really important that you include and make sure that you have your healthcare personnel who are being vaccinated, who can go out into the community and tell their families and loved ones. So this is me, a Black woman, holding the hand of a nurse tech, a Black woman, who is getting her COVID-19 vaccine from a Black woman. So just imagine all 3 of us are going to our communities to talk about the importance of vaccination. So increasing trust even within our own walls. And of course, getting out on the walls. This is some Emory medical students where we partnered with Fulton County Health Department to physically go out and give vaccines in places that are trusted, such as the churches. So it was important for parishioners to see us, people who look like them, and it was a wonderful opportunity for our medical students to be able to literally physically administer the vaccines. And this is about loss. Yes, we're talking about underrepresented minority population, specifically the Black population today, but we've lost over 1 million human beings, children, mothers, fathers, loved ones, sisters, et cetera. So, healthcare equity, I'm passionate about it because this little Black girl deserves to have the same care as her white counterparts there, and deserves to have her mom still living and her dad still living, and her aunties and uncles. So it is vitally important. So I hope that all of us on this call will continue to be vaccine champions. We'll really, highly recommend that our loved ones and our community are vaccinated so that we can all give COVID our best shot. So thank you very much for your time and your attention and everything that you're doing in the community.
Thank you very much, Dr. Wiley, for this great, important, and practical presentation. And I'm sure, many of us has questions regarding the presentation, because it's very deep and actually touched very practical and things that we see in our practice every day. I actually have some few questions, and I'm sure the audience also have some few questions. So basically, one of the major hurdles for vaccination is the public trust, how to increase public trust on the vaccine, and how to remove all these doubt that is casted by social media, is casted by rumors, and some of the doubts that I encounter personally when I'm practicing, some of my patients will tell me, I know somebody who had a vaccine and he got COVID. The vaccine came too fast. The vaccine has some kind of a GPS tracker. They're going to track me. Vaccine make me sick. And also from previous experience, from what happened in the past, that is still in the shadow of the mind of many people. So I want you to, if you can highlight techniques of how to counteract those kind of things, especially among the young people.
Absolutely. So what I do is I present the facts, the truth, and especially, Dr. Payne Foster and I are both in the Southeast. I am from Alabama, living in Georgia. So a lot of the mistrust is justified mistrust. So when I have a patient who is not trustful and is hesitant and et cetera, I say, you have a right to feel that way. I completely understand why you feel that way. And I am here as your doctor, as your community member, as a Black woman, to tell you the truth and answer a lot of your questions. And my job is to make sure that you that you get the answers to your questions, and I provide you with the information for you to make the best decision. And I think Dr. Gaither, someone right before us, were mentioning hey, everyone doesn't say yes the first time, and I continue to have those conversations. So telling people that you have a right to feel this way. However, you also have a right to a long, healthy life, and you have a right and a responsibility to help not just protect yourself, but to also help protect your community. So the way that I approach things is with understanding, with saying that some of these things are justified and it's okay that you feel that way, but it's my responsibility to give you the correct information and to help save you and help save your loved ones.
Great. Yeah. So basically, that is very practical. And also, I like the point that you said that we have to first agree with the patient that, this is something new. This is something that was developed quickly, not because of any bad thing, but because there was more funding, there was more technology put on it, there was more science, and there was more urgency. And the whole country came together to get this vaccine. So we can actually give the patient time to think about it. And then in the next time the patient will make up their mind, we can print materials, give it to the patient. We can show them examples from the community, people that they might know that who had the vaccine. We can use ourselves also as an example of that we got the vaccine ourselves. Yeah, so that's a very important issue. So you mentioned that you use like community leaders, like churches and stuff like that. Was that during like, was it done like virtually or was it done in person, or how was that done?
Great question. The vast majority of it, especially in kind of the depths of the pandemic, was virtually. And what I was so proud of and so appreciative of was how many pastors and preachers and parishioners who said, yes, I'm going to hold this forum. I will be on the Zoom call as well with my camera on, saying, and people, a lot of Black people, most Black people who go to church really trust your religious leaders. So rather than me coming and speaking, it was, it spoke volumes to have the pastor, et cetera, present. So most of them were virtual, but when it came to a lot of the outreach that we did at the churches, like us and the medical students, we were physically there. People were coming in to get their vaccines, and it made them feel good to see Black medical students and Black doctors there, and to answer their questions and to congratulate them on making a great decision.
Yeah, great. Actually, I just have like a last question, which is about COVID community levels. Can we share that like with the patient to ask them that they can check also the how prevalent COVID?
Yeah. And there are pages, certain areas like within the CDC website. Some of them are for healthcare personnel, but they also have wonderful sites that are literally, it says for like patient information. So yes, that can be shared as well.
Right. So I will open the floor to the audience if anyone has like questions, and I think there are some questions also in the chat.
I wonder, I think Dr. El-Bashir, the Q&A, Dr. Payne Foster and I were going to do it together at the very end.
Okay, all right, that's fine, that's fine. So with that regard, for the sake of the time, I have the honor to introduce Dr. Foster, who is a professor of community medicine and a preventive medicine expert, I could say. She has also an MPH from Columbia University. Dr. Foster has a long career in community health and preventive medicine. She has published like over 56 papers in peer-reviewed journal, and she actually has more than 400 citations. So Dr. Foster is actually an authority in the topics, and we are privileged to have her contribution here. And over to you, Dr. Foster.
Thank you so much, Dr. El-Bashir. And Dr. Wiley, thank you so much for your presentation. Mine will definitely overlap quite a bit because you talked about being from Evergreen, Alabama. I have worked since I've been here at the University of Alabama School of Medicine in primarily in the Black Belt, Alabama Black Belt. So I want to talk about two projects that we've done in that area. My husband's family is from Evergreen,
Really?
County. Yeah, so we've got some overlaps there.
Oh, yes, we do, Dr. Payne Foster.
Should I bring my slides up?
Yeah, go ahead.
Okay, wait a minute. I didn't have them up, so I've got to pull them up. I thought they were going to be here for me, but while I'm doing that, let me do NMA. The two projects I'm going to talk about are very large, multi-disciplinary projects with a lot of investigators. You would think, because I'm the only physician on the team, that's why I was put on the projects, but that's not true. The real reason is that I have had a long history of community engagement, which would turn out to be very important for COVID and doing work around COVID. So let me pull this up. Let's see. Find it, here it is. So I've entitled this Addressing Health Equity Issues with COVID-19 in Alabama. As I said, I'm going to briefly describe the two projects. One was CommuniVax, both 1.0 and 2.0, funded by the Chan Zuckerberg Initiative and the Rockefeller Foundation. And the second one is Shot on the Spot. And let me just add that, of course, I'm on the projects because of my community engagement expertise, because both of the PIs on these projects were relatively new to Alabama. And I hate to say really don't know Alabama well, especially the community well, and they certainly didn't know the rural parts of the state well. So I hope that's what I bring to the project. CommuniVax was really to investigate the equitable rollout of the vaccine, COVID-19 vaccine, and really get the local communities address around the vaccine issues and public health issues. CommuniVax was a national project. We were one of 6 sites. You can see here where they were: California, San Diego, Idaho, the DC area, Baltimore. You see the sort of brown is Alabama. So we were the only. There was a Virginia site as well, the Hampton Roads area, but we were the only really deep South project. Our team was led by Stephanie McClure, who is an anthropologist. So this project was led by anthropologists really through the lens of ethnography, an ethnographic study, which was very interesting. You see me on the right, another public health colleague on the left at University of Alabama. On the third at the top is also an anthropologist, and Bronwyn Lichtenstein is a sociologist. And we also had the luxury of 3 graduate students, so well-funded and a great approach. And you can see here our approach. We looked at 3 Black Belt counties, and I'll explain a little bit more about a map of Alabama. The Black Belt is made up of between 12 and 19 counties that run centrally from east to west across the state, predominantly African-American, predominantly rural, predominantly low, poor communities, very small, like I said, rural, some of the counties 20,000 and less. But despite that history of poverty, there's also a strong poverty of community resiliency. Of course, you know, this is the area of the bedrock of the civil rights movement in the 50s and 60s. So with that, we did environmental scans, both before the vaccine came out in December 2020, right before it came out, and then after it rolled out. We collected data from county residents, essential workers, community leaders. We did also interviews as well as social mapping, diary studies, and focus groups. And we came up with 3 basic findings. We do have a report. Everything is public on communivax.org. All the projects have reports written up on the data they collected. But the first one, of course, was vaccine hesitancy. It varied in strength throughout the work that we collected, but we definitely found that it was highest among younger people, definitely fed by misinformation and limited access to care, and reflected a variety of concerns and circumstances. And let me just add, of course, we are the state where the Tuskegee syphilis experiment happened, but that may not be as strong an issue around this COVID-19 vaccine. As Dr. Wiley talked about, there were concerns about it rolling out too fast, being developed too fast, really mistrust of not only the medical establishment, but the government as well. So those are findings we found. Secondly, you see here an Alabama football player, because you know I'm here at the University of Alabama and football is king. We found that Alabama needed to improve its public health ground game. So that's really the public health ground game. Public health efforts must reflect and respond to community needs. The message, content, and delivery must speak to the community. and the public health must have a local community presence. And we found that it was somewhat limited and exacerbated even more during this pandemic. And the third finding, which I find very fascinating, is that the community was very concerned about the pandemic recovery and its impact on education. Online education took many forms, and of course you heard stories, and it is true in the Alabama Black Belt, like many rural areas, the broadband access is horrendous. There is none in some areas. So education was stopped for some students. Parents and caregivers reported problems with content as well as student engagement because of the pandemic, and also learning losses due to emergency online education. And the biggest concern was that this is an effect that we'll probably see decades from now. So those were the three big findings. CommunityVax 2.0, a few of the projects were funded, and we were one of them. So some of our investigators left, and we added on others. We actually added on some consultants from Johns Hopkins. We added on, if you look at the bottom, the second person, with man with the bow tie, he's our vice president of community affairs. He was added to the team, and some of the other graduate students stayed on. And really what we were doing with CommunityVax 2.0 was to take a look at some of those findings and say, how can we really make some improvements? And we were really concerned about that second finding, the lack of ground game for the public health service, public health department here in Alabama, and to really take a deep dive into looking at how we could improve the whole idea of community health workers. First, to do an assessment to see where they are in Alabama, where they're located, elicit perspectives from the community on how well community health workers would be received through use of a Copewell survey, and then also identify where they are. And some of them are not necessarily called community health workers and not formally paid. The other thing we wanted to do was take our report and share it, but we also wanted to do some organizing, and some organizing was already being done even before CommunityVax 2.0 started. So we joined in with a coalition of people who were interested in really strengthening training opportunities for community health workers, a network for resource sharing amongst the group and support of community health workers, expanding the role and the need for it in the state, and making some sustainable policy issues, addressing those. So one of the issues that I did want to point out that we came across, our consultant found in Louisiana that a community health worker coalition group had pushed for legislation to reimburse community health workers through, I can't remember if it was Medicaid or Medicare, but really as a way to sustain the community health worker model, for example. So we're excited about trying to extend that work. And this is the website, as I mentioned before, communityvax.org, where we have a lot of reports and resources that people can pull down. I do want to mention that because we had a community presence, we had community members come to us with different ideas for how to really get the word out. Dr. Wiley on how to do vaccine clinics. We were approached by the West Alabama Chamber of Commerce to do some worksite vaccination clinics. So we did perform some of those. It's interesting. We went to one lumber site in Tuscaloosa County, Moundville, and the employer was giving large incentives, $500 incentives for people to come and get vaccinated, trips, time off trips, things like that, and still a push. There's still some hesitancy. But we were able to kind of see that and kind of help and assist with some worksite clinics. out in the community. The second project, Shot on the Spot, sort of talks about what Dr. Wiley was saying, taking the clinics out to where the people are. This was a HRSA funded grant. Our project was led by, I do have a picture here of the research team, led by He Lee, who is in the Department of Social Work. But you see here, we had a wide range of professor in nursing, communicative disorders, hearing disorders, and in psychology. And really the purpose of the project was to increase the vaccination rate from a mean of 30% across 18 Black Belt counties to up to 70%. That was our goal. Using a variety of different techniques, education, of course, taking the shot on the spot directly to communities, using co-trained community health workers, and providing the vaccines via a mobile van truck to really get to hard to reach rural areas. We have here, we had at the center of this project, and the only way that it could be successful was to have a community-based organization lead the efforts. We were just there to assist them. This is Loretta Webb Wilson, who is the director of the Rural Alabama Prevention Center. She's also director of a rural hospital in Sumter County, Hill Hospital. So they did the work. They had a staff of people who did the vaccinations. They also contracted with nurses in some of the rural areas before we went in to give the shots, and also contracted with community organizations to get the word out about the vaccination clinics. So I just really want to highlight her. And this is, she got a community star from HRSA for the work that she did. And this is just a graph of the Alabama Black Belt, the 18 counties we worked in. If you see Butler County, where Dr. Wiley talked about being from, on there's in pink, evergreen. And then, we are closer to the West Alabama counties, but we definitely work those areas a lot more than some of the East counties, but we were able to get out to all of them. This is the mobile van that was used. This is a hearing van. We also added that service into the vaccination clinics, which people loved, getting hearing screenings. And this is our achievement thus far. Since August 2021, the project has completed more than 50 COVID-19 vaccination pop-up clinics in 16 counties of the Black Belt areas. Two of the counties we were not able to really get into. And as of November, we've given about 58 first and second vaccine doses and 673 boosters, 731 doses in total, resulting in 51% fully vaccinated among Black Belt residents. Of course, our numbers for first vaccinations are higher, as high as 80% and 50% in some counties. But of course, our goal is to try to get everybody fully vaccinated. These numbers may look low, but remember, we're talking about really small counties and small populations. So I think we did a pretty good job. And we always celebrated those who were first time vaccines for sure. And this is just a summary. The vaccination rates have doubled in the Black Belt since the project was launched in July 2021. 8 of Alabama's top 10 most vaccinated counties are in the Black Belt. Of course, due to the high vaccination rate among majority minority Black Belt counties, they did not have as much of an issue around the Omicron surge. They had lower COVID positivity and mortality rates, while the reverse was, held for other less vaccinated non-Black Belt rural counties. And this may speak really to the successes of some of the CBPR approaches that we used. And these are just some pictures of us out in the field doing and being led by RAPSI to do the work. I just wanted to throw in this last barriers again. We did do some focus groups. Dr. Lee, the PI on this grant, conducted 5 focus groups around. She talked to healthcare professionals and community members about some of the barriers. And as you see here, they're very similar to what we found in CommuniVax. but add to our knowledge. Lack of vaccine literacy is a big one. People really just not understanding how vaccines work, long distances to vaccine sites, lack of public transportation, which is major in Alabama and is particularly in the rural areas, concerns about side effects, fear of insufficient vaccines in rural areas, and vaccine hesitancy, of course, around systemic racism and discrimination rooted in the U.S. healthcare system. So I just wanted to throw that one in. And that's my email there if anyone wants to get in contact with me about any of those projects.
Thank you so much, Dr. Foster, for this great work that you did in Alabama. And actually, I wanted to congratulate you in two things. Number one is actually bringing public and private organizations to support community work, which is, I know, it is not an easy task to do.
Can I add one thing, Dr. Elsie?
Go ahead.
Before we start with the question and answers. We were also approached by funeral home directors in Macon County in Tuskegee. Because if you think about it, they're sort of first line for COVID. They see COVID deaths. And often in healthcare, we don't think about them as being a messenger and getting education. So they approached us about doing a project where we would really do some follow-up either at the wake or after the funeral, and even doing pop-up clinics at the funeral. The idea went forward. It never really came to fruition, but I think it's a wonderful idea and a concept that somebody else should really kind of pick up on. I just want to do that.
Yeah. So actually, this very important point that you made is to take actually the care to the public, like to go to the rural areas because of lack of transportation, because of all the logistics stuff. I think this was like a model that has to be copied in other communities. And we would like to see funding coming to community health workers. We have community health workers intermittently in our hospital, but because of lack of fund, they are not like consistent. So this is a very important work you did for allowing the Medicaid to fund the community health workers. And I will like to start with Q&A. And Dr. Wiley, do you want to take in any of the questions?
So I've been answering a lot of the questions directly in the chat. Some of the questions that have come up are about the Novavax booster, and I want to try to answer a few things because my battery is dying and I'm at work and I forgot to bring my charger, so I may go off in literally in 2 seconds. So with respects to the Novavax booster, some of the questions were, is the Novavax booster more or as effective as the bivalent boosters? The answer is they're not. So the only time that I would recommend a Novavax booster to a patient is if the patient says, I don't want a Pfizer or a Moderna booster. And the reason is the updated bivalent Moderna and Pfizer booster are active against the variants, okay? The Novavax booster, not as much. Another question was, someone said that they thought that Johnson & Johnson was not available at all anymore. It is available only in a few situations. One, if the patient has had a severe life-threatening reaction to a messenger RNA vaccine, okay? Two, if the patient says, I don't want a Novavax for whatever reason. Or number three, if the patient says, I know about the possible side effects like TTP, et cetera, and I'm willing to take the risks, I want Johnson & Johnson because I only want one shot. So I have not recommended Johnson & Johnson for anyone, honestly, probably in 2 years, because we have Pfizer and Moderna and Novavax. But is it still available? Yes, you can still get it, but only in a few settings.
And can I follow up on that? That's a great
Yes.
point, Dr. Wiley, but in the field, there are a lot of people who are hesitant to getting shots, period. And so the option of a one shot is better than 2 or 3 or whatever. So
Totally agree.
we have all of them available because we find that it surprises me even that so many people are afraid to get shots.
Excellent point, Dr. Payne.
Yeah, but your points about the really assessing and seeing where the patient is and which one would fit best for them is a great one.
And there was another great question / comments saying, hey, should we offer the bivalent boosters for high-risk patients who are in the hospital, like an older person or someone with sickle cell, et cetera? The answer is heck yes. However, all hospitals, all institutions don't have the bivalent vaccines in the hospital or on formulary. So if your hospital is one of those, yes, great time to go ahead and get people boosted before they leave. And another question was, does one have to wait after their patient has received monoclonal antibodies to take the booster? The answer is no. Please give them the booster, the bivalent boosters as soon as possible. And another one of the questions that was raised was, if a person has just had COVID, how long should they or can they wait before they get their updated booster? It's my understanding that right now we're saying 3 months. But honestly, if I have someone in clinic in 2 months and they're just like, I'm going out of the country, I want my booster, and it's like now, I'm going to give them the bivalent booster then.
And another follow-up to your point, Dr. Wiley, the hospital should have the bivalent vaccine if we have it out in the field. You know what I mean? So we should really be pushing that. I know the herd immunity is a mixture of all the vaccines, including the bivalent, but as much as we can push the bivalent one, we should be doing that.
Great. Somebody is actually just like asking if you can highlight the post holiday infection rate.
Yeah, and if I knew the answer to that, I'd be a special woman. So fabulous question. So the question is, do we have any estimates or predictions on when we're going to have peak COVID infection rates after the holidays? I don't know the answer to that.
Dr. Foster, can you just like give us just a tip of how to replicate your programs in other states?
I tell you, HRSA is really looking to fund similar programs in other parts of the country. Okay. So look for funding. That second grant was a $1 million grant, which really helps to fund people in the community to do the work. And our subcontractor, RAPSI, got quite a bit of that money. They're still waiting on it from the university, but supposed to get it. I think going after funding, but RAPSI was doing work before COVID. They had some funding, but they've always done voluntary. They're a nonprofit, so they operate anyway, and the community wants to operate anyway, regardless of if they get funding or not. But of course, once RAPSI has had a history of getting funding, so now it gets easier and easier for them. And I did forget to say that before COVID hit, I brought together 5 really strong community-based organizations in the Black Belt, and we called it the Black Belt Collective. And that was for us to really have a stronger impact when we went after funding, trying to come together for going after funding. So that now it's not easy. Although those organizations love to work on their own. They really don't want to mix and match. Sometimes the missions are a little different. We have one really strong mental health organization. He really didn't want anything to do with, we went after a big health equity grant. So trying to kind of merge missions. But the idea of, and I did that before COVID, And it was just invaluable when COVID hit, because then we sort of had that relationship already. So I think Dr. Wiley even inferred that, you know, getting the relationships going before the funding is probably a way to build trust and move projects forward.
Great. We'll like to go into the question. Solomon, can you put the question on after our speakers has hammered the topic, so we expect like everyone to answer the question correctly. Yeah, the question, so please try to attempt the questions.
Oh, wow.
Has everyone attempted the questions? Solomon, can you like post the outcome? Great. Great. So with that, I would like to first thank the NMA for giving us the opportunity to present this topic that is impacting our community at this crucial time. I would also like to thank our expert, Dr. Wiley, Dr. Foster. I would like to thank Dr. Yutupi for the great organization, Dr. Solomon for the great production of the presentation. And I will like to thank our audience for all the questions and participation and for making this presentation as lively as it was. And I hope that we will, our paths will cross soon to highlight some of the new challenges in this regard. And thank you very much, everyone.
Thanks, everyone.
Thank you.
Good afternoon.
Good afternoon.
This is Dr. Jordan.
Hi, Dr. Jordan, how are you?
I'm good. How are you?
Good.
And I see Dr. Jefferson is on.
Dr. Jordan, you guys can begin.
Yeah, I'm the co-host. I'm going to introduce Dr. Jefferson. I have a few slides depending on if he goes over or not. He's going to make the presentation. Dr. Jefferson, are you here? I saw your name earlier, so. I see Dr. Ronald Jefferson. I'm not sure he's sitting at the.
I'm here.
Okay, you're here. Good. All right. Dr. Jefferson is the primary HIV provider at the Oasis Clinic, which is an HIV clinic in Los Angeles that was founded in 1984. He's been with me since then. So there's very few people in this country, black or white, that knows more about HIV than him, and he's going to speak to us about HIV and COVID. So, Dr. Jefferson, take it over.
Thank you, Wilbur. Can I have the first slide, Solomon? Hello.
Send to your slide, Dr. Jefferson. Can you see it?
Yeah, okay. All right, here we go. The first slide. You know, this is the third year of the pandemic with the coronavirus. I remember when the virus first hit, I actually was in India, just coming back from India. And within 2 weeks of me coming back, I remember it was now a pandemic with world wide problems that were going to happen shortly. So let's just go back a little bit and talk about the coronavirus. There are about 4 common coronavirus species. Next slide, please.
Dr. Jefferson, you're on mute.
Okay, can we go back now? Okay, SARS. This was first discovered in China again in 2002. And we had about 8,000 cases in 29 countries and about 774 people who died from this. In the US, about 27 confirmed cases, but no one died. This was a horseshoe-like bat, looked like a cat. Then it went to a cat-like mammal, and then from there to humans, and after that, from human to human. What happened again?
On mute.
Then we had Middle Eastern respiratory syndrome. This was thought to come from infected camel, from a camel to a human bite, and once it got in humans, from human to human. This was approximately, this first was discovered in Saudi Arabia. And in about a 6-7 year period, there were about 2,500 cases in 27 countries and about 858 people who died from it. And 2014, there are thought to be 2 cases in the US, both one in India, Indiana, and one in Florida. But both of these cases were healthcare workers who had recently come from Saudi Arabia. Next slide.
Mm-hmm. Are you on mute again?
The slide before this one?
No.
Before here?
Yeah.
Okay, next one after here. Okay, then in Wuhan, China, in fall of 2019, roughly the last week in December, we started hearing about a new viral infection. It was thought to be originated from this, what they call a wet market in China. In a wet market, you can get any kind of a wild animal you want, and people would eat it. And they thought there were some thoughts that this came, well, this was the origin of the virus. Although no one else believes that. I don't think. Can I have that slide again, please? It was thought that COVID-19 originated with a bat, and from this bat, it would maybe infect this other mammal called pangolin. Then that would go to humans, and then from human to human. It began with fever, cough, pneumonia. Initially, again, they thought that this virus came from seafood and other animals in this wet market. By January 2020, it was identified as a new coronavirus, and by January 30th of the same year, the World Health Organization deemed it a public health emergency. And by March 11th of 2020, just under 3 years ago, the World Health Organization deemed it a pandemic. Now let's look at the spread of this disease. Again, just do a little review. If you look at the very top, the stage and severity, asymptomatic or pre-symptomatic, okay, at that time you may test positive for the virus, but for the most part, you feel pretty healthy. After that, you might have a mild illness, just a slight sore throat, slight cough. You might get some changes in your taste or smell, but no dyspnea, no fever. Then from there, it went to moderate illness, but your O2 sat by definition would be greater than 94%, and you may have some lower respiratory tract disease. Then after that, if you got worse, it'd be severe illness where your O2 sat was less than 94%, respiratory rate may be more than 30, and about half the cases, chest X-ray shows bilateral infiltrates. And this is a very critical stage of the infection. Now, if you look at the middle one, disease pathogenesis, viral replication goes from asymptomatic to mild illness and stays at about the same rate. At the same time, if you look at the red, inflammation starts to go way up with this disease. The sicker you go along the spectrum, the more inflammation you're going to see. And as a result of the inflammation, we should see, or you still see, hypercoagulability. In fact, when the disease first started, one of the treatments for hospitalized patients for COVID was to give heparin. Now we have antiretroviral therapy, antibiotic therapy. Next slide, please. Next slide, please. Skip that one and that one. Oh, go back one. Go back one, please. Yeah. Before about a year ago, a little over a year ago, one of the variants of COVID-19 that we were starting to see a lot of was Omicron. And we had a huge surge in Omicron infections. Luckily, the vaccines we had at that time were still effective in most cases against the Omicron virus. So it surged and then it went down. And right now, the proportion of cases due to Omicron has been going down. Next slide, please. Now, with this Omicron variant, as with any variant of this virus, there are some prevention strategies that have to be done to fight this virus. The number one is still vaccination. It is critical that our patients be vaccinated against this virus, no matter whether it's Pfizer or Moderna. One should be vaccinated, and not only vaccinated, but the importance of booster therapy should also be explained to patients. Again, we have to emphasize masking, how important it is to mask. And even though now we don't see as many people with masks, it's still important that we really emphasize the importance of wearing masks. And also, frequent testing for COVID should be encouraged. A lot of drugstores were giving out free COVID testing kits. And we're giving out free COVID testing kits. Next slide deck, please. Now let's look at this, the current state of the HIV pandemic. If you look at this chart here, the number of cases of HIV based upon the population, look at the green. California, Texas, Illinois, then Florida, and Georgia, and then the Northeast. This is where the majority of cases of HIV are in this country. Now, if you look, next slide, please. Now look at the COVID and HIV, the individual. Okay, next one, please. The question we have asked at the beginning of this epidemic and still are people with HIV at a higher risk for more severe outcomes if they do become infected with the COVID virus? Or could people with HIV have worse outcomes with COVID-19? Okay, theoretically though, yeah, they may, because people with HIV, especially HIV patients with T cell counts less than 200, do have an increased risk for acute respiratory distress syndrome and other viral infections. However, it was not clear that immunosuppression in and of itself would be an increased risk for severe COVID. Also, we did know that people with HIV did have increased frequency of some of the known risk factors associated with severe COVID. For instance, more than half of the patients with HIV now are aged greater than 50. And as we all know, people greater than 50 have a higher incidence of severe COVID. People with HIV, because they are over 50, they do have a higher rate of cardiovascular disease and pulmonary disease. And also, our patients do have a higher rate of poverty and marginal housing. All these things would really increase your chances of having severe COVID. Next slide, please. Then another question people asked was, could people with HIV have better outcomes with COVID-19? Well, theoretically, yes, because one of the major drugs used at that time was Truvada, and it was thought that Truvada could inhibit one of the enzymes responsible for SARS-2 to replicate. So there was one study done in Spain, plus hydrochloroquine plus placebo, plus or versus boosted atazanavir. This really study didn't go any place. It did not show that there was any utility for using any of these HIV drugs to fight the COVID vaccine. I'm sorry, the COVID virus. Next slide, please. Can you get Dr. Jordan out the way? Okay. Next slide, please. Skip that one. Go back to that. Go back one, please. Okay, one of the questions asked again, they looked at people who did have the coronavirus in New York City. How many or what proportion of them also had HIV? Next slide. Okay, well, the conclusion they made over there was that people in New York City who did have COVID or HIV, there was no increased incidence of people with HIV having more severe care COVID, and that people with HIV who also had COVID had the same characteristic symptoms as people with COVID without HIV. Next slide, Dad. Next slide, please. I'm sorry, one before that. Before that, please. I'm sorry, go back. Go down to, sorry. Go down. Go down, keep going down. Down, please. Down. Go back the other way, Keep going the other way. Keep going, please. Keep going. Keep going. Okay, go back, go back, go back one. I think we're there. Go back one. Okay, now go back the other way. Go back one more. Go back one more. Go back. I'm sorry, you're going the wrong way. Go the other way. Other way. Other way. Okay, let me go here. Okay, we'll look here. Okay, then they also looked at the crude risk of COVID-19 death based upon HIV and also people with HIV with COVID and comorbid conditions. So let's look here. They looked at age and sex.
So undiagnosed, no,
Wait a minute.
unadjusted was on the line.
I'm trying to get this thing here.
That's age
Okay.
and sex.
So they looked at unadjusted, okay? And then they looked based upon age. Basically, for every 10-year increase in your age, you do have a higher susceptibility of having severe COVID. Now let's look also. Also, it looks as though males had a slight increased chance of having COVID or severe COVID than females. And if you look at ethnicity, Blacks had a much higher rate of COVID and severe COVID than other ethnic groups. Okay, next slide, please. Next slide, please. Now, there was one study which was done in South Africa where they want to also look at, do people with HIV have a higher rate of severe COVID or people dying from COVID? So they looked at South Africa. They looked at their database. So please go next slide. Next slide. And they looked at the risk factors for people who were dying from COVID in South Africa. Okay, so the biggest risk factors was age. If you look at age from 40 to 49 compared to the next 10-year gap, 50 to 59, you get a major increase in the rate of people with severe COVID or dying. The next one was diabetes. People with diabetes with a higher hemoglobin A1C have a greater chances of severe COVID or dying from COVID. Also, people with a previous diagnosis of tuberculosis or current tuberculosis had a higher incidence of people with severe COVID or dying. However, they did look at the HIV positive cases, and in the South African database, it looked as though the HIV positive cases with COVID did have worse outcomes. This was a database, and this was not, this hasn't been verified in any other places that I know of. Next slide, please. They also looked at the risk by HIV condition among hospitalized patients. They looked at the HIV status. Okay, looked at the HIV uninfected. That's the relative risk of 1.0. Now, HIV infected patients had a 45% greater risk of severe COVID of patients who were hospitalized. And of that group, the ones with the lower T cell count had increased rate of severe COVID. Next slide, Deck. Next slide, please. The overall conclusion was that HIV in and of itself does not increase the susceptibility to COVID-19 or lead to severe outcomes. Next slide. Next slide. Okay, slide, no, right there. Go back, I'm sorry. So there's no current evidence that people with HIV are more likely to contract COVID than other non-HIV infected populations, or that they're going to have a more severe outcome. However, it may appear that people with HIV who do have the lower CD4 cell counts are at an increased risk of having a higher rate of severe COVID or dying. Next slide, please. The NIH interim guideline for COVID-19 people and people with HIV, the guideline is that people with HIV who have COVID-19 have an excellent prognosis and they should be clinically managed the same as people in the general population with COVID-19, including when making medical triage determinations. Okay. Some people with HIV and other comorbid conditions like cardiovascular disease or lung disease may have an increased risk for more severe COVID. Okay, next slide, please. Okay, let's just go ahead, next one. One question we always did want to know is, do people with HIV respond similar to COVID-19 vaccines? Next one. Okay, next one. Go back once more. The answer to that question was yes. Black people respond just the same as everyone else. And there were lots, thousands and hundreds of thousands of participants in studies which kind of looked at that. Let's look at this one here. Next one, please. Or let's just go back to boost. Go back, next one. Next one. Let's look at boosters, okay? When the disease first started and we first got the first vaccines, remember the Johnson & Johnson, J&J, you got one dose, you had to wait at least 2 months and then you may get a booster dose. But this was only required at that time to have one shot. Then we got the primary series, Pfizer or Moderna. Pfizer, you got one dose, day 1, your second dose, day 21, at least 5 months later, got a booster. And the Moderna, you got one day 1, a second dose, day 28, and then a booster at least 5 months. And this has changed, as you know, over the past several months and year. Now it's recommended, it's going to be a minimum of 3 doses. Now, elderly patients over 50 may have had up to 5. Initially, you got the first dose of Moderna, Pfizer, then you got your second dose, and then 5 or 6 months later, you got the booster. Then it was recommended that if you're over 50, to get another booster because you're getting faded immunity. Then we start getting these new variants, so it suggests that you even get a 5th one. So a lot of your elderly patients are going to have 4 or 5 shots altogether. Next slide, please. Go to the next one, please. Next one. Next one. Okay. One problem we've had when this pandemic started was trying to get people of color, especially vaccinated. There, a lot of Black people, brown people, very hesitant in getting these vaccines. A lot of it in the Black community had something to do with some of the older studies, the Tuskegee study, which is still on the mind of lots of Black people. So there are a lot of fear of these vaccines being used. So this was a problem that we had initially. But now we know it is very important that this COVID vaccination is very essential for people living with AIDS, just as essential as with people with non-HIV. Now, people with HIV, the majority of cases, they do well. They do respond both to production of humoral and cellular immune response to vaccines. Next slide, please. Okay, let's look at some of the treatments we have available now. Okay, now we have, let me go to the one we're using the most. The first one here is Paxlovid. This is an oral medication. You take 3 pills twice a day for 5 days. This particular drug has 100 milligrams of Norvir in it. Now, this drug is an oral drug. Generally, you start within 5 days of having symptoms. Symptoms of like upper respiratory tract, a loss of taste or smell, fatigue, or fever. It's reserved for patients 12 years or older and weighing at least 40 kilos. Again, 3 pills twice a day for 5 days. Now you compare it to placebo, the relative risk reduction was 99% reduction in hospitalization or people dying compared to placebo. And it was very effective against the Delta and Omicron. So this was the drug we mainly use and have used as outpatient therapy. Now, for people who are sicker people who are hospitalized, generally we've used remdesivir, 200 milligrams IV day 1, 100 milligrams day 2 and 3 for a total of 5 days. This is given intravenously. Now, this drug is FDA approved in 12 years or older, weighing at least 40 kilograms. Generally, you start using it as soon as possible, but within 7 days of symptom onset. And again, the reduction rate is an 87% reduction in hospitalizations or people who are dying. And this was effective again against the Delta and Omicron. Okay, this is what we had used for the sicker patients. Now, the one that up here, molnupiravir, this was not used. Used 800 milligrams twice for 5 days. It was only effective in about 30% of cases. So this was something that we really had not used. Next one, please. So let's go look at the treatment options again. The first one is Paxlovid, 3 pills twice a day for 5 days, 88% reduction in people dying or hospitalizations. Then from there is a very good IV treatment, okay? And that one, it's a monoclonal antibody treatment. And you use an IV, 1 HIV infusion followed by hours of observation. This wasn't used that much by where I was because we just didn't have it. The one that was mainly used was remdesivir. Again, you take it IV for 3 consecutive days, and that did have a reduction rate for severe severe outcomes or dying, 87%. So this was used, and this was very effective. Next one, please. Next slide, please. Now, mainly right now, if you do the priority for treatment for this now is the first one, which is Paxlovid. Okay, as mentioned, it's 3 pills twice for 5 days, or that you can use an IV one time, 500 milligrams, or for patients who are hospitalized, remdesivir, you're going to use an IV for 3 consecutive days. Again, that's going to reduce that proportion of patients dying or having the severe outcomes by 87%. The one we weren't using was molnupiravir because it only had a 30% effectiveness. Okay, next slide.
Yeah. Do we know what percent of hospitals have Bob?
No, I don't, because I know where we didn't have it.
That's something the NMA should look at, particularly in the southeast.
Yeah, because it's just one time. Okay. Next slide, please. Okay, again, for the Omicron or the newer ones, the prior authorization for treatment remains the same. The first 3 that we mentioned already. Next slide, please.
That's the end of your slide.
Next one. Okay. Now, okay, thank you. Now, what's happening recently now, there's a new subvariant of this COVID variant of the COVID virus out there now. The new variant has really went from 4% until about 2 weeks later, 40% is probably now more than 50% of the newer cases. It appears this new subvariant is much more contagious than the other ones, but it's probably not more virulent. In other words, it does not look like it's going to lead to more severe cases or more chances of people dying from it. Whether or not the vaccines are going to be as effective against this new variant, I'm not sure. It may not be as, but time will tell us. Okay, any questions now? Okay, here I am. Okay, any questions now?
Well, my question I have is really for the NMA staff. We need to ask, do we want to know the availability of these in hospitals, particularly in the Southeast, where there's the majority of the people who get sick, infected are going to be Black, and then doing any good if you don't have the drugs there.
No, yeah, I agree. So the ones
that can't be done here, but that's something,
yeah,
NMA
so,
office we need to do.
Okay, I can agree with that. Okay, any other question? I think one thing I hope everybody understands is that this COVID vaccine, I mean, this COVID virus is not over. It doesn't look like it's going to be over. The problem we're going to have is what we always thought, the ones of us who've treated HIV, is that the virus is going to mutate. Sooner or later, it's got to mutate to a form that's much less able to overcome vaccines and some of the current drugs. It's going to be here and it may get worse, but for now, it's still going to be important for yes, still get vaccinated, but also wear your mask, okay? Try to social distance as much as possible. Don't go to work sick, and frequently check yourself if you're having any symptoms, because it's going to be here for a while longer. Okay, Dr. Jordan, anybody else?
Yeah, I think we need to realize it is not going away, and we need to be doing things to really reach people more.
Yeah,
I'm thinking about nearly every doctor who's on here is in a city that has an SNMA chapter. And I really think NMA and SNMA need to work closer in getting people tested and being made aware. Because I've had several patients come in 2022. You want to ask, were you sleeping with Rip Van Winkle? Because they're just, to me, there are just some things, particularly when you're in a city. I guess I don't know if I'm being racist or what, but I guess if you're in rural Mississippi or Arkansas, I can think you can have some ridiculous thoughts or be way behind in time. I just find it very hard to believe you're in Los Angeles or Memphis or Nashville, and you don't have any idea what's going on. And I'm seeing patients like that, and that's me been very, very frustrating, period. Do you have my slides now? Okay. Important. I've had 3 patients come in and 2 from phone consult. A lot of people who are HIV positive, not in treatment, are not in treatment because they wish to not be in treatment. So now because of COVID, then they got scared and they come back wanting either some medicine or the vaccine. But this is just to address the HIV part. If someone hasn't been to see you for over 6 months, then get another T-cell count and they're viral load. You as a provider need to know that, because I'm stereotyping. If they haven't been in, then more than likely they haven't been taking their medicine. They have been doing other things. So I think it's important to cover yourself. So next slide. So, I'm really not talking so much about HIV as I am the immune reconstitution of the RNA virus. It is a protein molecule covered by a protective layer of lipid, which when absorbed by cells of the eye, buccal mucosa, causes their genetic code to mutate and converts them into an aggressive cell that multiplies. It is more of a protein molecule that disintegrates rather than be killed. Next. Iris was first recognized in patients treated for tuberculosis and leprosy in the 1980s. I remember that, unfortunately. It was later associated with HIV/AIDS therapy, especially in new infections with low CD4 counts. We saw that in India and we saw it in Nigeria. It is a state of hyper-response that occurs within the first 6 months of therapy of HIV/AIDS patients. So right now I'm focusing on this HIV/AIDS patient. The overall incidence is really unknown. The lower the CD4 count at treatment initiation, the greater the chance of getting it. So basically, if someone comes in, has been lost, hold on to follow up, have a low CD4 count. I have a young lady right now, her CD4 count is 2. And I'm walking on fractured glass with her because we finally, after over a year with her mental health therapist, we finally got her to agree to take treatment. So with a CD4 count of 2, you're expecting her to show some sign. Her viral load is over 1 million. So we are hoping she will improve. But we have her come back to the office 3 times a week to give her a shot. I mean, she's just out there with that. So you want to make sure you know the patient's CD4 count, their viral load, and you monitor because they can get sore throat, swelling in the throat, enlarged lymph nodes around the neck and throat and in the mouth, fever, chills, shortness of breath. And this really had nothing to do with COVID. It has to do with them having an immune response because their immune system was so washed out that they weren't able to respond. And now that they're finally taking medicine, they're able to respond. So the number of patients that you get like that is going to be very, very few, but just be aware of that, particularly in someone who has been lost to follow up or who has not been coming in to be seen. Next. An example, a patient lost to follow up, last seen in 2021, now wants the vaccine. Now I've had several come in on the vaccine. Are you taking your HIV medicine? I've been busy. Too busy doing what? And you know, if you're treating HIV patients, some of you know, for some pharmacists, it's big business. So they will go someplace to get other things and not really thinking about the meds. But so my message for you is draw your labs to make sure you have a recent CD4 count and a recent viral load. Again, this to help you gauge how they may respond to the HIV medicine, not so much the COVID. But the COVID part is easy. You give them a vaccine, you give them treatment. But this is the part where I'm finding lately some patients, not that many, thank God, but they're still out there. Next. So my question, the patient has not been seen for 8 months. Do you draw a CD4? Yes, you can vaccinate. There's no reason to not vaccinate someone. But when someone comes in, make sure you draw a recent CD4, which is a T cell count, and a viral load, the PCR. You want to have the latest data because if they have been out that long. Now, it's harder to speak for Mississippi and Tennessee, but in California, there's no reason to not come in. You can get your medicine. And if you don't have insurance, you can get your medicine. So anyone, particularly in Los Angeles County, they can get their medicines. So when people get lost to follow up, it's because of other things. Most times it is drugs. And I'm not speaking for or against it, it's just that's their life situation. But if someone comes into your office, draw a CD4 count. If you do not know how to draw it, call the NMA office and have them call me. We'll be happy to tell you how to do it. But I think it's important. Just don't let them leave with the vaccination and nothing else too. This can help save someone's life as well. Is there one more slide? I think that's it. Okay. Any questions for me or Dr. Jefferson?
Dr. Judy, there are some questions in the Q&A. If we check the Q&A box, there are some questions there.
I don't see no Q&A box. No.
Right at the bottom of your
I
Zoom.
see it. I see it.
Okay.
I prefer Paxlovid if possible, but you need to get it earlier.
Are you talking about now? Wait. What's the question, Wilbur?
Remdesivir like Paxlovid have recently been utilized to treat COVID-19 patients, non-hospitalized with mild or moderate disease with chronic medical conditions who are at high risk to progress to severe complications. Do you prefer Paxlovid, which is oral, or Remdesivir, which is 3-day IV infusion? I mean, to me, I look at Remdesivir as being the patient who needs Remdesivir is sicker than the patient who needs Paxlovid. So they're two separate things altogether. I would prefer to be able to treat the patient with Paxlovid. They can go home, take it, etc. It is, again, depending on where you are, not convenient having to have someone come back to get an IV infusion. And many hospitals don't have it. That's something we need to look at. So I would rather have the patient come in when he or she is healthy enough to be able to manage themselves by taking pills. Remdesivir is now an IV, and that means, well, let's just say if it's in Compton, it means me and my staff have to know how to give it, how to get it, and they've got to come back. And how many of you have patients who don't come back for the second or third dose of something if they're feeling better? So I'm not sure that's the right question, but I would rather have it be Paxlovid. Someone come, and again, that's why community education is important. This will not necessarily go away. And if the person is really has been exposed and is sick, they need to come in. And we have had too many patients who try to play it off, or I'll wait till tomorrow, I'm not going to do it. That is not going to work. What is your response to those concerned about cumulative effect of the vaccine? I'm not that concerned. I worked in India, smallpox eradication. I worked in Nigeria. I stood in line as a kid to get my smallpox vaccine. If the man wants to kill us, there are better ways and easier ways to do it. I think that's just not the way. We need to be more involved in our healthcare and doing things and making sure people in our community take advantage. Now, when someone comes up and says, all Black folks in this line, all white folks in this line, all Asians in this line, then I'm gonna get concerned. I mean, we've gone through a time when I was a kid and Dr. Jefferson was a kid. When we got our smallpox vaccination, there wasn't a white face around. And they separated us, they segregated us by the schools. We were in segregated schools. So there have been times that they wanted to do that. To me, people have had a chance. If they want to, they know which Coke you buy and which RC I drink. So all that information is out there. I personally think we spend too much time being paranoid about some things rather than enjoying life, period. Next. Any other question? Dr. Jefferson, you might be quiet.
No, I'm just listening. I've agreed to everything you've said so far, particularly with the Paxlovid and in favor of remdesivir. When it's possible, give it PO. That's what I've always done. And another thing, with Paxlovid, it works incredibly quick. You give someone.
It does. I took it, and it worked. I was amazed. I could tell, damn, this stuff is really working. So, but I think there are some of us who not take. I don't know if we're angry or what, but we're just not trusting. But we're not trusting. But we would go out in the park at night and shoot up with somebody we don't know. I mean, it's sort of like, wait a minute, you don't trust them because of A, B, and C, but then you would do, K, J, and F, which makes no sense. If I was not trusting, I wouldn't be doing anything. But you went out, I mean, look at the number of people who got monkeypox going in the park, going to the bathhouses. So you didn't trust folks, for one thing, but monkeypox told on you. You did something else and you got monkeypox. So you don't mind putting your mouth certain places, stretching your butt certain places, etc. But then on the other hand, you'll be straight talking in church on Sunday morning. This is BS, period. But I think we have to just deal with that. Some people, there is a paranoia, but I had to speak at Centennial when they first started this. They wanted some of the doctors to talk to the kids at the Centennial High School about the vaccine. And I spoke to the honors class. No one, not one student wanted to take the vaccine. It's all Black honors class. And I asked, why not? They try and do a Tuskegee on us. So how many of you believe that? The whole class raised their hand. I said, okay, take out a pencil and piece of paper. Write down what was Tuskegee. And now one person in the class knew what Tuskegee was. I said, if you're going to use Tuskegee as an example, they get off your lazy butts and at least learn, find out what it was. Because none of you really know. I mean, it's easy, and I really get frustrated when I hear Black people saying they can do a Tuskegee or mention Tuskegee, when in fact, they have no idea of what Tuskegee was. I just told the class, I don't like the N-word. I find it's disgusting. And all of you just call me the N-word. And they had no idea what I was talking about. I said, do you understand? And when Tuskegee occurred, the white man didn't need permission to do anything. I lost 2 classmates because they did experimental procedures on them without telling the families. That's the way it was then. If anything, Tuskegee has helped prevent those kinds of things happening. Now, so when you all just say doing a Tuskegee, you're saying they can do anything they want to do to us. And we, all of us who spent time going to medical school, etc., have no power. That's really insulting. And we had a nice discussion afterwards, but it was like, you all haven't been reading enough about your history. You don't know enough about what it was like. And watching some stupid movie is not going to tell you really what it was like. It was more than just Emmett Till allegedly whistling at someone. People could walk into your house then and take your stuff, rape your mom, and do whatever. And there wasn't a damn thing you could do about it. Things have changed. So don't come tell me it ain't no different now than it was then. It's a hell of a lot different than it was then. But too often, our kids don't know. And we don't have a discussion, our forum for them to learn and to appreciate how far we've come. Yes, we have a further distance to go, but it ain't nearly like it once was, period. Anyway, I get off my stumping block. Any questions you have, Dr. Jeff? Comments you have, Ron?
Yeah, no, I've agreed with what you said. One thing that I want to make sure everybody understands is quite important is that when you hear about what's happening with the CDC and what the feds are doing, it's really important that it's going to be other pandemics, it's going to be other viruses out there that's going to be more deadly than this one. But hopefully this is like dress rehearsal. So when one that does come out that's more virulent, that has a 10% mortality as opposed to 1%, that they'll be able to really act on it quickly. We did get vaccines made pretty quickly. They were made quickly, but they were also made in a good scientific way and I thought they were done in a way in which I was pretty convinced that they were safe, and I have remained that. So it's important that we know that the CDC are getting what they need for research and development for new antivirals and vaccines. Okay, that's all.
Thank you for that. One of the women who created the COVID vaccine is a former student of ours, is Mizia, and I think that's important. And there's an irony in that if you look at nearly all the other vaccines that we have had to deal with, period, there have been many, there have been checks and balances. But for most, there were, whatever the committees were, or the authority were, etc., they were all non-Black. This is the first time that every committee, every committee has a Black face on it. And we were worried about it. It's like, this is the one time we should be able to go to sleep and rest because there's someone there looking out for us more than ever before. And I think there'll be more in the future. But I think it calls for us to realize either we're part of the country and we raise our hand to participate, I get on the boat and go back to Liberia. I have no desire to go back to any place. I'm an American. I'm the only thing that can say they're more American than me are Native American Indians. I give them that, but we're American. So we need to embrace ourselves. We've come a long way, and let's do the thing that we can do to be able to participate more rather than continually isolating ourselves. I mean, it's acting like a spoiled child wanting attention. We need to do the things we need to do. We need to do to be able to participate more. And we need to find out more data about what's going on in the Southeast, because that's where I think the majority of Black people are. And I think we need to have data to be able to do those things. Anyway, thank you all very much. Are there any other questions?
Okay. Well, thank you, everybody. Thanks, Dr. Jordan.
Thank you. Have a good day.
Bye.
Hello, can anyone hear me?
Yes,
Hello?
Dr. Justin, we can hear you.
Oh, yes, it's Solomon.
Yes.
Oh, okay. Just wanted to know if we were going to have some licenses start earlier. There's another section coming on.
No, yes, you guys can begin.
HIV. Okay, well, let me make sure that I get do a little housekeeping. Can everybody else come on for a second? Hakeem and Alonze.
Yeah, I think I was going to go first, then Hakeem will go second.
It doesn't matter. I'm just saying that now it's not quite 4 o'clock, so I don't want to necessarily penalize people who think the session's starting at a certain time too much. Trying to be a little bit mindful of that. But what we could potentially do is we could potentially just go ahead and, I can do the introductions a little bit earlier. So if we all can agree on a time, we can still stay on the same timeline. I was going to ask Solomon, are there any housekeeping issues as far as AV is concerned that we need to be concerned about now before we move on?
Not at all.
If you're still there, Solomon.
Hey,
Everything seems to be
Solomon.
moving smoothly.
Yes, I'm here.
Is it too late? I updated my slides a little, but the slides are sort of hiding from me. Is it too late for me to give you a final version?
No, you can just send me the final version, but if you can present yourself, that's fine. Yeah, just send me the final version of what you have.
Actually, let me email it to you right now. Let me just make it and save it.
So are we presenting from our desktop, or Solomon is running it?
No, you guys can run your show. I don't have to if you guys can. Only if you guys have any difficulty, then I can do it.
No, I can run my show, Solomon.
Okay.
I have a lot of slides that way. I can also pace myself if need be. Let me see, how's my lighting? Because
you guys' cameras are now on.
Yeah, I know. How's my lighting right now? Is it enough, too much, too little?
I think it's good.
Wait,
Okay.
first of all, are we live or not?
Yes, we are. Just be mindful of that.
Yep. Yeah, we're ready.
All right. Let me get on.
All right. So I got by my clock, it's 4 on the nose right now. So what I was going to suggest was that I'm going to just go ahead and really start to talk about both speakers. And then that way, we want to add a little bit more extra in as we get closer to the time we can. But that way, pretty much the introductions are kind of be, mostly out of the way, and any housekeeping items we have come up as well. So if that's okay, we can probably do that if that works out for everybody. Let's do that. Let me bring my picture back up here. Okay. All right. Well, for those who may be on the line now wondering about cardiology, it looks like just to kind of give everybody a quick introduction, I'm Dr. Wallace Johnson, University of Maryland, assistant professor there in the hypertension section. I'm also the medical director for the Aortic Center, where we do hypertension consultations for the surgical group who specializes in the repair and management of various aortic diseases. Also am the NMA co-chair along with Hakeem, although we're happy to say with Dr. Hakeem Allende, we're moving on into the next phase of his NMA involvement, meaning now he's following in the footsteps of our now chair, Dr. Marie Blum. Certainly Dr. Hakeem Allende will be moving into that role. So Dr. Alonze, whether he knew it or not, was also stepping up to Hakeem's role in that position as well. But again, just in case to orient everybody, again, just want to let everybody know this is the CDC essential factors for promoting the increase in the Black community of COVID vaccine uptake. And of course, we're talking about things that relate to cardiology at this moment in time. Quick housekeeping points. Please have your microphones to mute so that we will not hear. We love to meet your family, but we may not want to meet them right in the middle of a didactic lecture. So we want to make sure that everybody will mute their, I should say, microphones for the screen. We also want to remind everybody too that we are going to do the format's basically going to do, of course, I'm going to get ready to start the introduction. We're going to do a pre-test, and then of course the lecture, and then a post-test. And then at the end, when we do the post-test, which will actually be after both lectures, we're going to make sure that we also leave some time for questions and answers as well, just to let everybody know where we are in terms of orienting people what our format will be for today. But in terms of that, what I'm going to do now is begin to start the introductions of our illustrious faculty. For those of you who have not heard the cardiology section take on any topics or items before, you're in for a real treat today. So we're very happy to see that their speakers are very well prepared. I've been working with them for a while, and you will not be disappointed in no shape, fashion, or form. And I also want to give thanks and homage to all the previous speakers who gave us a nice background to get things started, to make our lives a lot easier during this program at this particular point. So I'm going to start out with introducing our first speaker, Dr. Alonze. Dr. Alonze is an assistant professor of medicine at the division, I should say, of cardiovascular medicine now at Indiana University School of Medicine, the same institution as somebody else I'm sure you've all heard about in passing by the name of Dr. Virginia Kane, who made a lot of this possible. Want to make sure we give homage out to her as well. He happens to be board certified in advanced heart failure and is a heart transplant cardiologist as well. He completed the medical school at the University of Nigeria, moved to the United States and completed an internal medicine residency at the Rochester Regional Health Center. He went on to complete his first advanced heart failure fellowship at the Wake Forest University, did a general cardiology fellowship at Virginia Tech, and also did a second, if you will, further training in advanced heart failure, transplant, and pulmonary vascular disease fellowship at the University of Alabama in Birmingham. He has a strong interest in reduction disparities in heart failure and disparities in heart transplant evaluation. He also serves on as committee member for the heart failure and heart transplant section for the American College of Cardiology. And of course, you couldn't have a good, strong heart unless you have a good, strong family. So Dr. Alonze, not surprisingly, likes to spend a lot of time with his wife and 2 children. They enjoy traveling to new destinations. They like playing board games, and they like interacting with the community. So the take-home message for today is not only just to worry about what type of medication you may be on, but make sure you keep your heart intact by keeping your family intact and having a good, strong family structure to provide support and to keep you having a warm heart as well as a healthy heart. So with that, we're going to get ready to move on to the first part of our agenda, and that's going to be talking about the risk of myocarditis with COVID-19 infection and the COVID vaccines, debunking some of the myths. Again, for those who just as a reminder, again, I'm going to be the moderator for these sessions. I'm Dr. Wallace Johnson, again, from University of Maryland. And with that, we're going to get ready to get started with Dr. Alonze. And I think if I remember correctly, we're going to start out with the pre-test first and then move into everything from there, unless Dr. Alonze has anything else we need to know about right before starting. But without further ado, Dr. Alonze will speak on, again, risk of myocarditis with COVID-19 infection and COVID vaccines. We want to, again, debunk the myths. Thank you.
Yeah. Solomon, can we get the pre-test up, please? So I think we'll give 2 minutes, maybe 45 seconds for the pre-test. And the question says, when considering the risk of myocarditis from COVID-19 and COVID-19 vaccination, which of the following statements is correct? More than one option may be correct. Higher rates of myocarditis are seen with COVID-19 infection than COVID-19 vaccination. The relative risk of myocarditis is about 7 times higher in the infection group than the vaccination group. The risk of heart complications is lower after COVID-19 infection than after mRNA vaccination. And the option B is COVID-19 vaccination is the best way to protect against COVID-19. That's question 1. Question 2, which of the following cardiac complications are commonly seen following COVID-19 infection and should be a reason to consider vaccination? A, myocarditis, B, pericarditis, C, heart failure, D, hypertension. So give about 30 more seconds, and then we'll start the presentation.
And fortunately, we're starting a little bit early in terms of time, so people don't have to feel rushed. It won't have to feel like a board exam. So everybody think carefully about your answers.
Okay, I'll make it a full minute, Dr. Johnson. In the spirit of having more time, I'll make it a full minute to make sure we get all the answers from my illustrious audience.
Mm-hmm. Okay, we'll get about another 4-8 according to my time. We'll give it to around just a full 9 or so.
Okay,
and
so
we'll flip over.
Another 45 seconds then, just to make sure we get everyone engaged.
Again, no pressure. Okay, we assume everybody's keyed in their answers at this point, and we can kind of move on from there.
Okay, let me share my screen. I believe everyone should be able to see my screen by now.
Yes, I can see it well.
You can see it well, okay. All right. So I want to start by thanking the NMA for this kind invitation to talk about this topic, which we have worried about a lot and actually researched a lot about, and we also keep having this conversation with our patients. So brief outline, we'll start with talking about COVID-19 and disparities, and then we'll spend the bulk of the conversation on COVID-19 and COVID-19 mRNA vaccine myocarditis, diagnostic modalities, and touch a little about the treatment. So we've already gone through these 2 questions. A third question, which I hope that being the last section, COVID-19 vaccines are safe and COVID-19 mRNA myocarditis is a benign condition and should not be a deterrent in considering the mRNA vaccine. I hope that everyone on this call would answer true to this question. So as has been talked about by a lot of people, and I probably will not spend too much time, the coronavirus is a large family of viruses that cause illnesses in animals and humans. And reminding all of us that COVID is not the first rodeo. We've had the common cold, the SARS virus, and the Middle East respiratory syndrome, and now COVID-19. I gave a similar presentation, and I just left this about a year ago for the NMA. At that time, we had about 73.1 million cases and 876,000 deaths in the US. We all know that those numbers are exponentially higher today than at that time. So just a little bit of history identified in Wuhan, initially thought to be caused by at a seafood market, but later now we know a lot better about how COVID is spread. 3 main ways COVID can be spread: breathing in the air when close to an infected person, small droplets, and touching the eyes and nose with hands that have the viruses on them. So now we know what COVID does, and we know that circumstances can increase the risk. So we know that poor ventilation, prolonged exposure to someone who might be infected, close contact, and activities that lead to exposure to a greater number of respiratory fluids. And in summary, these are all factors that are worsened by adverse social determinants of health. So talking about the weekly trends, and I love that many people have said this before me, but I feel like I just need to say, a lot of people associate COVID-19 pandemic with 2019. But if you look at these spikes, you can see that, we've had a lot of spikes. Granted that we don't have those, due to the presence of vaccines and some sort of immunity, we do not have the mortality that was seen earlier. But COVID-19, if you're looking at the weekly trend from the CDC, is still here with us. So looking at trends, going to back to the same, so this is of August 30th, 2022, about 94 million cases. We can see there's been a change in flavor in sort of the Alpha, Delta, and Omicron, different names, same disease. Everyone on this call realizes that even though the biology and the physiology of the disease is the same, that not all groups are affected equally. And we saw this early on in the pandemic. So Clyde Yancey, who, I'm sure most people on the call know, we caught this on very early in the pandemic, and writing in JAMA Cardiology, we know that health disparities occur when there's disproportionate difference attributable to variables other than access to care. We do know that there's a higher prevalence of cardiovascular disease, hypertension, diabetes, obesity in persons of African ancestry. And it became clear to all of us that COVID-19 was a pandemic of inequality. Yes, COVID-19 was present, but some groups were dying faster than others with much higher infection rates. At that time, the infection rate in some Black communities was more than, and the death rate was more than threefold that in predominantly white communities. And in some areas, as high as sixfold higher. And these became really concerning. So looking at sort of the age-adjusted rates of COVID-19 hospitalizations among persons of all ages by race and ethnicity, you can see that American Indian and Alaskan natives and Black populations bear a disproportionate burden across the different time frames from March of 2020 to August of 2022, represented in these slides from the CDC. Look at the mortality rates. You can also see, again, American Indian is in light blue and Black is in dark blue. Looking at, a lot of, at least from March of 2020, sort of accounts for these spikes in mortality. Even though there's recent evidence of less evidence of disparities, we know that this could be caused by a lot of things, but the predominant picture which we have seen, even prior to the COVID pandemic, for a lot of us in the space, persists, and it will take more than just a graph to make us know that it's going to go away. So honing in on COVID-19 and the cardiovascular system, I want to talk about, most of the time people talk about COVID-19 vaccine and myocarditis. I want to remind the audience that we knew from 2020 that COVID-19, by virtue of the direct myocardial toxicity and the systemic inflammatory syndrome, had a lot of effects on the cardiovascular system. We knew that there was a susceptibility from having underlying hypertension, coronary disease, and diabetes that led persons to have worse severity. We knew that, even without acute heart attacks, that there was evidence of acute cardiac injury by higher troponin levels. We knew about myocarditis from COVID-19. We knew about some cases of thromboembolism and acute coronary syndrome, and in some cases, arrhythmias from COVID-19. Initially, there was concern about the efficacy of ACE inhibitors, given the propensity of COVID-19 to affect the ACE2 receptors. We now know that that is not a thing, really. We also know that there was a potential of COVID-19 drugs to have sort of cardiovascular side effects. And something else I would mention now, which is emerging, is the role of some COVID-19 therapies to interact with some medications which we use commonly. So COVID and the heart is a thing prior to the vaccine coming. So we looked in 2021, our group wanted to understand what the clinical variants of myocardial involvement in COVID patients. This was before the vaccine, was when we did this. And we found, similar to what was in the prior slide, that myocardial injury is common in COVID patients. We also found that this was mainly in middle-aged persons, predominantly male. Some patients had low ejection fraction, some had myocarditis, some had pericarditis, some had pericardial effusion, and some had a low ejection fraction that resolved soon. So we knew this. We knew that COVID-19 was not benign. You can see here, we found that the mortality appears to be as high as a quarter of the patients, and some patients also developed cardiogenic shock. Shortly after this, the vaccine was approved. So we had early evidence that there were some myocarditis with the vaccine. The early reports was from Marshall et al. And in the US military. They found 7 healthy males, all teenagers, within 4 days of the second dose of the vaccine, and all abnormal troponin ECG. They were treated with NSAIDs, but nobody died. All were discharged home. We had Rosner, 5 males, again, within 7 days of first dose, all abnormal troponin, ECG findings, treated with NSAIDs or colchicine, all discharged home after 2 to 4 days, median 3 days, all lived. Okay. So more reports came. Larson et al., 8 males, within 4 in the US, 4 in Italy, within 4 days of the vaccine, all discharged home. Then the largest series was from Israel, which sort of led the world in vaccine rollouts in 5.4 million, about 27 cases out of 5.4 million first doses, and then 121 cases out of 5 million second doses. Again, mainly men, most were in the hospital up to 4 days. 95% of cases were mild. So we saw this coming out, and then we looked again. So we found that a lot of the data was either from Europe or from Israel or from America. And we looked, we did a search in 2021. We looked at all the cases of COVID-19 myocarditis that were published in the literature for the year 2021. We found that heart failure guideline therapy was common. Again, 11 patients, very low number, very low mortality. Only 1.7% of patients died. 3 patients had endomyocardial biopsy. Most cases were mild. We found something interesting, which was females presented at older ages than men, and their duration from vaccination to symptoms was longer. This raised the question of whether this was really vaccine-related myocarditis, or whether this is traditional myocarditis, and I'll get into that later. Of course, like was seen, cardiogenic shock needing mechanical circulatory support and mortality was low. More recently, I found this study that was published late last year, which was a meta-analysis and a systematic review of myocarditis in COVID-19 infection versus COVID-19 vaccination. Because this is, I believe, is the central theme. This is the central question. There is a risk of myocarditis, but which is worse? So this was an electronic database of randomized controlled trials and observational cohort registries, really asking the question, what is the risk of myocarditis with the mRNA vaccine versus COVID infection? So this was about 2.5 million patients in the infection cohort. Median age was 49. And of the patients with myocarditis in both in the vaccination and COVID-19 cohort, about 1% were hospitalized and 0.015% died. But look at this highlighted. The relative risk for myocarditis was more than 7 times higher in the COVID-19 infection group than in the vaccination group. Okay, with a relative risk of 95% confidence interval of 1.4 to 2.65 and relative risk of 15. Now, so the conclusion was that these findings support the continued use of mRNA vaccines among all eligible persons per CDC and WHO recommendations. So we went further. Another trial came out by Block et al., which was another Picorinet EHR data from about 40 US health systems, basically calculating the incidence of myopericarditis in patients aged greater than 5 with SARS-CoV-2 infection stratified by sex and age group. And again, this found that the incidence of cardiac outcomes after mRNA COVID-19 vaccination was highest for males aged 12 to 17 after the second dose. But again, patients with COVID-19 infection had about a 6 times higher risk for adverse cardiac outcomes than patients who received the second dose. So again, these I believe are the largest that we have with the highest number of patients that show that the risk of the COVID-19 infection is much higher than that of mRNA COVID-19 vaccination. So is it myocarditis? Is it pericarditis? Is it myopericarditis? So just, myocardium is the main heart muscle. We believe it's mainly a mixture of myopericarditis because in many of those cases, we use MRI to make the diagnosis. But then the question means, is there a difference between COVID-19 myocarditis versus that from COVID-19 vaccination versus traditional myocarditis? Because we know that even before COVID-19 and COVID-19 vaccine, we knew that we had myocarditis. And these were the reasons that would commonly cause myocarditis before COVID-19 and the vaccine. Viral agents, parasitic agents, bacterial, fungal, protozoal agents, toxins, hypersensitivity, and immunologic syndromes. So COVID-19, so what is the pathophysiology? So whenever there's more than one proposed mechanism, that means that the exact mechanism is unclear. So there's a theory of direct myocardial damage by viral proteases. There's also another theory of innate immune response. Then there's a cytokine release syndrome, but these are all to work together. So in your practice, what makes you think of myopericarditis or myocarditis? Classic symptoms, chest pain, elevated troponin, and MRI if it's feasible. So these are operable, confirmed. You normally need troponin, and also you need MRI findings. So we talked a lot about myocarditis, and I think it's important for us to realize that there is a difference between myocarditis in children and myocarditis in adults. So in children and teenagers, it's relatively rare. It's not a very common disease. And we know that it's mainly males, and median length of stay is probably about 6.1 days. So this is a review paper from Vasudeva et al. You can see that myocarditis hospitalization sort of peaks. I mean, this at 0, always at birth, but most of the cases are from sort of 12 to 18. Looking at in adults, we can see that it is not really a disease of older persons. You can see that from peak at age 20, 15 to 20, there's this drastic reduction in myocarditis, and there's a significant male to female predominance. And this we have seen in most of the data that we have evaluated, that males have a lot more myocarditis than females. And when females have myocarditis, it tends to be more severe. So in your practice, history, physical exam, ECG, echo, MRI, if it's available, and endomyocardial biopsy, I'll get into, something we really advocate. It's really rarely done. So cardiac MRI, we sort of use the Lake-Lewis criteria, which requires basically 2 criteria: myocardial edema on T2 imaging, and then also abnormal late gadolinium enhancement, abnormal T1 extracellular volume. So this is basically a clinical diagnosis, which if you suspect, you don't need, MRI would be helpful, but I would hope that most clinicians would feel comfortable making this diagnosis even in an MRI. An MRI will basically confirm the diagnosis. We do not recommend endomyocardial biopsy in making this diagnosis because it's invasive, causes tricuspid regurgitation, and it has a very low sensitivity sampling error caused by patchy myocardial involvement and high interobserver variability. It's very specific if you get it. You can use it in cases of fulminant, where it's very fulminant and patients are really decompensating rapidly. In our data, and that is mostly published data, it's mainly a lymphocytic viral myocarditis, and few cases see the COVID-19 genome, but most cases do not. So, timing from mRNA vaccination to symptoms. This was a study that came out in JAMA last year, which is comparing sort of the 2 traditionally commercially available vaccines, seeing that most cases occur within 0 to 4 days, and also for the mRNA between 0 to 5 days. So this is when most of the cases would be, and you should probably feel comfortable making this diagnosis even without further testing. So of course, supporting the prior data, query was the query of the vaccine adverse event reporting system, and showed that, of course, like we kind of saw from other series, 12 to sort of 18 was the peak, and then the age at onset sort of leveled off. And then was also a little sort of older age for the mRNA 1273 vaccine. So just a little bit of a difference between COVID-19 vaccine myocarditis and traditional is that they both have a male greater than female predominance. That secondary to the vaccine normally comes within days of COVID-19 vaccination. But for COVID-19 or regular viral myocarditis, that may be maybe months after the viral illness. And COVID-19 vaccine myocarditis resolves fastest, typically in days, and even without intervention. Traditional myocarditis, it can be slower. Clinical hemodynamic instability is a lot higher in in regular myocarditis that is not from COVID-19 vaccination. So you can see here that myocarditis that is not from the vaccine can be, which may be from COVID-19, can be symptomatic, and some patients may need heart transplants or even die from that myocarditis, which is pretty serious. So this is sort of going through everything we sort of have talked about. The one thing I just wanted to, CDC has active follow-up surveillance in adolescents and young adults, following the health and functional and other outcomes within 3 to 6 months. So this is something that is ongoing. I'm not just saying take the vaccine because it's safe, but there's also an active surveillance program which will detect any adverse event, any more adverse event if it occurs before it even happens. So the American Heart Association, American College of Cardiology, no competitive sport for 3 to 6 months, and they recommend normal ECG, ambulatory rhythm monitor, and exercise test prior to sports, and also to sort of hold off a little bit on further doses of mRNA vaccines until that has sort of improved. So treatment, basically supportive care, exercise restriction while the heart recovers. The role of anti-inflammatory medicines remains unclear. Role of COVID-19 therapies is unclear for myocarditis because it normally helps. And then directed care for arrhythmias, decreased heart function, or congestive heart failure. Again, severe cases are rare. You may have need for mechanical circulatory support, like maybe balloon pump or impeller, but this is mainly for traditional myocarditis and this is rarely, if ever, seen for mRNA vaccine myocarditis. So just to talk a little about something that may or may not be seen in your practice, which is COVID-19 infection in heart transplant recipients. So we did a review of this. We looked in 2021. So we looked at all the cases and case reports and case series of patients, heart transplant recipients infected with COVID-19, 9 countries, 74 patients. We saw there was a similar clinical presentation as the general population, but mortality was almost 1 in 5, about 20% mortality. Also, in our series, holding of the anti-metabolite like the Celcept or Myfortic was the commonest immunosuppression strategy used. So still keeping in the heart transplant space and medications, I want to really talk about Paxlovid, which we all know is used, approved for early disease. There is a significant interaction with tacrolimus, which I believe that everyone on this call should be aware of. So we all learned about the cytochrome P450 inhibition. So Paxlovid is a potent inhibitor of this system. And you can see in this case, this was a case report. Normally we want tacrolimus levels of about 6 to 8 post-transplant. You can see that starting Paxlovid, this went as high as 30. And this was without an increase in tacrolimus dose. So the cytochrome P450 inhibition is so severe that this is something that everyone should be aware of. And tacrolimus may be for heart transplant, maybe for kidney transplant, maybe for a lung transplant. But if you take care of any patients with solid organs who may be on tacrolimus, this is a side effect you want to be out. This is a drug-drug interaction you want to be aware of before you start patients on Paxlovid. In this patient, consider the serum creatinine trajectory also got elevated. There's another patient who had a heart transplant. Again, you can see here, again, remember we want the tacrolimus target range to be about 8, right? 8, 6, 8. Patient started Paxlovid, nirmatrelvir, ritonavir, and you can see that the level went from about 8 to 50 and 60. So tacrolimus toxicity, as you all may remember, is a significant problem, causes a lot of neurologic syndrome like the posterior encephalopathy syndrome, hypertensive crisis, and is something that we should be very careful about. So this is one of the most dramatic cytochrome P450 interactions I have seen in a long time, and I wanted to include these for all of us to be aware of, in our clinical practice. So the key takeaway is that when you're starting a patient on Paxlovid, consider holding the calcineurin inhibitors, which may be commonly tacrolimus or cyclosporine, or the mTOR inhibitors, which are like sirolimus or everolimus, when they're receiving Paxlovid, and also for 2 to 3 days after, and also to check tacrolimus or cyclosporine levels a little more frequently after you start them on Paxlovid. And I think the key takeaway, which is what we do in our practice, is that we just consider alternative therapies, or we kind of drastically lower the dose of the tacrolimus, but this is something I believe everyone should sort of be aware of. So sort of closing it out, so I think the key question, this is a sort of, should we or should we not? So what is the risk of myocarditis with COVID-19 vaccination? And what is the risk of COVID-19, right? We know that with COVID-19, there's a lot of hospitalizations, ICU admissions, and death in all age groups, which is, we know it's more common in the elderly population, but the younger ones, male and female, are not spared. We know that with myocarditis and COVID-19 vaccination, it's more predictable. We know who it affects, mainly males more than females. We know that the cause is clinically benign, and we know that a lot of cases resolve with or without significant intervention. So I would say that personally, I believe that the risks of COVID-19 infection far outweigh the risk of myocarditis from COVID-19 vaccination, which has been touted as a reason not to, by a lot of persons not to proceed with the vaccine. So I believe I have my summary, which is just that myocarditis is rare, but again, it is not a new disease. We've always had myocarditis. When it's due to COVID-19. Oh. Can you hear me? Hello?
Yes.
Okay, sorry, it echoed a little. Okay, so myocarditis is rare, but it's not a new disease, commonly in males less than 30 years old, when it's due to the vaccine within a few days after the second dose. The risk of myocarditis is more than 7 times higher after COVID-19 infection than from COVID-19 mRNA vaccination. When it's due to COVID-19 vaccine, treatment is largely supportive. Myocarditis after mRNA vaccine, the early data outcomes have been good. We don't have long-term data yet, but we have taken the vaccine personally. Our families are all vaccinated. I encourage everyone listening on this call, on this webinar, who may be on the fence to strongly consider vaccination, as the risks of myocarditis are really not something that we worry about strongly. With that, I'd like to conclude and thank you once again for the kind invitation to present.
Thank you, Dr. Alonso. So what we're going to do, just to kind of remind everybody of our format again, we're going to do the post-test for both speakers, as well as the Q&A at the end, conclusion of Dr. Allende's presentation. So I'm now going to introduce our next speaker, Dr. Akeem Allende, who really needs no introduction. He's now beginning more and more involved in the National Medical Association, we're all proud to say. And today he's going to speak in reference to the cardiovascular burden of COVID-19 infection. But I'm just going to tell you a little bit about him prior to us starting to do that. Wanted to let you know that Dr. Allende, on a personal note, I met him at a conference many moons ago, and at that time you were still at Howard University and still just a young and fledgling soon-to-be cardiologist at that point. But now I'm pleased to announce him as a board-certified cardiac electrophysiologist. in cardiology down in Fredericksburg, and also an adjunct clinical assistant professor of the University of North Carolina in Chapel Hill. Now, Dr. Yende, of course, as you can tell by his involvement with this program, has a strong interest in medical education, mentoring, reducing healthcare disparities, and increasing access to healthcare among minority populations. Also serving as now the vice chair of internal medicine of the National Medical Association, as well as the co-chair of cardiology subsection for the NMA. Dr. Allende serves on the membership committee of the Heart and Rhythm Society and is also a member of the Cardiac Electrophysiology Committee of the Association of Black Cardiologists. He mentors many young minority physicians throughout the Association of Black Cardiologists, and he has a research focus on atrial fibrillation, cardiac implantable electronic devices, and some of his research interests more specifically include atrial fibrillation in athletes, device detection of atrial fibrillation, and outcomes of atrial fibrillation ablation. So, and I also know that he didn't put it down on his resume, but I should say I know that Dr. Yende is a dad as well. So we'll also say another one with a warm heart for the little ones in the household as well. So without further ado, to talk about the cardiovascular burden of COVID-19 infection, what he's gonna, I know, start out with a pretest, I'd like to introduce Dr. Akima Yende to the audience. Thank you.
Thank you, Dr. Johnson, for the warm introduction. And I welcome everybody to this NMA symposium. Thank CDC for helping support this and bring in education on COVID vaccination to light. It's important that we increase the uptake of COVID vaccination amongst the high-risk populations, and we're here to discuss why, and hopefully the takeaway from this program that's everybody goes back home and we tell our friends, our family, our patients about why COVID vaccination is very important and safe. Today, I'll be talking about the cardiovascular burden of COVID-19 infection. I'm going to share my screen. So my topic today is cardiovascular burden of COVID-19 infection. I have no disclosures. Now, what are the numbers today? There have been over 1 million deaths reported in the United States, although we know it's much higher because there are some that were not reported. We have about 600 daily deaths from COVID. 72% of Americans are fully vaccinated, meaning we have 28% that are not. Now, we're not counting the booster. We know that the vaccine wanes. The effect of the efficacy of the vaccine wanes over time, and hence the need for booster doses. There's about 1.5 million daily COVID infections, people that live with COVID infection currently, and we've seen seasonal changes in COVID infection. Now, there've been a lot of reports since COVID started in 2019 to early 2020. What we understand, so we quickly understood what COVID could do in the acute situations. We learned that COVID could cause myocardial injury and myocarditis, acute myocardial infarction, heart failure and cardiomyopathy, arrhythmias, especially atrial fibrillation, bradycardias, shock, cardiac arrests, pulmonary embolism. And we learned that there were some people that were specifically at risk for these conditions, especially the elderly, people with comorbidities like underlying cardiovascular disease such as hypertension, chronic lung disease, diabetes, people that had systemic inflammatory disease, people with immune dysfunction, and coagulation disorders. Now, as time has passed, we are beginning to realize, okay, what do we know? Because we're entering the 4th year, because I think the first COVID started late 2019. This is 2023. This is now a chronic condition that we have to look back and discuss, the chronic conditions associated with COVID. Some questions arise. People ask questions such as, is my long-term risk of cardiovascular disease increased if I catch COVID-19? Does the severity of COVID-19 infection predict the risk of long-term cardiovascular disease? If I develop myocarditis from COVID-19 infection or from COVID vaccination, are the outcomes any different? I hope today we will be able to answer some of these questions at the end of my presentation. We've gone through these pretest questions at the beginning, but if you're just joining us, you're free to answer this quickly. First question, so there are going to be 2 pretest questions from this presentation. First question, there has been a major uptick of cardiovascular deaths in the United States during COVID pandemic. True or false? I'll give you 5 seconds for that one. Second question, the following are likely reasons for the increased COVID-related mortality seen in African Americans, except, so this is all but 1 are true. First, delay in or poor access to healthcare, relatively high burden of comorbidities, genetic susceptibility to COVID infection, and D, job hazards such as being an essential worker. So one of these is not a likely reason for increased COVID-related mortality seen in African Americans. Only 1 answer is correct. Okay, we will move on now. This slide was presented at the last symposium of the American Heart Association in 2022, and it is quite striking. We've seen a decline in cardiovascular disease since 2010 due to improvement in healthcare, increase in the number of people that are insured, improvement in medications and procedural outcomes, and better prevention. So we've seen a decline in cardiovascular death from 2010 to 2019. And something interesting happened in 2020. If you look at the slides, you see it goes from 2010 all the way to 2020. And if you stratify them by, age, ethnicity, gender, it appeared that pretty much most groups had a decline in cardiovascular deaths. But in 2020, every group suffered a reversal. Cardiovascular death increased by about 4% in total, and it took us back 5 years. And when you look at the non-Hispanic Blacks specifically, that's the group that suffered the worst. You can see the green line, second line all the way almost at the top. And Blacks actually suffered a 10-year reversal in the gains. Black Americans had a 10-year reversal in gains that we have sustained over the last 10 years, just in 1 year. The other thing we saw was it appears that younger people, 55 to 74, had deaths that were actually now higher than the 2010 rates. So overall, 2010 was a very bad year in terms of cardiovascular death. And it brings to question, how? Was COVID that bad? Is COVID that bad? How did COVID do this? Well, we could suppose you all remember in 2020 when we were all sitting at home, we had we had elective procedures canceled. We had, physician offices were closed. A lot of people couldn't get screening. You couldn't get in to see a doctor. You couldn't get into the hospital because the hospitals were swamped with COVID. So when you look at people so this is a survey that from the US Census Bureau that looked at people between May 2020 and May 2021. And it shows this is the percentage of people that had either delayed healthcare or did not get healthcare. And it was as high as almost 50% at the peak of the shutdown in May to July. It got better through 2021, but it was still, even when it fell to its lowest, it was still about 20%. So a significant proportion of the population either did not get healthcare or had delayed healthcare, which, we were talking about people who are high risk, people with coronary artery disease, heart failure, obesity, diabetes, things that need continued care. They couldn't get their care. So this definitely contributed to cardiovascular mortality. And the question is that it? Is that the whole story, or is there more to it? Does COVID actually have a direct effect on the heart? Let's find out, because there's always two sides to a story. This publication is a very important publication. It was published in 2022 in Nature Medicine, and what this team did was they looked at the people that used the VA healthcare system. We're talking about millions of people, so it's big data. They had 6 million people who used the VA in 2019, and then, this 6 million people had COVID sometime between March 2020 and January 2021. They took another 6 million people matched who during the same time did not have COVID. So now we're going to compare 6 million people who had COVID at some point with 6 million people who did not have COVID. And also to correct for certain confounders, they also compared to people, 6 million people in 2017, just so we're clear. And what did we find? So they looked at cardiovascular outcomes in these patients. And here's what they found. So after following these people for the median follow-up was about a year, it was 347 days. You can see that, so from the top down, strokes or cerebrovascular diseases like stroke and TIA, abnormal rhythm like atrial fibrillation, sinus tachycardia, bradycardia, ventricular arrhythmias, inflammatory heart disease like pericarditis, myocarditis, ischemic heart disease like acute coronary syndrome, myocardial infarction, ischemic cardiomyopathy, other cardiac disorders. Every single thing we could think about was worse in the group that had COVID infection. At least 2 times or more risk of stroke, atrial fibrillation, myocarditis, everything, every single cardiac condition you can think about was more likely to have occurred in patients that had a COVID infection versus those that did not have a COVID infection. And they then stratified the population. Like, let's look at age. Does age matter? Was it that, elderly people had the problem, but the younger people did not? Was there any ethnicity that had a higher risk of these conditions? Was gender, obesity, smoking, hypertension, diabetes, kidney disease, were there any factors that would make you more susceptible to these complications if you had COVID infection? And here's what they found: nothing. It did not matter what your age was, what your race, your gender, your smoking habits, hypertension, nothing. If you had COVID infection, you were at a higher risk of suffering any of these cardiovascular complications. This is very interesting. Now, does the severity of COVID illness matter? Meaning, if you had a mild COVID infection, you were home, you go to work in 2 days, 3 days, versus you were hospitalized for a few days, versus you actually ended up in the ICU. Does it matter? And yes, it does. People that ended up in the ICU were at a higher risk of all these factors: strokes, abnormal heart rhythms, myocarditis, pericarditis, atherosclerotic heart disease, blood clots, everything. So, this is actually a linear relationship, meaning the people that were in ICU were more likely to suffer these problems, followed by the people that ended up in the hospital, and the least likely were those that had COVID but did not end up in the hospital. Now we can ask, a lot of studies have discussed how the pathophysiology of COVID-19 in cardiovascular disease, and pretty much it centers around 4 factors. So you have cytokine release, like your interleukins and tumor necrosis factor. This drives inflammation. You have a dysregulation of your renin-angiotensin aldosterone system. You have plaque destabilization and rupture with increased inflammation, microthrombi forming, and you also have a procoagulable state. So a combination of these factors leads to different expressions of cardiovascular disease in all the organs. Now let's shift gears a little bit and talk about race, ethnicity, and mortality that we've seen with COVID. So this here shows data on mortality back in, this was August of 2022. So how does mortality compare between the different ethnicities in the United States? And we can see that Blacks, Hispanics, American Indians or Alaskan Natives, and the Native Hawaiian or Pacific Islanders had a much higher risk of mortality compared to whites and Asians. What is common to these 4 groups? Ethnic minorities. This appears to be, well, let me ask this question before I answer it. Why is there a disproportionate death rate among African Americans and other ethnic minorities? That was the second question in the pretest. I mean, is it, are we more susceptible? Is it, what brings it together? Well, we know the answer. They're all social determinants of health. We know that when COVID came, COVID became like, it just widened the disparity gap. It separated the rich and the poor. It separated people, the people who could work from home and order Instacart versus the people who had to commute to the nearest grocery store and buy their groceries, or who had to go to work because they were not gonna get paid or have any way to feed their family, even when they was shut down. When we talk about these social determinants of health, you can see that specifically, let's talk about how this leads to the increased mortality, the increased burden of cardiovascular disease, the increased death from just pretty much not only cardiovascular disease, but if you look at even maternal mortality, look, whatever you choose to look at, why? You look at high unemployment rates, this is, a lot of it is just economic. You have a group of people who have much higher unemployment or underemployment rates than the majority of the population. People who are more likely to be essential workers, one in 6 essential workers are African Americans. You look at people who look at Black-owned businesses. Black-owned businesses were actually, the studies showed that they were more likely to be affected by COVID because they existed more in urban areas that were more disproportionately affected by COVID. So you had a lot of people from a specific ethnic group put out of business because of COVID. You're talking about a group that has a lower household income, food insecurity, less cash reserves. When everything was shut down, people had to sit at home. Well, you don't have cash reserves to sustain you for months at home. Higher homeless rates. 40% of the homeless population in this country is African American. That was data that was scary when I saw it. We talk about high incarceration rates. Talk about reduced access to healthcare. No insurance or underinsurance. Disproportionate burden of comorbidities, hypertension. African Americans have the highest rates of hypertension and die more from hypertension. Even when African Americans have atrial fibrillation, we're more likely to have strokes and heart failure compared to other populations. Talk about a population that lives in a polluted environment. You have noise pollution, environmental pollution that contributes to poor health. All these factors contribute to worsen health in a group of people that are not genetically more susceptible to COVID, but just because of the social and economic circumstances that this group is exposed to, we end up seeing a huge gap in mortality. The other thing to look at is, it was a brilliant talk during the HIV conference before this, listening to Dr. Jordan talk about disinformation. I mean, if you look at this graph, this is the COVID-19 vaccination rates by race ethnicity between March 2021 and July 2022. You can see that which group has the lowest rates of vaccination. That's African Americans. And we've been in this conference, you've heard many reasons why. Sometimes it could be like when you look at, for example, just COVID testing, government distributed COVID tests and everything. But the thing is, when government initiates a program, you're trying to be, you have good intentions. The problem is the society is already stratified in social and economic classes that what you apply to this group may not necessarily work for what you apply to this group. So a lot of, for example, African Americans live in communities where, transportation is a problem, food insecurity is a problem. Data showed that they could not access this COVID testing like other populations could access. So that's one example. And, we could also talk about the disinformation. But the point is, we have work to do. We have a lot of work to do to change this graph and change the curve and increase, because we're talking about a population that's disproportionately dying from COVID. It's very, very important. We know that the best way to reduce COVID-19 death is preventing infection from COVID-19. And how do we do that? Vaccination and practicing the safe precautions as outlined by the CDC. Finally, Dr. Ilonze talked about COVID myocarditis before this. I just want to show this slide, the COVID vaccine myocarditis versus other types of myocarditis. We know that mRNA vaccines are associated with a higher rate of myocarditis in younger patients, especially males. Now, the CDC has surveillance. They've been conducting, so CDC has been conducting surveillance on reported, self-reported myocarditis cases, and also through physician offices, health systems, and try to gather data and follow these patients. So there was a recent publication from this surveillance. It looked at 519 confirmed cases of persons between ages 12 and 29. 95% of them improved, 81% fully recovered. There were no deaths. Compare that to children, 23%, compare that to, other viral and other acute myocarditis. When you suffer myocarditis from other causes, in children, 23% require a heart-lung machine or a heart pump. 11% require transplants or die. Among adults, 5% die within 90 days. So it's not, we should not compare the vaccine myocarditis, which there have been no deaths reported, people generally recover, to viral myocarditis. What can we do? Takeaway here will be, number one is, we should influence public policies that will reduce racial inequities and build trust, encourage policies that will actually understand the social and economic problems of each community and apply policies, and also monitor the effectiveness for each given population. Raise awareness for COVID vaccine safety, practice safe habits to reduce COVID transmission, and also reduce cardiovascular risk factors, healthy eating, exercise, routine health checks. And there goes the final pre-test questions. Yes, there's a major uptick in cardiovascular deaths in the United States during the pandemic, and African Americans and other ethnic minorities do not have an increased genetic susceptibility to COVID-19. It's all socioeconomic. Thank you.
Thank you very much, Akeem.
Over to you.
Yes, okay. So one thing I was going to say, one quick housekeeping point, the question that frequently comes up is whether or not there'll be post-conference availability for the materials. The shorter answer is there'll be, my understanding is you'll be able to find a link which will allow you to have access to, if you want to call it, the didactic lecture portion of the conference, but not necessarily for the slides contained in the conference. That would have to be done on a case-by-case basis if you have a personal relationship with the speaker or know of a way that we should speak it. So that, if I have said anything incorrect related to that, please let me know. But that was my understanding in terms of what availability would be post-conference. So with that, we'd like to go and open up the floor to questions, whether they relate to the pre-test or post-test or just Q&As in general. But I did want to handle that one housekeeping piece that came up already. And I also want to again thank everybody for their time and attention. We know you have a lot of things you could be doing on a Saturday, so we thank you for spending it with us. And if there's no questions, I'm going to quickly jump in with one. I don't see, let's see, double check again. Okay, the one question was related to what I just talked about in a minute ago. So I'm going to open up the floor to a question. I think the big issue that comes up, this can be directed to any member of any one of the speakers, is whether or not when we look at people who, for example, like myself, or whenever I get a vaccination, I automatically take 2 Tylenol. So my question is going to be, I wonder if whether or not anti-inflammatories of some type could potentially be directed towards a high-risk group, males ages 15 to 30 who take a COVID vaccination. Should they take some kind of anti-inflammatory type medication? Is there any study or anything related to that to see if it might have some kind of impact on reducing the already low, admittedly low incidence of myocarditis that we do have, or any other complication you want to think about for that matter?
Yeah, so I can take that. I think that the way I look at vaccines is if I take a vaccine and I expect a reaction. So I think the anti-inflammatories help. I don't know that it will prevent myocarditis from someone who is susceptible. But I think it's always good practice if you kind of feel like you have a susceptibility to take an NSAID. But I don't know that we have any data that because normally you take maybe 2 or 3 Tylenols, that would prevent myocarditis if that's something that may come on.
Okay. All right, great. That's what I wanted to find out about, because I know this comes up all the time. I guess the second question leading in to that is a follow-up is people sometimes ask, does prednisone have a role in myocarditis treatment?
So that's a mixed bag because we know that. So the answer is no and yes. If it's frank myocarditis, whereby you know that troponins are high, BNP is high, maybe needing circulatory support, prednisone doesn't really change anything. Actually, there's evidence of harm with that. But if you get maybe myocarditis as part of maybe a systemic inflammatory syndrome, maybe some infection or bacterial or some sort of sepsis-like syndrome, or maybe there's some sort of hypotension, maybe careful targeted use, mainly in an ICU setting, may be permitted, but routine use of prednisone or steroids is not indicated for myocarditis. It's not.
Okay, thank you.
Unless the other exception is if you were giant cell myocarditis. Because giant cell myocarditis, basically there's a lot of ventricular arrhythmias, use of a temporary mechanical circulatory support devices, and rapid, sort of like it's like a crash and burn picture. And if you confirm it with endomyocardial biopsy, you could. But for most myocarditis, it's not routinely recommended to use steroids.
Okay, thank you so much. Another question I have seen that's come up from Dr. Kane, one of your, I should say your faculty associate. How does long COVID present with heart disease versus the COVID myocarditis, i.e. say, for example, heart failure? So how does a long COVID present with heart disease versus say COVID myocarditis? If you're thinking about heart failure versus say, for example, myocarditis just in general, if I'm saying that correctly.
Dr. Inde.
So I think we should separate acute complications of COVID from long COVID. With the acute complications, usually myocarditis is an acute complication, but in some situations, it may present late. I think what happens is down the road, these people, because really the reason people suffer complications from COVID is just really immune dysregulation. You have increased activation of your RAS system, you have increased inflammation, you have a higher coagulable state. So the question is, does this state reverse to normal or does it persist? And in people that it persists, then you start to see complications. I see a lot of people, we all get these patients. A patient will swear to you that, doctor, this thing started after I had COVID. This thing started after I had COVID. And when you start seeing these publications, you have to believe it. You have to believe it. I think COVID is just, it's just the continued chronic inflammation, immune dysregulation that leads to these long-term complications.
Okay. Oh, I hope that clarifies everything. And now another question that has come up. Is there any data on COVID myocarditis, I should say the COVID myocarditis death rate in the elderly Black population as to whether or not they have a worse, health outcomes in all disease categories? So again, is there any data on COVID myocarditis death, the COVID myocarditis death rate in the elderly African-American populations as they, for example, have the worst health outcomes in all disease categories, just in general. So I think that's what the question is saying.
Yeah, so I can take that. So I think I want to start by reminding the audience that the mortality from COVID-19 mRNA vaccine myocarditis is very low. It is predominantly a disease of teenagers. Most of the papers outside of the United States do not categorize patients by race and ethnicity. So it is sort of difficult when you're passing through the literature worldwide to sort of see, who is of African ancestry or not. But I would say that based on the data we have, the rate of death for the elderly Black population from COVID-19 myocarditis will definitely be higher than whatever the rate from COVID-19 mRNA vaccine myocarditis is. I think I can say that with a lot of confidence. We don't have that data because the rates are so low and most of the cases are self-limited with minimal to no intervention. It sort of become almost standard thinking. If we were to get an elderly male, if you see a case report of an elderly male, Black or white or Hispanic with myocarditis with COVID vaccine, we would really want to look and make sure that it's really from the vaccine and not something. That is sort of how uncommon that is. So I would say that it is a very rare occurrence, and it's not something that we commonly see.
Would you say and this is just me, you can, what do you think about this? I feel that the reason people develop mRNA, this COVID myocarditis from the vaccine is just younger people have a higher immune response. And it's really that immune response.
Oh, absolutely.
Versus the older people.
Yeah, absolutely. We sort of see that, even if you talk about solid organ transplantation, sort of that is the younger females have the highest rates of what we call rejection, which is sort of due to a hyperactive immune system. So to your point, the young males also have a lot of very robust immune systems. When you get older, we have some sort of immunosenescence where the immune system sort of becomes naturally ablated and they're not able to mount as robust immune responses. If we transplant an elderly male, 50, 60, we don't really worry about rejection because the immune system already is attenuated and not that active. So that is clearly, again, we sort of hesitate to label. You're likely right that if you read a lot of our papers, we always talk about, there's possibly one or two mechanisms, but definitely sort of that innate immune response clearly has a role in COVID-19 mRNA vaccine myocarditis.
I want to highlight something you mentioned in your presentation. I think that's very relevant clinically, which is interaction with Paxlovid. So I treat a lot of patients with atrial fibrillation that need anticoagulation. And when you're on Paxlovid, it really interacts with anticoagulation. So when you take rivaroxaban, which is Xarelto, you cannot take Paxlovid with it. You have to discontinue Xarelto while you're on Paxlovid. If you take apixaban, which is Eliquis, you have to reduce the Eliquis dose by half or even discontinue it. When it's and that's because the CYP3A4 interaction, it elevates those anticoagulants. When you take Pradaxa, which is dabigatran, they say just monitor closely. It's a P-glycoprotein pathway, but it's less so than the first two. And also with warfarin, the INR can swing both ways, so you have to check INR closely. So this is very, very important. Any patient on anticoagulation has to be monitored closely and decisions have to be made when you prescribe Paxlovid.
Yeah, we have two questions in the chat. I'm going to take the one from Virginia Banks. Akim, I'll let you take the one from Michael Young. So the question is, would you advise parents to hold off on sports activities that their children are involved in after acquiring a COVID infection? I'm guessing that she's talking about children who have COVID infection, whether they should be off sports activities. I would say that, assuming that is the question, I would say that if you just have a regular, there's different grades of COVID infection. Was it a symptomatic COVID infection, or was it someone who went to the hospital for a different reason, went to the ER and tested positive for COVID? If it's a symptomatic COVID infection and it just comes and goes away, and there's no evidence of myocarditis, there's no chest pain, there's no shortness of breath, there's no fever, there's no need to visit a health facility, that I'm not sure that we have to do that. But if clearly there's even a clinical suspicion of maybe male teenager had COVID and had some shortness of breath, maybe had some chest pain, I think even in the absence of, after the vaccine, after the infection, I'll say even in the absence of any confirmatory test, it's reasonable to sort of hold off, because COVID infection in 2022 is clearly not what it was in 2019, 2020. Now a lot of people are exposed to vaccination. There's some sort of herd immunity where it's applicable. I wouldn't want to give a de facto hold up on sport activities. I would say it's more on a case-by-case basis, sort of how was the COVID infection diagnosis made and what were the symptoms. And of course, a healthcare provider would always be the best person to sort of guide that.
And the other question relates to vitamin D, which often comes up in these conversations. There's vitamin D deficiency, of course, is very pervasive in people of color. So we want to know about whether the panelists feel that the role vitamin D may play in terms of trying to get vitamin D from quote unquote subtherapeutic to therapeutic levels. In most institutions, for example, my institution, we use a vitamin D level of greater than 20. Is that something you think we should be screening for in populations at risk? And do you think raising the vitamin D level is a good idea in this population?
Yes, I would agree. It's just like I see it as vitamin D is important in calcium metabolism, and yes, it's a prohormone. The thing is not just vitamin. There's so a lot of these vitamins and minerals like magnesium, zinc. Those are things we don't really pay attention to, but they're very important, very, very important in immune regulation. Yes. It's definitely important, especially as people age, to get your vitamin D levels in normal range.
Sorry, I just realize that we didn't have an official post-test. Are we supposed to do that? We had the pre-test questions for the audience to know what the answers are.
Yeah, I was going to ask if you could go with your post-test question. I know we kind of jumped right into that, but go ahead. Mm-hmm.
Yeah.
Yes, I just relaunched it.
Okay. Solomon, do we get to see the audience responses?
Yes, once they answer, I will post the result.
Okay. I think we can maybe, I don't know how much time we have left, Dr. Johnson. Maybe you give another 30 seconds.
Yeah, it's 5:20, we have to 5:25, so we got a few minutes. Go ahead.
So I would maybe give another maybe 1 minute for the audience to, I'm sure this is our second time of reading these questions. If you want to give your answers, and then we can look at the responses, and then we can just go through the questions and the intended correct answers. Please, 1 minute.
Okay. Go through those questions quickly if you like them, Alonzo.
You want me to read them on again?
I mean, that way you think is sufficient. I just want to make sure that the audience has a chance to be sure to see the questions as you list them so we can respond. Yeah. But I mean, they can go ahead and read and start responding at any time. You're reading the questions, won't stop them from responding. So.
Sure. Yeah. So first question, when considering the risk of myocarditis from COVID-19 and vaccination, which of the following statements is correct? A, higher rates are seen with COVID infection than vaccination. B, relative risk of myocarditis is 7 times higher in the infection group than the vaccination group. C, risk of heart complications is lower after infection. B, COVID-19 vaccination is the best way to protect against COVID-19 and rare heart complications. Question 2 is commonly seen complications, myocarditis, pericarditis, heart failure, and hypertension. Question 3, major uptick in CV deaths in the US during the COVID-19 pandemic, true or false? Question 4, the following are reasons for increased COVID-related mortality seen in African Americans, except a delay, poor access to health, higher burden of comorbidities, genetic susceptibility to COVID, and job hazards. Okay, so can we see the responses, Solomon?
By the way, I expect a significant uptick in the other questions, but we already answered them. Questions 3 and 4 were already answered. So there should be an uptick in the number of right answers for that one.
Okay, yeah. So I think for the first question, I deliberately made it to multiple choice so that people will really read it. I think the intended correct answers here are A, B, and D. We know that there's higher rates of myocarditis seen with the infection than with vaccination. We know that from a presentation that the relative risk is more than 7 times higher in the COVID infection group than the vaccination group. And we know that COVID vaccination remains the best way to protect against COVID. We know that the risk of heart complications is higher after COVID-19 infection than vaccination. And then for question 2, we know that myocarditis and pericarditis are higher cardiac complications seen following infection, and is a reason to consider mRNA vaccination. So Hakeem, I'll let you talk about your questions on 3 and 4.
There's been so number 3 was there's been a major uptick in cardiovascular deaths in the US during the COVID pandemic. Yes, in fact, the cardiovascular death rate among African Americans was up 11% back to 2010 levels, a reversal of 10 years of gain. And the second, number 4 question, the following are likely reasons for the increased COVID-related mortality seen in African Americans, except here it just highlights that the main reason for disparity, just not only with COVID, but with other health conditions that African Americans appear susceptible to, is mostly socioeconomic burdens that African Americans suffer from compared to the major ethnic groups. So there's nothing genetic there.
Solomon, do we have the actual poll results?
It's showing right there the result and the answer. It's showing that the number of, I don't know what you guys see.
It just shows the correct answer. It doesn't show the percentages of who answered what.
Right.
We're not seeing that.
Oh, I guess it doesn't show it to the panelists, but it showed the percentage here.
That means 100%.
Is it 100%? So
it's not 100% really. Oh, the only one that is 100%. Yeah, it's one of them is 100%. The 4th question.
Oh, okay.
Good job.
Okay.
No, we all know that. I mean, it's so sad. We talk about this every year, and things don't change.
Yeah. Well, one thing I was going to say was that a couple of last housekeeping point was that I've been reminded by Dr. Holsey that we need to note that session evaluations are going to be sent out. So remember that even though this is not a CME per se, we still want everyone to participate in the session evaluation so we can get adequate feedback on how to do better in the future as we go forward, and understanding that there's always something we can do a little better with each program. So I want to make sure everybody was aware of that. Again, remind everybody again, links are available to have access to lectures, but not automatic access to PowerPoint slides. Some people always ask about that. 2 different distinct entities in this particular case. But PowerPoints could potentially be available if you have access to speakers on the individual level. And if questions come up, of course, we ask you direct them to the NMA, either website, and they can pick things up from there. But I think as that seems like that's pretty much it. I didn't see any further questions come in through the Q&A. So we're going to pretty much conclude and hand the program over to Dr. Ende for concluding remarks. And again, I want to thank everybody who hung in there with us. There's a lot of different things you could have been doing on a Saturday evening and afternoon.
Thank you, Dr. Johnson. So this is, the theme was the CDC essential factors for promoting the increase of Black community COVID-19 vaccine uptake. And we've had excellent speakers come today, and we thank all of them. And we've seen that, you know, there's a reduced uptake of vaccines among African Americans, and also African Americans are disproportionately dying from COVID. This is very important. And we're here, we've had excellent experts from all the subspecialties of internal medicine come here and break this down in an organ-specific way. So this is not the end. Tomorrow we continue. We have the next, tomorrow we're gonna start at 10 a.m. and we have the pulmonology subspecialty, we have rheumatology, medical oncology, allergy, asthma, and immunology, and we'll round out with the infectious disease subspecialty, all giving excellent talks tomorrow. So please join us 10 a.m. tomorrow. And yes, okay. Oh, you have it. Okay, that's good. Yeah, so please join us tomorrow. The Zoom link has been posted. Please share this with friends and the community. This is open to all members of the community. And again, I want to thank everybody that attended, that took their time out. It's a weekend, but we appreciate your attendance, definitely. And we also appreciate you sharing the words you've learned here with your family, friends, patients, and all your contacts. Thank you very much. And one more thing, this will be recorded and you will have access to the recorded sessions. So at the end of the day, you will get evaluations in the emails, but then you will get access to the recorded sessions. Thank you.
And please, I should also say on a totally different note, if some of you haven't heard already, the football player who was injured has already apparently started to show evidence of neurologic improvement. So stay posted. We need more information about that. I'm sure when we do the next NMA session, we'll be able to talk about a little bit more about what happened or what did not happen for the next session. So stay tuned.
Yes.
And again, continue to send the sessions. And we ask that everybody please fill out the session evaluations and give us your feedback. And we also ask that, everyone who's looking for the link, we can help you in facilitating getting that as well. So I thank everybody again for their time and attention.
Thank you, everybody.
All right, thanks, everybody.
Everybody have a great, great evening.
Yeah, see you tomorrow.
See you.
Bright and early.
All right.